and 2026. The age ranged from 27 years old to 42 years old. And the causes of injuries, the etiologies, and the chronicity varied across the 5 patients. And these 5 patients, the interventions were also individualized, and there are those ones who underwent decompression and stabilization. Then there was now the stem cells infiltration, and then those who underwent nerve conduit or autologous nerve graft reconstruction. Then we did a follow-up and assessed the neurological and functional changes in the postoperative period. So all these patients underwent a baseline clinical assessment and neurological characterization. They underwent imaging, and we had the operative planning. Then there was the conventional surgical management as indicated. Then we brought in the regenerative augmentation at around the injury level. Then there was the nerve conduits, and then now the post-op rehabilitation and serial clinical assessment. So the interventions were basically 3. One was decompression, the other one was stem cell, the other one was the conduit to give a structured guidance healing strategy. So the outcome, they were basically clinical and patient-centered. What the patient reported and what we were able to do clinically. So there was bladder sensation, urge awareness, reduction of pain, spasticity, and spasms. Then the timing of this improvement was recorded in weeks after surgery. So this is also, we're looking at the cohort, these 5 patients. So they fall, as you can see, the age ranged from all the way from 29 to 42 years, and the etiologies for the spinal cord injuries were heterogeneous, and all of them reported early neurological function or improvement. So this is a slide with a chart, a bar graph showing the observed early improvement, basically using a descriptive signal. As you can see on the graph, all the 5 patients reported any early clinical improvement. And this is an encouraging hypothesis generating signal, not evidence of 100% success, treatment success. It is an important hypothesis generating signal. So the correct interpretation from this slide is that all the 5 patients in this selected case series improved clinically after combined treatment. So our first patient was GK, 29 years old male, who was an electrician employed by KPLC. And the mechanism of injury, this gentleman sustained a traumatic gunshot injury following assault, which caused a spinal cord injury and a vertebral injury. This was in August 2024, and he subsequently lost blood and bowel function, and then had also a sensory level at T8. He also developed bilateral lower limbs weakness. So immediately after the trauma, he was unable to move. Then he came to the hospital where an MRI was done that showed a T8 L2 wedge compression fracture and shattered spinal cord at the same level, compressing spinal cord and corners, and the corners showing central myelomalacia. So this is the MRI of the gentleman taken from the viewer with the level of injury T8 L2. I don't know if it is clear, but the picture on the left shows now the intra-op pictures, whereby the dura is opened, and you can see there are things that look like rods on the side, circular rods on the sides. Those are the implants that were used for stabilization after the decompression. And then after the dura was opened, you can see there is a defect, about 3 centimeters defect, where the spinal cord had been shattered. And on the right, that defect, as you can see, there is a nerve graft that has been done. I don't know why it's not clear. And then this photo on the left now shows that harvesting the lateral cutaneous nerve of the forearm, the one that now we used as a nerve graft, now to bridge the gap. And then we did stem cells. You can see it on the photo now on the right. So this gentleman underwent the decompression and interpeduncular screw fixation, and then after about 4 weeks, these patient who had a chronic was a chronic paraplegic, it started regaining. Started regaining bladder sensation and urinary urge awareness, and also the severe spasms were able to were resolved within 3 weeks. Then the new autonomic sensory awareness was clinically meaningful, and a possible explanation for these findings was the improved function in surviving autonomic or sensory pathways, which was potentially aided by stem cell mediated trophic and immunomodulatory effects. So in future, maybe for such, we could do objective urodynamics and standardized sensory scoring to strengthen our evidence. I know time has gone. This was another patient with the gunshot, same injury. So this slide shows us tries to explain how stem cells work. So basically the rapid time course of these results also suggest functional modulation that may be more plausible than complete data anatomic regeneration alone. So this I'm going to skip because of time, basically explaining the mechanism of action of stem cells. We also know that spontaneous neurological recovery can occur, especially in incomplete spinal cord injury, and also natural resolution of edema can also, or inflammation can also improve conduit, and even basically decompression, it may in itself produce recovery. So all these were taken into consideration to rule out all this. So in conclusion, this 5 patient series, patients reported a positive early functional and neurological positive changes after combined surgical and regenerative management, and stem cells offer plausible mechanisms, that is trophic support, those immunomodulation, neuroprotection, angiogenesis, all that could contribute to early recovery. So thank you so much, and those are some of my sample references.
Thank you very much, Dr. Adegu. We'll proceed with Dr. Ula Aldabas's presentation on distal superficial peroneal nerve compression syndrome, an undiagnosed cause of pain and dysthesias in the lower leg and foot.
So good morning, everyone. The slides.
Sorry. Good morning, everyone.
Morning.
So from the timekeeping desk, what we'll be doing is when it goes orange, you've got like 2 minutes remaining. So when it goes orange, I'll be hitting the glass once, so that's a signal for you to know that you're about to finish. Thank you.
And we thank you very much, timekeepers. We're working to try and get things sorted out. One, we have, I think, a problem with the screen. So we're trying to get that, and then the other bit is we want to get a timer on the presentations. We want to respect everybody and everybody's time, so thank you very much. Let's try and, we started late, so we try and run so that we can catch up and finish in good time. Thank you very much.
Yeah, so good morning. This is a pretty short presentation, I hope. So I'll be talking about a distal compression syndrome of the superficial peroneal nerve, which is a pretty much underdiagnosed cause of pain and dysesthesia in the lower leg. I will not get into the anatomy too much, but it's just important to keep in mind that the superficial branch of the peroneus pierces through the crural fascia in the anterolateral lower distal part of the leg and divides into two sensory branches, which is one, the medial dorsal cutaneous nerve, but also the intermediate dorsal cutaneous nerve. And this is also the area where the mechanical irritation always happens. So in that distal third, right when it pierces the crural fascia. So patients always come with this exact same three symptoms. It has localized pain in the distal part of the lower leg. It has burning dysesthesias and paresthesias and also claudication-like symptoms after prolonged walking. Causes can vary a lot, so we have facial thickening and fibrosis, which can be the cause for the pain. This happens especially for patients that are very athletic, they run a lot, they ski a lot, so it leads to a chronic friction between the fascia and the nerve. We also have tumors that can be the cause, as you can see in the upper right images. These are intraoperative images of a 15-year-old boy that had a schwannoma in the anterolateral lower leg. It can be due to post-traumatic or post-inflammatory scarring, also persistent external compression. For example, with patients, we have them a lot in Austria. They go skiing a lot, so they have these external compression issues due to skiing boots or even inline skates. And for some patients, it can also be idiopathic. For example, when they're very, very slim, they have very thin legs and are very muscular at the same time. As for diagnostics, we have two tools. It's one in the clinical exam with a positive Tinel sign over the area in question, and also a high-resolution ultrasound. Here you can see a few images with pathologies that can be seen in the ultrasound, but basically it's either a focal swelling or caliber change of the nerve, or when it passes the crural fascia, or in some cases you can also see nodular facial thickening on top of it. I can't see my slides. I can't see them. Yeah. Okay, so for differential diagnostics and clinical relevance, it's important to keep in mind that patients stay misdiagnosed for a long, long time. They go to neurologists, they go to angiologists, they keep referring them to some other type of doctors or images, especially when the patient is elderly or diabetic. The first thing they think of is a polyneuropathy, which doesn't make sense because it's a systemic cause, but if patients come and present themselves with a unilateral, activity-dependent or exertion-related issue and very localized pain, you should think of a focal nerve compression. So, yes. So now we get to the clinical cases. The first one is a 49-year-old male having pain, forefoot and numbness and paresthesia for the last 5 years. He noticed it first time while going skiing and has been going from one doctor to the next trying to figure out what the issue is. He was at the neurologist, he suspected a polyneuropathy, and because he ended up being a friend of a friend that knows about peripheral nerve compressions, he was then sent to us. We did an MRI that turned out to be unremarkable. We also did an ultrasound examination, which then showed an early branching of the superficial peroneal branch and a very tight fascia, like a crural fascia, where it was mechanically compressed. So we also always ask the radiologists to do the markings, so they help for surgical planning. This is what you can see on the right picture. We ended up doing a neuralized right where the markings are, and these are some intraoperative images where you can see the fascia being thickened and also the two branches that we then did a neurolysis of. The patient came 4 weeks later and it was completely pain-free. Important to know that Yes, the patients are pain-free, but the dysesthesia and the tingling stays for a while. It can stay for a few weeks until again. So this is case number 2. It's an 86-year-old patient. He had a bit of a complicated journey. He had pain in the right peroneal nerve for over 10 years and was a professional skier as well. 10 months prior to his presentation at ours, he underwent another surgery already. It was a decompression of the common peroneal nerve over the fibula head. Exactly, but post-operatively the pain was worse. So he came to us. He had a positive Tinel sign, one over the fibular head, but also over the distal lower part of the leg. So we also sent him to an ultrasound, and he compared it to the preoperative examinations that he had, and basically he confirmed the increased swelling of the peroneal nerve and also the compression more distally. So he had a double crush lesion in this case, so a proximal decompression was necessary and also a distal one. This is what you can see in the intraoperative images. The nerve already looks a bit bluish. It was suffering a bit, but already 2 weeks post-op he was pain-free. So in conclusion, a distal peroneal compression is rare, but it clinically very, very relevant. The diagnosis should always be considered, especially when patients have a one-sided problematic that gets exerted when with activity and is being localized. Clinical examination is important as well as ultrasound, and at the end, it's a very simple surgery that can help patients with pain they've been suffering for multiple years. Thank you.
Thank you very much. I think as the IT team are sorting out the issues we have with the screens, we'll take a few questions for the first presentations that have been done before Dr. Ola progresses with our next presentation. So any questions for Dr. Nyabuto, Dr. Adegu, or Dr. Ola?
Yeah, thank you. My question is to Dr. Adegu. For the cases you are presenting, I think maybe I don't look at a lot of spinal injuries, but there's hardly any evidence out there that cord transection does get neurological recovery, either with stem cells or interposition. So you told us that there was some improvement. Of course, the presentation was short, so I don't know where the evidence, objective evidence was that that was true, and the levels of the injuries that you are handling, whether they, in relation to the recovery or the improvement that was being observed. They are interesting findings, but I'm still struggling to figure out how.
The one on the floor, I'll ask you another difficult question. I happen, unfortunately, to chair an IRB. So did you get IRB approval and patient consent for the interventions? Do you have any other questions until we're told? So yeah, I'm very sorry to the speakers and the team, because I thought Dr. Nyabuto's, I was actually thinking, I thought we were going to have a fight with her about the color of her slides, only to realize that it's a screen problem. So they're still sorting us out. I hope we can be fixed as well. Sound, because it keeps going off, and I can't believe it's the batteries that are going off. It has to be a system issue, so hopefully we'll get them fixed. And then, any questions to anybody else so that Dr. Adegu doesn't feel selected out? Okay, well, there, thank you.
Thank you. So regarding whether we got consent for the interventions, yes, we sought consent before the surgery and the various interventions. Then, yeah, it's true what Dr. Obira has asked. Actually, from literature, they don't usually regain their, you don't usually recover after the transection, and that's why after we did a little bit of reading, and then we decided to try the stem cells out. Most of the papers we found out, they were saying it's still experimental. It's not yet an approved or an approved right way of managing the cord transections. But then when we tried out, and for those 5 patients, and then it brought out some positive results. So we thought maybe it's something we can share out and look at the various mechanisms.
Hello, my question is to Dr. Ula. Do you think some of the cases of plantar fasciitis that do not resolve could be distal compression syndrome?
Was the first part, which kind of issues that could be that?
Plantar fasciitis,
Plantar fasciitis. It's
the ones that do not resolve with conservative management.
yes.
Yeah.
It could be, honestly. We had one patient where we had a similar case, and okay, it wasn't a plantar fasciitis in this case, but it was an incomplete decompression she had a lot of years back. So I think, yes, if it's one-sided especially, and it's not a bilateral issue, so excluding a systemic component to it, I think it could very well be that.
Any other questions to the presenters?
A great session, guys. These were fantastic talks. I was more of a comment on the superficial or the distal compression. It's actually sometimes common, and the other thing I wanted to stress is that you can see it after ankle sprains, because people's sort of ankle twists, then swells, and then they maybe get a tight cast, and then you can have compression. So I actually see this not that uncommonly after ankle sprains. So I just wanted to add that in.
Thank you very much for that. Yeah, so I think we can proceed to the next presentation. Dr. Ula will also be presenting on distal thoracodorsal to long thoracic nerve transfer for scapular winging in Parsonage-Turner syndrome.
Thank you. So yes, I'll be talking about a specific nerve transfer for Parsonage-Turner syndrome. So what is Parsonage-Turner syndrome? It's also called neuralgic amyotrophy, and it's an autoimmune mediated neuritis of the brachial plexus. Nerves that can be affected are either the suprascapular nerve, the axillary nerve, in rare cases also the phrenic nerve, but most commonly the long thoracic nerve, which shows as a scapula lata clinically, and this is also the nerve I will be talking about today. So when we have patients, they usually come in with very clear symptoms. They have a very severe episode of a shoulder pain, which subsides after a few days or weeks. The pain goes away completely, and it follows by an episode of weakness in the shoulder arm area, and also atrophy of the muscle related to that nerve. So when we have patients like this, they usually come in a few weeks later before all of this happened. But in the first 3 months, 3 to 6 months generally, we start with conservative treatment. So we treat with pain medications, corticosteroid therapy, and also physiotherapy, so that to prevent contractures of all the joints. Monitoring is also very important, so we tell patients to visit us again for a clinical reassessment after 3 months, and during after the 3 months we will also do a repeat MRI or high resolution, because a lot of these pathologies that happen right after only show after after a specific amount of time. So when we see that after 3 or 6 months there is no improvement clinically, we then think of a surgical option. So for the options we have a neurolysis. If there is scar tissue, it all depends on the pathology seen in the imaging. So it's either a neurolysis, resection of the stricture if there is one, with direct suturing. If the lesion is proximal, one has to think or plan for a longer regeneration time. And if there is a fatty atrophy, which is an indication for an already advanced disease, a distal nerve transfer should be thought of. So today I'm going to talk about the nerve transfer of a branch of the thoracodorsal nerve to the long thoracic nerve, and why the branch of the thoracodorsal nerve. This has a lot of reasons. So one of them is the anatomical proximity of the two nerves, which allows tension-free coaptation, which is also very important. The latissimus dorsi can compensate very well post-transfer, because we're taking just one of many motor branches that it has, and the latissimus dorsi and the serratus anterior, which is affected with long thoracic nerve palsy, activate synergistically. So it means they both activate during elevation, and the brain does not need to relearn anything. So this is case number 1. This is a patient, he came to us 10 weeks after his initial pain problems, pain in the shoulder, that went away after a few weeks, and it continued or progressed with weakness and atrophy. As you can see in the imaging, he does have scapula lata. It's very pronounced during RM elevation and anteversion. So we did an EMG examination that showed a denervation of the right serratus anterior muscle. In the MRI that can be seen in the left video, it shows hyperintense change of the long thoracic nerve. So after 4 months, we saw him again. There was no clinical reinnervation, so we decided to do the nerve transfer. As you can see, the patient is always in a lateral position. It's always a mid-axillary line, because it's very easy to visualize both nerves at the same time through that incision. You have the anterior border of the latissimus. Right underneath it, you have the thoracodorsal nerve. On the chest wall right there is also the long thoracic nerve. So this is what we did intraoperatively. You can see we're stimulating the long thoracic nerve. It shows no activity at all. Now the branch of the thoracodorsal branch, which shows a strong function. So this is also the surgical concept, just for you to visualize. Exactly, you can see that's the long thoracic nerve in the front of the chest wall, in the back the thoracodorsal one, and exactly, you can do the end-to-end coaptation, as can be seen in this intraoperative image. We also did immunohistochemical analysis, which I will not get into because of the time, but we just wanted to show that the thoracodorsal branch was also a very great donor nerve with a motor axon count of 22%. And the long thoracic nerve of patient number 1, we also visualized or did a immunohistochemical analysis, and we couldn't quantify anything because of the severe degeneration, as can be seen here. This is our patient number 1, 7 months post-op. You can see, yes, he does not have a scapula lata anymore. It glides physiologically, craniolaterally, and he could go back to the sports he was doing. I was very happy. Case number 2 is a similar case. He had a sports injury 6 months prior to his presentation at ours with the same exact symptoms, progressive weakness after an episode of pain, marked scapula lata. Which is interesting for him, though, is the hypertrophy of the trapezius muscle since he was compensating. And although he did regular physiotherapy, it was, yes, still problematic. So we were still waiting 8 weeks after he presented to ours, so we operated on him 8 months post-op. And we did the same thing, mid-axillary line. You can see here intraoperative nerve stimulation, no function of the long thoracic, and a strong thoracodorsal branch, end-to-end coaptation, and these are the results 3 years post-op actually. Yes, and you can see in the surface EMG as well that the activity got much better than we had as baseline. Yes. So in summary, it is a very reasonable and reliable nerve transfer. It is great because of the the anatomical proximity and also the synergetic action of the latissimus dorsi. You can use it even after the classical 6-month surgical window, and you can not only use it for delayed presentations or diagnosis, but also in proximal lesions where you expect a long regenerative time. And yes, thank you so much.
Thank you very much, Dr. Ola. We'll proceed to the next presentation. We'll not have the presentation on microsurgery, but the next presentation will be integrating neurophysiological assessment into chronic post-amputation in a Cynthia Monte will present on this.
Good morning. My name is Cynthia Monte. I'm a medical officer. I work in Makueni County, and I want to share a case with you that will emphasize on the role of integrating neuropsychological assessment into chronic post-amputation care in resource-limited settings. So there was no conflict of interest to declare. So the case is about, I'll share with you the case, but as we go through it, we'll see the role of, if the patient could have undergone reconstructive surgeries, especially the peripheral nerve reconstruction surgeries. And also there's the gap that we'll see about the role of neuropsychology in that patient, neuropsychological evaluation, and also some part about wound care management and the advanced dressing materials that we could use if they are actually available in some of the counties. So it's about a 70-year-old female was diagnosed with type 2 diabetes around 3 years ago, where she had presented with non-healing leg wounds. So the diagnosis was made at that time, and also the amputation was made the same year. And then since then, she has been presenting with persistently non-healing stump that has been requiring frequent cleaning and dressing depending on the condition of the wound. And at some point, she has done around 5 debridement sessions up to the point that we did an above knee amputation. So at that time when she came 3 years ago, she was evaluated and a below knee amputation was done, and then now she presented with a non-healing stump. Of note is that she has been exhibiting severe pain behaviors during the cleaning and dressing sessions, and these were exhibited by symptoms such as withdrawal and flinching. And also of note is that this patient became mute around 7 months ago. although there's a history of a cerebrovascular accident around 30 years ago, but she didn't have aphasia until 7 months ago when she started doing the frequent cleaning and dressings. So she also had these flat facial expressions, and of note is that there was no any neuropsychological assessment that was done throughout the course of the treatment. So I've mentioned that the patient has had severe for almost 30 years now, had suffered the weakness and has done the physiotherapy sessions, but she has improved with the physiotherapy sessions. So currently she doesn't have any recent focal neurological deficits that were associated with the new onset aphasia. So upon reevaluation, the decision was made to do an above knee amputation, and now the discussion is about the multidisciplinary team care role that was supposed to be done for this patient. So the nursing part was done, the cleaning and dressing, although there's that deficit in that there's no dressings materials that are available actually in that county and in that hospital that I work in. There's no good wound care sessions that are usually done to enlighten people and give them continuous education about the wound care management. So there's the general surgery team that was in the amputation, there's the internal medicine team for the diabetes. So now the big problem we have is that in the entire county we do not have any plastic surgeon that is offering services to about 900,000 people in that county. And we have to refer these patients to a different county in Machakos County. So if we have a patient that needs a plastic team's review and an expert opinion, then we refer these patients, and then at the end of it all, we lose this patient to follow up because we cannot get a surgeon, and it's astonishing that it's in 2026 and we cannot get a surgeon in a whole county. So the other role that was missing was the role of the neuropsychological team, because this is a patient that has suffered a CVA 27 years ago, and so it's more of a neuropsychologist doing the work other than a psychologist or a psychiatrist, because this is a person that understands the neurology and the psychological aspect for a certain patient. So the main point of this presentation was that we are in such an advanced era that we cannot lack a plastic surgeon in our county, and something needs to be done about it. And not even a visiting surgeon. We don't have a resident surgeon. We don't have a visiting surgeon. And so there's a lot of, and even the case that was presented yesterday about the cleft lip repair. That's a patient that was done surgery in their teenage years, and this could have been done way earlier if there was any visiting plastic surgeons. This could have been done way earlier in their childhood. And also there was a presentation about the Margot debridement therapy. We do not have these things in that county, and so we are just doing the regular cleanings and dressings, and we don't even have those dressing materials. And I think those sponsors usually come and give us the dressing materials. They could come and they could show us the different types of dressings and how to use them on different types of wounds, and then we could integrate on how to maybe find a way to get a plastic surgeon in that county. So that's it. That's my presentation. Thank you.
Dr. Cynthia Monta. We'll proceed with Prof. Thumba's presentation on salvaging mangled hands using the thoracoepigastric flap.
Dr. Monte, kindly don't leave the stage. Please stay seated. And I was going to say, I'm not the president of KSPRAS, but I know that the Kijabe team and the KSPRAS and KSPRAS as a community, if you are able to make arrangements through the county, we probably can find you a visiting team every month, maybe for one day. So I think you get the county, you walk through the county, you contact the KSPRAS, the president. I'm sorry for throwing you into this under the bus, but under that, I think we would be able to, we can provide someone monthly. For all you have to do is make sure we can come, have a place to stay, and we can go back to our places. And then we'll work around our schedule.
Yeah, I agree fully with Professor Ndumba that yes, we are more than willing to come and help you in Makueni. And also we'll be very keen to have you train as a plastic surgeon if you are interested, so that you become a pioneer plastic surgeon in Makueni. And I think even just being here already demonstrates you that you are keen to join the specialty of plastic surgery.
So congratulations. Thank you. Waiting for the presentation. While it is coming up, I guess I can do something that Dr. Dossi will be doing later on. Thank you. Well, it's here, so we'll go. My name is Ndumba. I'm a surgeon at AIC Kijabe Hospital. And I just want to talk about hand salvage for patients who, a lot of them come self-referrals or referred to us because they were told they needed an amputation and did not want it. So I have a disclosure, I have an interest in hand surgery. I'm concerned, as demonstrated by a previous speaker, we have a limited skilled workforce. We have limited resources, a whole county without dressing materials, rehab, revisions, etc. Because of that concern, we are in the process of launching a Kenya Hand Society in collaboration with orthopedics. We plan to have a conference on the 20th to 22nd of November this year in Nairobi. And we hope to be able to start a hand fellowship. Hopefully the next time we come here, we will have announced the positions. We hope to do 2 hand fellows per year. Still, I think some of these have been filled. Professor Nangole has kindly agreed to do the free flaps. Anybody seeing anything of interest and has time in November, please come. So upper limbs are amongst the most injured anatomical regions of the body, resulting frequently in loss of skin envelope and exposure of vital structures. So stable, reliable cover with the simplest reproducible procedure permits management of extensive injuries in a multi-stage journey. For example, if we were to go to probably the easiest thing to do in Makueni would be to go and do a flap, even if it needs to be divided 3 weeks later, because someone else will come and take care of that. This paper was published last year. And we're looking at thoracoepigastric flap for multiple potential problems in the upper extremity. What I love about this is it allows for the upper limb to remain elevated and avoids hygiene around the perineum, which is a problem with groin flaps. And so this is a conveyor belt injury, hopelessly mangled. There's really nothing you can do for this guy except an amputation that allows for the wrists to still function. These are 2 different patients. This patient was caught in a heat press, a hot press, triple lesions. So the first thing is to find a stable cover and then plan for reconstruction. This is a patient who sustained a crush injury in a cement mixer and came 5 days as a self-referral from a neighboring country, came in an overnight bus to avoid an amputation. When we opened him up, this is what it looks like volally. And it's even worse dorsally. So he came so we could salvage, and the question is, what can we do? So a first look debridement allows us to have a discussion. Of course, what's dead is dead. What's questionable is what we leave around, behind, especially in the upper limb. But subsequently, we ended up with a single digit and about 3 metacarpals that we then covered with an envelope of thoracodorsal flap, a thoracoepigastric, and gradually creating what would become digits and then some motion. So currently he's able to use this to assist, but when the process of, he can get a pinch in the next process. The difficulty with these patients is, so this is a patient actually from Makueni who was a self-referral again at about 5 days. He's diabetic, he's 35. He was told he was going to have an amputation and he didn't want to. It was very difficult. Dead bone, how much do you take? So the upper extremity basically can be shortened. As long as you have hand function, you can shorten it and use it. So a little shortening and attempts to plate him, we've had problems. These are serial photographs to your right, I guess. That distal radius attempting to, so I've done 2 bone grafts. The first one failed. The second one, we ended up with a non-union infected. So second time, he's got some colors and hopefully we'll get some function from him. This is a different patient, tractor injury on his farm. They always look simple when they first come, but this picture on your right, upper right, is not clear, but it actually has a loss of bone metacarpals, and the hand is divided into 2. Basically, there's a proximal dorsal and a distal volar. This is him, so we reconstructed his metacarpals with an iliac crest bone, and he's got reasonable function. This is a chaff cutter, arrives like this, looking very nice, debrided, that's what it looks like. He's lost a lot of bone and soft tissue, and that's what his x-rays look like. He actually only had a thumb stuck to the rest of his limb. He showed up late, so there was really nothing we could fix vascularly, but he had a live hand, and that's always scaring because he has like 2 centimeters of tissue holding him, and the whole hand is alive. And when I go in, killing it is a real possibility. So I usually do minimal hardware, which is a single pin everywhere. That's him after he's healed. And you can see the scar, if you can, on the left. It goes right across to the index finger. And the scaring bit is coming back to give him sensation, because he has a live hand that he can see. And I am going to do, and I don't know what supplies him. I mean, I think one, I've done some MRI angios to try and see. This one I did not, but so this one is nerve grafts and tendon grafts, and I'm sorry the picture isn't very clear on the screen, but if I can get this. So this is him late last year. He's got a nice grip, and if I can get, are you able to play the video on the right picture, or is it the left? Okay. Okay, if you're not, it's okay. Oh yeah. So that's him. Somehow his index opens up, and then that's him. He's got a nice grip. He's back to his work. He's only 25. All right, I have 2 minutes to go. So I was going to stop there anyway, but so these patients require a lot of thought process into following them up. So far, I've been fortunate. I haven't lost hands that we'd salvaged, but it's always a reality. So thank you very much.
Prof. Ntumba, We'll proceed to the next presentation by Dr. Mundi. He'll be presenting on of the thumb with the finger in a heavy smoker.
Good morning. Kindly load the presentation. This smoker. So this is a case report that was done 3 years ago. It's been published. Those are the co-authors. And my name is Dr. Ruben Kamundi. So it's in the current journal of our paper, what is it called? Journal. Yes, the June issue. So you can grab your copy at the registration desk just to check on it. So as Dr. Ndumba has it's similar. The presentation is just similar to what Dr. Ndumba has presented, only that in this case we didn't have a viable thumb. So he was a construction worker. His hand got caught in a revolving machine. Then his thumb got crushed, his index finger got crushed, his middle finger also was crushed. However, it was salvageable, and the ring finger was also traumatically amputated. The small finger was spared though. So heterotopic reimplantation basically refers to reimplanting a finger or a digit that has been traumatically amputated to reconstruct another finger. It is paramount in this situation to use heterotopic reconstruction, basically whereby you cannot reimplant. So let's say, for example, you lose the thumb. Your thumb is chopped off and you want to reimplant it, but you cannot because it's badly crushed. So you resolve to using another digit to reconstruct the thumb. Or you can also use the toes. Anyway, so reconstruction of the thumb takes precedence over other digits because the thumb is responsible for 40% of hand function. So it's a really vital digit, and especially for us surgeons. Some surgeons have gone ahead to insure their thumbs because without a thumb, really, especially of your dominant hand, you basically not be able to operate well. So we've seen advancement in microsurgery skills that has led to increased cases of successful reimplantations that has led to good functional and aesthetic outcomes. It's possible to attain full functional recovery, and this depends on the severity of injury, meticulous nature of the repair, and rehabilitation services. This is the part where we really struggle a lot as a country because we have very limited physiotherapy personnel who are trained in hand rehabilitation. However, we make do with what we have and we still try to get good outcomes. The other challenge we face is patient compliance. Most of these clients who come to us, the company will either pay for the surgery but will not pay for the follow-up physiotherapy. So it becomes a great challenge. So other secondary factors that influence outcome are comorbidities, your hypertension, diabetes, your age, and in this particular patient, our patient was a heavy smoker. This we've mentioned, and the reason why thumb takes priority is to be able to provide opposition, the pinch grip, okay? So what happened is basically we took the middle finger, repaired it. Let me just move forward a bit so that you're able to appreciate the photographs. So he was a 45-year-old male, a heavy smoker. And this is what we were dealing with, okay? You can see the thumb is not there, basically. It was a traumatic amputation. The index finger was also missing. The middle finger was present, but the neurovascular bundle was destroyed, but it was salvageable. Then the middle finger was amputated. You can see the digits that we had to work with. In the interest of time, let me just show you the images. So this is another angle of the same case. So basically the priority is to ensure that you have at least 2 to 3 digits, what we call a bipod or a tripod hand, to assist be able to offer some form of function for this particular patient. It was his left hand, not the dominant hand, however, is still important when you're considering reconstruction. So we had the ring finger disarticulated at the PIP joint, index finger totally amputated at the MCP joint. Of course, the initial assessment was done, x-rays, surgical toilet, and the reimplantation. We used K-wires, of course, to reattach. So basically what we did, we took the ring finger, then reimplanted it to the thumb and repaired the neurovascular bundle using a nylon 10-0, followed by some skin grafting. Being his left hand, then he may have a challenge putting on his wedding ring, because we had to use the ring finger to reimplant. Remember, the ring finger was also traumatically amputated. Then, of course, what follows after is a back slab, discharge and follow-up, and with the removal of the K-wires, 3 to 4 weeks, and regular physiotherapy. And we did have some very good results, because at 6 months follow-up, we had 30 degrees of metacarpophalangeal joint movement with limited movement at the distal interphalangeal joints. And he had some good opposition of the reconstructed thumb with the index and little finger. So basically, we were able to give him a tripod hand. Out of the mess that was there, we were able to salvage 3 digits, which was very good for him. So this is the initial day. This photo was taken a few hours after surgery. We had bleeding. We were called back to the hospital to check on the dressing. I think it was around 2 a.m. So we took this photo. You can see now the reimplanted thumb. That's the middle finger that we had repaired and repaired the neurovascular bundle. The ring finger, you can see, we used it to reconstruct the thumb, and then the small digit. And you can see the bleeding is quite good. This is just a few days after surgery, as we're following up. And yeah, this is at 6 months. You can see healing has taken place. He's able to hold a pen. Remember, it's his left hand, it's not the dominant hand, but he's able to scribble something which could not have happened had we not given him this kind of result, a tripod hand. So basically, the ultimate goal is to achieve a sensate hand and digits plus good function to enable them carry on with normal activities. So it's important to prioritize the available digits and tissues to achieve maximum function. We've had cases reported, successful cases. An example, Bitomi Nai Chen, who reimplanted more than 50 digits. He had a survival rate of 83% and a tripod hand in more than 80% of the cases. We've had other authors who've reported quite some good outcomes also, with a tripod hand in about 90% of the cases able to achieve the pinch movement. So though our patient was a heavy smoker, we didn't experience any incidence of vessel thrombosis. Remember, microsurgery was done. Wound or flap dehiscence. The one thing that worries us as surgeons is that smoking affects your wound healing, so more often than not leads to wound dehiscence. And of course thrombosis, but this, we were fortunate enough, didn't happen. And I think we could deduce that smoking should not be used always as a contraindication to reimplantation, especially when it's an emergency situation. Tripod hand has best results. However, we did face some limitations, of course. He had reduction in both of the reconstructed thumb and the middle and little fingers in the metacarpophalangeal and the proximal interphalangeal joints. He was able to oppose, but there was limited movement in those joints that were mentioned. This could be attributed to the prolonged K-wire placement and delayed commencement of physiotherapy, again due to access and financial capability. In conclusion, prioritizing the thumb and two adjacent fingers is very important to be able to achieve that opposition. Postoperative follow-up and hand rehabilitation are critical for full functional recovery. And to conclude is that heterotopic reconstruction of the digits remains a viable option for reconstruction of the hand, following a mangled hand injury even in patients who smoke a lot. These are my references. Thank you very much.
Thank you very much, Dr. Kamundi. We'll proceed to our last presentation for this session. Dr. Andreas Goheritz will give his presentation on the surgical treatment of intraneural ganglion cysts of the common peroneal nerve.
Good morning. Good morning, dear colleagues. My talk will be on intraneural ganglion cysts, pathophysiology, diagnosis and treatment. But rare tumors, they are cysts that arise from an adjacent joint and go via the joint branch that connects the nerve with the joint and form these cysts that then travel along the nerves. They have been described first in 1810, but for a long period of time they were a bit enigmatic. You did not know where they came from and how to treat them. And in many cases the surgeons tried to remove the cysts, but the cysts always came back. And this was until there was an explaining theory, the unified articular theory by Robert Spinner from the Mayo Clinic, who discovered that you have a weak point in the joint capsula where the joint branch of the adjacent nerves enters the joint, and retrograde, if you have a higher pressure in the joint, for example when you're kneeling a lot, then the joint fluid can be pressed via this connection into the nerve. And this is a mechanistic model, but it explains this phenomenon, and it also gives you a good treatment option. So the typical patient has a painful neuropathy, sometimes very sudden. He says, I had electric shock. There's a motor deficit. There can be also a sensory deficit. And the symptoms can also change because the cyst's pressure can change. And there can be a disparity between the clinical image and what you see on the imaging later. So, for example, we had this 45-year-old man. His wife had a spinal cord injury, so he had, while she was in hospital, he had to renovate the house. He did a lot of kneeling work, and then suddenly he had an acute foot drop and a lateral ankle pain. So he had an MRI which showed his intraneural ganglion cyst of the peroneal nerve at the fibular head. MRI has been for a long period of time the reference standard because you can directly visualize these cysts. They have one disadvantage. Usually it takes a while until you get an MRI. So if you can be faster, then you can also see faster what the problem is and probably operate the patient as soon as possible, because these mononeuropathies sometimes take a long period until they recover. So you see the clinical image, the imaging MRI of this patient that I described to you. with a large 7 centimeter ganglion cyst with a tail extending towards the superior tibiofibular joint, subepinural propagation, so within the epinurum the cyst travels along the nerves, and there's like an inner compression of the nerve, and the muscles that are innervated by the nerve in that region, they become denervated, and you can see that clearly on the MRI by edema. So high resolution ultrasound in comparison is much more rapid usually, because you can do it yourself, or you have a radiologist that you can send the patient to in your hospital optimally, and you can also see clearly the articular branch joint connection. If you have a good radiologist, sometimes it's a bit difficult, but it can be used, I would say, as a complement as an MRI, because it's much faster and it shortens the time until a potential decompression. So you see, this is the ultrasound image of this very long cyst, and this is the intraoperative image, and I put a thread around, and you see a little arrow around the connection, the joint articular branch that goes from the perineal, common perineal nerve to the proximal tibiofibular joint. So the principle now is not to remove the cyst entirely with all the wall and then damage the nerve. It is to find the connection, transect the connection, because that's the source of the problem, and then you can just make an epidural incision and decompress, so press out the what is in the cyst, and then suck it away, and but you don't have to touch the nerve any further. So that's the new surgical strategy. It's much more gentle to the nerve. You decompress it after this epidural incision. You avoid radical intraneural surgery, and you address the real source of the problem by transecting this connection. So this is again the MRI of the patient. It's very common in the perineal nerve, but also in other nerves like a tibial nerve or ulnar nerve, can be in every other nerve of the body. This is the example of a tibial nerve. So you see the small connection, and I'm about to clip it with a microsurgical clip. So there can be also recurrences when you don't find this small branch, or when you mix it up with other branches. You need nerve stimulation, muscular branches, and to for example cause a drop foot permanently. But usually recurrence rates, it's much lower than in the previous with the previous strategies, and it's a very good field to cooperate interdisciplinarily with radiologists. They give you the information about the cyst, and then with that information you can plan the operation. So we had 8 cases during the last 2 years that we treated with this principle. We did no complete cyst wall incision. We always found the branch and transected and clipped it according to this unified articular theory. We had good outcomes in 7 of 8 patients. We had 1 patient that did not recover M4 motor function, and he had a tendon transfer, and there was 1 patient that I had to reoperate 2 times because there was a cyst recurrence. So the clinical take-home message is, think of an intraneural ganglion cyst when you have an acute palsy in a nerve that you cannot really explain otherwise. high-resolution ultrasound can speed up the diagnosis and facilitate an earlier operative treatment. If you're early to decompress, you have the best chances that the nerve function and muscle function can recover. Treat the mechanism. Do not cut out the whole cyst, but interrupt the articular branch, the joint connection, decompress the nerve gently, and the earlier you can do that, the better the results, because delay matters. Thank you very much.
Thank you very much, Dr. Andres. We'll move on to the Q&A section. Any questions to our presenters?
Hi, morning. My name is Dr. Sharon. I work in an emergency room, and my question is to Dr. Kamundi and by extension Professor Nthumba regarding crash injuries, especially for people working with machines. Are there any preventive measures in these workplaces that are put in place or can be put in place to prevent these injuries? Second question is, what are the immediate emergency measures that need to be taken to ensure as much limb salvage as possible? Third question is there a comprehensive care package for patients who've had such injuries? Because I'm thinking there's a psychological aspect to it, especially after reconstruction, for example. Is there like a care package, physiotherapy care package, and how often these patients come back for that follow-up, or are there those that are lost to follow-up, and what can be done about that? Thank you.
Prof. Thumba?
Just going to say, if you can have one question per speaker, we'll then have everyone respond. We want to try, if we can be ahead of time, it would help us. We'll have a sponsor come and speak, and then we can go off for coffee, and then the next session's a little earlier, and hopefully today we are ahead of ourselves. But any more questions to the speakers?
Yes, thank you. Good presentations. One question to Adegu. Did you have like a comparison to see the interventions that you are giving, whether there was anything superior to what is normally done in a standardized fashion, to see really whether the interventions that you give really help to make a difference from the standard therapy that is normally given to the spinal cord injury patients? Then to Professor Nthumba, using the thoracogastric flap, when you shorten that arm, how do you handle the vessels if you have to really shorten too much, and of course the nerves, to really ensure distal perfusion and nerve sensation thereafter? Thank you.
Any other questions? I think we can give the presenters time to answer the questions that have been forwarded.
Thank you, Dr. Sharon, for your question. Now, whenever you're faced with such a patient, especially with such kind of an injury, the most important thing is your primary survey. Your airway, your breathing, your circulation, your disability, those are paramount, because you find that they'll have multiple injuries. However, the injury that will draw your attention is the one that is actively bleeding, which is usually not the case. Remember, a few years ago, a patient was lost in KNH. She had 40% burns and also had an acute abdomen, and died from an acute abdomen simply because it was missed on admission. So the most important thing is to go through your ABCs, stabilize the patient, then now focus on the wound. In terms of knowing which wound to salvage and all that, it depends on the extent of the injury. So you get to examine the digits, get to examine if there's pulse, the normal things, color, capillary refill and all that, then it becomes a challenge, especially if you have the digit still hanging on, but there's no blood supply. That one's a bit tricky, but the color also will guide you and all that, and also the time of injury. So it's a collection of things you have to look at. Then in terms of care package, yes, before you amputate anybody's digits or limbs, it's important to always counsel your patients. I think we also do it in Coptic. Before you even sign, there's a form usually signed, disposal form. Before the patient signs a disposal form, if the digits cannot be reimplanted, you always have to take them through counseling, because this is something they lose, and this is something that will also affect their function and all that. If you're able to reimplant, you go ahead and implant, but you still proceed with your counseling sessions thereafter and your rehabilitation after. So remember, it's multidisciplinary, this management. You still need your nutritionist, your medical officer, your nurse, and the entire team, basically. Yeah, so basically, I remember in 2018, a similar question was asked, the conference, Professor, I don't know if you remember, the SSK conference of 2018 when you were presenting on the hand. I think it was Dr. Laura, and they did mention that if you're faced with an amputated limb, it's important to preserve it. Okay, so you preserve it in a cool box. Of course, you don't put it directly on the ice, but you wrap it in something wet, and then put it in a cool box, and then now you can refer the patient. Yeah, so basically that's what you do when you're faced with such a challenge. Unless you have any other question. Okay, thank you.
Thank you. To answer Dr. Kiriga, we didn't have a control group. This was like a pilot study. So once, now that we got the preliminary results, we are now going to scale it up and have the control group to compare with, and then we match them, the demographics and the patterns of injury, so that they're all matched. Thank you.
Thank you. Was there a question to anybody else? So let me respond quickly. Shortening of the forearm. So the decision is usually how much, what is the degree of injury? Now for me, the patients that come to me hardly ever come that day. Like they usually come when they've been threatened with an amputation. So I am not dealing with an acute injury, which has different dynamics. So if a bone was dead, it is dead. And usually the question is like the patient I presented is figuring out turning him into a single forearm bone until we're able to reconstruct something else. So the shortening usually isn't that much. 4 or 5 centimeters does not interfere with function. Otherwise, I guess you'd need to hold him out with an X-fix. The other thing is I really don't enjoy X-fixes unless I'm doing something with them, because reconstructing, especially around the lower extremity, but frequently you have to take them off. So the shortening shouldn't interfere with vascular supply. In fact, foot filler is one of the most difficult ones, because you do tend to almost cause kinking, so that needs to be managed. Comprehensive care, I think mental health has become a big deal these days. It wasn't when I look back at the way I was trained. There were mental health issues. I probably needed support at that time. But I think for all our patients, almost all our patients have mental health issues, concerns. Usually there are social issues surrounding anybody that comes to hospital. So if they're severely injured, the best thing is to get psychology involved early. And that's for almost every patient, irrespective. And the issue of preparing the limb has been mentioned. So one of the problems for us is advocacy, referral pathways, and just an understanding. So everybody in this room knows we can replant digits. replant joints. I guess Kenyatta has done a good deal being in the papers, but people still don't understand. Actually, doctors don't understand that you can fix brachial plexuses. So I think one of the things is we need an advocacy arm that will go out and tell everybody that this can be managed if presenting in a timely fashion. There's no point sending a brachial plexus injury at 18 months to the plastic surgeon. And then the other advocacy is just workman's compensation. So hopefully these are some of the things that having a hand society would strengthen in KSPRAS, because workman's compensation is a joke. It's only about amputations. There's nothing about loss of function, which is a big deal. So I think with that we will do the needful, get the group together, take a group photo, and then, or maybe we should do that after the sponsor?
We can do it now before the sponsor. So the photographer is ready. Just our presenters just stand for the photo. Then we'll proceed with the sponsor talk from Dawa Life Sciences.
Dosi, part of the team on the podium.
So as we wait for Dawa Life, we still need to give the certificates as we wait for the presentation. Thank you very much. I just want to give a brief just explanation on the upcoming Kenya Hand and Microsurgery Conference 2026. It will be held in November 20th to 22nd in Nairobi, and we're holding it in support from the International Federation, from the IFSSH. It will be held in Westlands at the Dusit Princess Hotel, and we have a great program with both local and international speakers, as well as a cadaveric flap workshop on Friday 20th, and a tendon and nerve repair workshop on Saturday the 21st. And the conference will also hold as a way to launch both the Kenya Society for the Surgery of the Hand and the Hand Surgery Fellowship that we intend to start. So I'd like to welcome many of you to give papers. We'll be sending out the abstract notification and also the website for all the information, and you're all welcome to join us. Thank you. Dawa Life Sciences, you can proceed.
Good morning. Thank you very much, Dr. Dorsey, for this opportunity. My name is Esbon Minor. I work for our life as senior manager. And today I'll give a brief presentation of our company and also a few products that we handle. Thank the KSPRAS fraternity for this opportunity. Indeed, we're privileged to partner with you as Dawa Life Sciences, and I'll be very brief on my presentation, but it's always good a background about our company. Dawa Life is a local company, a local manufacturing company, which has been in existence for 30 years. We're in the business of people and also and also animal health. And we'll continuously work together with the local association, local doctors, and also any partner that comes to Kenya, even for CSR or any activity, we can definitely partner, reach out to us. We have two companies here at KSPRAS. We have Skin Tech, which is part of our system, and also Dawa Life Sciences is a. So moving forward again, Dawa employs over 700 Kenyans. So every time you prescribe a Dawa medication, you are giving employment to over 750 employees. We have presence in over 10 African countries, and this to make sure our medicines are available in our neighboring countries. We manufacture locally, but we have presence in all these countries where we ensure quality and affordable medicine reach our neighbors. Again, we have our values, core values, and one is quality and innovation, and definitely customer satisfaction. Medicine is key, but it's only effective if it's available and quality. We have our leadership. The company was started 30 years ago. These are top leadership: Dr. Raju Mahindra, Dr. Ajay Patel, Dr. Rima Mahindra, the co-founder, and Arun Mathur. Then again, in the pharma, I mentioned we have the pharma and the livestock department, but we're here for the pharma, and these are top leadership. You can see our leadership is quite from a wide range of, or rather, it's quite inclusive. And we've been expanding our plant, and on the 20th of October this year, we'll be opening a new plant, which will expand our portfolio and be able to produce more medicine at a cost-effective rate. So these are key standards that we've been able to achieve. And again, our partners are across the country, and we do GMOs and we have CMOs, contract manufacturing, but we also at our local plant. So I'll go to our products. Before that, I've seen you've done a lot of, or you encourage that you partner with us for CSR. We want even the medical students at Kenyatta or anywhere, Kijabe, everywhere, reach out to us. We always partner with students, and also we sponsor these events. On the products, we have a wide range, but I'll dwell on 4. And the first one is, globally we know there's a hype about weight loss, and affordability is an issue. But we want whatever is in the West is also available in Kenya, because the benefits are really huge. We have our GLP-1, GIP, receptor agonist. This is our tirzepatide. I believe the mode of action and the dosage in diabetes and obesity is well known. So I'll go just straight to the available options in Kenya. We have available in the 2.5 milligrams, the 5 milligrams, and 7.5 milligrams. Competitive. Obviously, the 2.5 for a monthly dose, 1,000. The 5 milligrams at 20,000, and the 7.5 milligrams at 22,500 factory price. Secondly, we have a wide pain portfolio management. So, and we have our aceclofenac ranges, ACEPA. This is from we have versions of ACEPA. We have the ACEPA plus paracetamol and the ACEPA MR, and lastly we also the ACEPA SP. Still in pain management, the traditional NSAIDs have always had a lot of challenges, and especially with GI, the cardiovascular challenges, and the GI defects. Kidney problems as well. So we recently introduced a new brand in the market, a coxib called Polmaster. It's a Polmacoxib. It's available in a 2 milligram capsule. First in class, you will realize most of the coxibs will be from, if it's heterocoxib, you will start at 60 all the way to 180 mg. But you find the Polmacoxib is 2 milligrams. So it's quite effective and has a unique mode of action. Binds largely to the carbonic anhydrase in the red blood cells. So the 2 mg is actually almost a slow release. And this gives it quite many benefits from the cardiovascular to the renal and also the GI safety. So it's now available in Kenya as Polmaster, 2 milligram, and readily available in the market on a once daily dosage. Again, we have our iron supplementation. This is Hemoflux. Hemoflux is also available in the market. I know in wound care and all iron deficiency, we have an option here of Hemoflux 500, which will, when you come to our booth, we'll be able to explain to you how it's packed, how it's available, the formulation, the benefits, and we'll encourage you to take this out. All these, as I mentioned, are available in the market at very friendly, cost-effective pricing, which makes it available to your patients. So that marks the end of my presentation, and I welcome you after the tea break to visit our booth. It's right, you won't miss it. So welcome and learn more about our life and skin tech. Thank you very much. Back to our moderator, Dr. Dorsey.
Yeah, I'm not very good at this business. Watu wa mlima ndio wanaelewa hii kazi, lakini nitajaribu kidogo. So at the registration desk we have a bit of merchant. Yesterday we held the journal and the book. So you need to grab yourself a t-shirt. So there are two colors. I don't know whether that is white. You know, men are colorblind. And maybe those will tell us that one. I don't know whether it is black or blue. Oh, navy blue. She says it's navy blue. So those are going for 2,000 Kenya shillings only. If you know how to bargain, unaweza jaribu. And then we have scrubs. So the t-shirts are branded. The scrubs are not branded yet, but they are very good quality in 4 different colors. These ones are only 3,000, so it is a complete set. You have a top and the pants as well, different colors. And then for our friends from the northern hemisphere who are going back, summer is almost over, so you can grab yourself this hoodie for, they call it what, autumn or autumn, one of those. And for our Kenyan colleagues, you can also grab this. So this is 3,500 Kenya shillings. The scrubs are 3,000 for a set. And as I said, if you are very good at bargaining, maybe you might get a discount of 50 bob. Thank you.
Thank you, Dr. Abir. We can proceed for a tea break, and we should be back by 10:30. Thank you.
Okay. Thank you very much. Welcome to the next session on breast surgery. So, unfortunately, Dr. Christina couldn't. You're presenting for her? Oh, perfect. Yeah, we were looking for her, and she looked female, but it's okay. Part of our transgender surgery. Anyway, so welcome. Yeah, we'll have the first presentation on autologous reconstruction, breast reconstruction in previously failed implants. Enjoy.
Okay, thank you very much, everyone. Of course, I'm not Dr. Christina. Many of you already know her. She's a plastic surgeon from Italy, based in Milan. She's very passionate about autologous breast reconstruction. Many of you already know her because she's been to Kenya, to North Kinangop many times. Actually, she cannot be here today because she just finished a very busy autologous reconstruction camp in North Kinangop, and she had to take care of some complicated patients. So she asked me to give her a presentation. Okay, so that's okay. She has no conflict of interest, and she's always been very passionate, not only about the breast reconstruction, but also to spread awareness about autologous breast reconstruction. This is a book she published some years ago with some journalists, where they're telling the story of 14 patients that went to their breast cancer survivor that went through reconstruction. Asilo nudo means naked breast in Italian. So I'm going to show you some cases of autologous breast reconstruction, mainly after a failed implants. So what we have to consider when we're doing an autologous breast reconstruction are a few key points. Of course, to consider what we think it's the ideal reconstruction for the patient and what the patient is asking. So we have to make a balance between those two things. And of course, to make it clear if what the patient is asking is a realistic or unrealistic goal. Okay, to make it clear what expectation can be met by the surgery. And then, of course, you have to understand what you're dealing with. So how the tissue are, if there are some existing scar, progress operation done there, if it's got through radiotherapy. And then, of course, one thing is the plan, and then one thing is what happened during the surgery, okay? So this is a case of a young patient, okay? She already went right breast mastectomy. She got a mesh and an implant that get exposed. And so she was willing to have it removed, of course, and go through autologous breast reconstruction. She was a young woman, a model, okay, so with not much belly. So what we tell her, okay, we're gonna have to remove the fistula and all the tissue, to remove the mesh and the implants, and then we would cover it, we reconstruct it with a dip based on a single perforator. Of course, in this case, you know, you have to remove a bigger piece of skin and of tissue, because you have to be very aware to remove all the fistula. But the result is it doesn't have very big breast. It's quite good. Of course, we have to pay attention to try to preserve the nipple and the areola, okay, and to feel the inferior pole of the breast. We propose also to a contralateral stapes with a vertical scar, but in the end the patient say no, it's fine. She was not willing to do it, and this is also something very important that we have to consider. That, you know, we are aiming to have, you know, perfect symmetrical breasts. We are aiming to perfection, but sometimes those patients, you know, are a bit tired. They went through a lot, so sometimes they say, okay, even if there's 2 centimeter differences, sometimes they're not willing to go through the procedures because they are tired, they've been through a lot, and we have to respect and to accept that, of course. And so you think the result at 4 months, see quite a good result. the belly heals nicely, and you see quite a good symmetrical result. This is another case, very young patient with the mutation BRCA1. So she was wishing for a bilateral autologous reconstruction, but of course even this one was quite a tiny patient with not a big belly. She have not previous scars. In this case, what happened is that we were not very happy with the umbilical scar. And of course you have to tell her, since you are not that fat, you're not that much fat in the belly, if you're gonna have a bilateral reconstruction, you know the breast cannot be too big, of course. When we're doing a bilateral dip, not all the times, but we prefer maybe to leave an island to check how it's going. And these, of course, the two island flap after for 2 months. Usually we remove them, and you do also a bit of mastopexy after 2 months, and you can see with quite a good result. We're not that happy with the belly button. They get a bit strangled, okay, a bit of stenosis, but in the end the patient was quite happy with the result. You can see not so bad. You know, at the end, they even look, you know, nicer a bit, with a bit of mastopexy than they were before. This is another patient, a bit older patient, with a bilateral implants, and you can see on the right a nice result, on the left quite a big contractor of the capsula, and she wanted both of them removed, and she was asking for autologous reconstruction. Even her is not that, you know, not that big belly, and of course she's got quite big implants, like medium implants, but with this belly it's difficult to replace almost 400 cc in both breasts. So what we proposed to her, okay, was to reconstruct with a dip just the left breast. It was the one with the contractor of the capsula. And on the right part, we just removed the implants. We replaced the pectoralis major because it was a submuscle implants. And then we proposed also to do some lipofilling, fat injection. So at the first, after 6 months, you can see the right breast is clearly, you know, emptied. Okay, so she will need another procedure of fat grafting, and even in the upper pole, okay, of the left breast. So we do another procedure, and you see after 8 months, and then we do another procedure of fat injection. The results are quite nice. Still, we can propose her some, you know, small touch in local anesthesia. For the scar, you can see it's a bit indented. But usually, those patients, when they see they've got a nice breast and they look nice in their bra, usually they are happy. They're not bothered too much for the same reason I told you before, that they went through many surgery, and so they're just happy with the result. This is another patient willing for autologous breast reconstruction. She has a tumor in her right upper pole, no previous scar. Of course, in this case, she was having neoadjuvant chemotherapy, and of course, after the surgery, she may as well go through radiotherapy. In this case, we suggested on the right side a dip, and on the left side just mastopexy with a vertical scar. You can see with quite good results. At the end, there's still a bit, okay, of asymmetry, so we may propose another correction of the areola. And I don't know if you can see in the belly, but there is some 2 dogs here. This is something that may happen, and we can propose after the surgery. With we can remove them under local anesthesia without any problem. This is the last case, another reconstruction. You can see she got a right breast tumor, already been treated, no previous scar. You can see this is sometimes when you do the reconstruction, they can happen, of course, almost finished. Some complication. In this case, you got an hematoma, so you have to bring to evacuate the hematoma on the next day. But at the end, you can see the result was very nice. She even looked prettier than before, so we were quite happy with the result. Of course, you have to tell the patient those are big surgery. There can have, be some complication, but at the end they're quite willing to accept if you give them a proper informed consent. And of course, these are also the cases we are doing in North Kinangop with quite nice result. Here, even more than in Europe, truly the autologous breast reconstruction, since it's difficult to get implants, is very valuable and a very important option. And I have to say, thanks to Dr. Christina, in the last 2-3 years, we really increased our breast reconstruction activity in North Kinangop, and are willing to increase also in the future. Thank you very much.
Thank you for that. Next, we'd like to invite Dr. Shaban Saidi. Dr. Saidi is a plastic and reconstructive surgeon in Kenya who has more than 25 years of clinical experience. He works at Nyeri, Nyeri Hospital, and he does a lot of work on band reconstruction, cleft lip and palate surgery, and hand surgery. Welcome, Doc.
Thank you. Good morning. So thank you for the previous speaker. I enjoyed your talk on autologous. I'm going to talk about implants, breast augmentation by implants. As we know, we need to go to the future. Where are we heading as a country also? Okay. So usually there are various reasons why people undergo breast reconstruction, but mainly the change of the breasts, symmetry or breasts that had other issues that you want to change. We know traditionally the breast augmentation using implants would be either transaxillary, periareolar, and from these are the usual basic ways we used to do the implants. Two ways of usually placing the implants. One is subglandular, the other one is submuscular. What we are talking about today, we are going to place our implants subglandular. Usually the conventional way was to do an incision in the inframammary manifold, put in the implants. Usually would need GA, and the recovery time will be higher. We are coming with a technology that we want to do it at a local anesthesia. We want to do it without any scar on the breast. We are trying to look at it as more of a breast harmonization than a breast augmentation. That's how actually the clients themselves have looked at it as. So actually this is what we look. Now let me introduce this implant. We call it the MIA implant. The MIA implant is diamond shape. It's actually biconcave, so that what it gives you a more projection than a normal implant, which is supposed to be unipolar. This is like bipolar. On the other hand, it also gives you the ergonomics quality. If you hold it like this, it takes the shape of the teardrop, meaning that it's working like an ergonomic. Now the MIA implant comes from Motiva, and Motiva now what they have done, they have tried to make like the next gen implants. These are super silicons, and what they do with it, they put a microchip with it, which can be connected to Bluetooth, and it is easier for monitoring. The only thing you need to check with these implants, the biggest has a base diameter of 12.5 centimeter. So for a client with more than 12.5 centimeter, you may need to do something else. we have another concept. Just like MIA, using the same technology under local anesthesia, we call it preserve. Preserve, same issue, but we are going through the inframammary fold. But today we are talking about MIA, which you are going through the axilla. These are our tools. We have the, after injecting the local anesthesia, we have the channel separator. We have the balloon, which is going to create for you the space. Then you have the injector. The injector will inject the implants as we go. Usually this is for a patient who doesn't need a massive increase in volume of a breast. Moderate, like 1 or 2 bra sizes. Doesn't need a very exaggerated cleavage. This is very good for them because it serves shortly. Let's look at a small video here. Just play this video. We see how it works.
Faster recovery time and truly natural look and feel. MIA is the ultimate solution for women who have seen their breast change due to aging, fluctuation in weight, breastfeeding, or who did not see their breast developed in harmony to their body. Discover a breast harmonization experience with a breakthrough minimally invasive technology designed to be performed without the need for general anesthesia. Thanks to its convenient and gentle approach, you can be back to your everyday life on the same day. Implants used during the MIA experience are the first ever injectable biocompatible implants with a new generation diamond-shaped design, offering greater projection with the same volume. Crafted from super silicones, those implants are flexible, stretchable, and ergonomically designed to move and feel like your natural breasts, giving you natural-looking results in any position, standing, laying down, or moving, with just 3 simple steps. A small incision of approximately 2 centimeters is done and hidden in the fold of an armpit, leaving no scars on your breasts. Once the breast pocket is prepared, our patented balloon tool is inserted to gradually inflate the pocket and gently confirms the space for the implant. Native supporting tissue is preserved and breast sensitivity unaffected, helping with a quicker recovery and higher comfort. With the use of our patented injector tool, the implants are easily inserted into the pocket through the same minimal incision. Placed between the muscle and preserved breast tissue, the results look and feel like part of you. The implant's improved biocompatibility provides better foreign body response, therefore reduce pro-fibrotic complications. Now you can enjoy natural results in harmony to your body and resume your life on the same day. MIA Femtech, setting a new standard in safety, convenience, and true natural results.
Thank you very much. We can continue with our slides. Generally supposed to be, it's really marketed as a 15 minutes operation. Sorry, I'm still at 27 minutes. I'm not getting to 15. Maybe I'll get there soon. This lets you get to back. Let's proceed with the slides. Yeah, postoperative usually is not very complicated. It's to return the patient to activity as soon as possible. No special bras to be worn. And the patient is permitted to start showering on the same day, though no aerobic activities or sexual activity for 2 weeks. Follow-up visits usually on the 5th to 6th day. 6 weeks, 3 months, and just as we know, it has a microchip. We can monitor the progress, and over the phone, it doesn't need an MRI for it. Usually, as I told you, it doesn't have to be too big, no scars on the breast. And those are some few cases we've been able to do. Thank you very much. I hope we'll be able to offer this to Kenyans more. Thank you.
Thank you, Dr. Saidi, for that interesting presentation. I would like to welcome Dr. Ruth to give us a talk on multidisciplinary chest wall resection and immediate reconstruction for a giant recurrent malignant phyllodes tumor.
Good morning, everyone. I'm just waiting for the slides to be projected. Okay, I'm presenting a multidisciplinary approach to a giant recurrent malignant phyllodes tumor with heterologous liposarcomatous differentiation. My name is Ruth Kwamboka. I'm a third-year Gen Surg resident at the Aga Khan University. I'm presenting the work of Dr. Esther Gadhura, Plastics, Dr. Zenebe Teklu, Plastics, Dr. Miriam Mutebi, Breast, and Dr. Keith Dindi, Cardiothoracics. I have no conflicts of interest to declare. So malignant phyllodes tumors are generally a clinical challenge, and this is because of their inherently aggressive nature, the fact that they have an unpredictable biological behavior, and thus they present a significant oncological and reconstructive challenge. They make up about 1% of the breast neoplasms, and of the sarcomatous type, it's even rarer. So there's a spectrum between benign, borderline, and malignant. The benign ones are about 60%, the borderline are about 30%, and the malignant are about 10%. And of this 10% of the malignant subtype, less than 1% is sarcomatous. In this report, we shall describe a multidisciplinary management of an aggressive malignant phyllodes tumor. We had a 36-year-old lady who was originally from Burundi. She had initially presented in January 2025 in her home country with a progressive breast lump. Biopsy at the time was inconclusive but suggestive of a lipoma. In last year, October, she underwent surgical excision, but this year in January, she had recurrence of a rapidly progressive painless breast mass with no other breast or constitutional symptoms, and she thus self-referred to our facility. By the time she had arrived, this was in March 2026. As we can all appreciate, there was a large tumor extending from the clavicle to beyond the inframammary fold. It was attached to the underlying structures with no axillary lymphadenopathy, and the mass progressively went on to become necrotic and to have an ulcer. She was evaluated with imaging. As we can appreciate, we have CT scans, there's a scout image and an MRI. There's a large lobulated breast mass involving the underlying chest wall. MRI confirmed the above with heterogeneous enhancements and focal areas of necrosis. However, there were no nodal, visceral, skeletal metastasis. Subsequent to this, there was a second review of the previous biopsy that was done, which confirmed a malignant phyllodes with sarcomatous differentiation. We proceeded to have a multidisciplinary meeting between the breast team, plastics, oncology, and cardiothoracics. And after a passionate discussion, and much to the disdain of the surgical team, the decision was to begin with neoadjuvant chemotherapy and then subsequent surgery, which she started. However, there was chemoresistance, there was disease progression, which was evidenced by an increase in the size of the mass, and she also developed neutropenic sepsis. Secondary to this, a second MDT was held, and at this point, about 3 weeks after the first cycle of chemo, she was then scheduled for surgery. With all the teams present, she underwent an initial radical resection. The radical mastectomy was carried out by the breast team, and then there was an en-bloc chest wall resection because ribs 3 to 7 with the intervening intercostal muscles and the parietal pleura was involved. Those were resected. The total weight was about 5 kilograms, and the full thickness defect that was subsequent to this was quite large, about 30 by 25 centimeters. The cardiothoracic team proceeded to reconstruct the ribs. The mesh, the parietal pleura was reconstructed with a mesh. The ribs were reconstructed with wires that acted as a scaffold, and this was augmented by bone cement. And then the plastics team proceeded to carry out a pedicle latissimus dorsi flap to cover the soft tissue defect. The reason for the choice of an LD was because of the reliable vascular pedicle, adequate soft tissue bulk, and anatomic proximity to the defect. There was consideration for other types of flaps. We couldn't choose a DIEP because she was quite lean and did not have adequate abdominal panas. There was also consideration for a tram, but because we wanted to reduce the surgical morbidity and intraoperative time, the choice was for an LD flap. The goals for this particular case was to protect the intrathoracic contents. As you can imagine and as you will see, after resection of the tumor and the ribs, the lung and the pericardium were visible, so the goal was to reconstruct the soft tissue and to protect the intrathoracic contents and to provide durable soft tissue coverage and not really to reconstruct the breast. After this, a split thickness graft was harvested. The final pathology, it was quite a large mass. It was about 26 by 24 by 17 centimeters with an R0 status. She had an unremarkable postoperative course. The drains were progressively removed and she was discharged home on day 7. She has since been reviewed in the clinic and she's doing well. Regarding her adjuvant care, because of the high grade of the tumor, the rapid growth, and the previous recurrence, she has been offered, and she's actually currently undergoing radiotherapy, which she's tolerating well, and the graft is well healed. And subsequent imaging has confirmed no recurrence or residual disease. So in summary, from the case we learned that the malignant phylloides tumor, especially with a sarcomatous differentiation, is exceedingly rare. A multidisciplinary approach is key, and that if we can offer our patients concurrent resection and reconstruction, we will avoid the morbidities that would be involved with just chest wall and breast resection. Thank you.
Thank you, Dr. Ruth. The next presenter is Dr. Lee. He's a plastic and reconstructive surgeon. He's going to talk on a retrospective 5-year audit of the breast reconstructive service at Aga Khan.
It's not the Lee we know, but this is general surgery resident.
Good morning, everybody. I'm somewhat of an imposter. I'm not that consultant that she speaks of, but I appreciate the elevation in status. Thank you. Okay, so I'm here to present on a 5-year retrospective analysis of a breast reconstruction service at the Aga Khan University Hospital. As you can see, the other doctors contributing were Dr. Ruth, who's also on stage with me, coincidentally, Dr. Daniel, who's not within at the moment, Dr. Zenebe, who's around, as well as Dr. Gadura. Those are the reconstructive surgeons. All right, so we had a total number of about 87 cases. of which we analyzed 80 of them. 4 of them we had to knock out because of incomplete data. 3 of them had some duplicates that would not have had added much value to our analysis. But in any case, from this audit we're going to look at the patient demographics, the surgical modalities that were chosen, the postoperative complications, systemic effects as well, adjuvant oncology therapy timelines, and the impacts of the patients, the treatment on that on the chemo and the radiotherapy, as well as the evidence-based recommendations. So from our cohorts, we found that the average age was about 44 years. Yeah. And this is just, I'd like to highlight this because generally, globally, we tend to find that breast reconstructions are done in ladies who are a bit older than this, particularly in the West with an age range of about 65 to 74. The mean BMI that we'll find significant in the rest of this talk was 28.2, which is a little high. And just as a red bar that you can see over there, we have majority of the population was overweight or obese. Yeah, so that's above 25 kilograms per meter squared. Now, the whole spectrum of reconstruction, we had majority of our cases were pedicle flaps, so that comes to about 33.8%. Our 23.6 were attributed to the implant-based, and then free flaps were about 11.3%. The rest of the bar graphs you can see there were other types, so your fat grafts and the like, all contributed to the 19 cases that we have there. So some of the complications that we found. I'll start with the one that's highlighted in red, where your eye will go at first, is the hematomas. So hematomas were about 11.2%, and we put this adjacent to the global data, which, if you look at it, looks like about almost maybe almost 4 times. Yeah. Seromas were well within the range. Wound infection was fairly about the same as the global data. The flaps and the implant outcomes were fairly good, actually, where we had minimal complication rates. So our skin flap necrosis came to about 5%. Flap issues, your flap loss and our partial and our total flap losses were a little less than actually the global percentage, as well as the implant losses. Yeah. So, just as a quick dashboard screenshot, I guess, of what we've discussed so far, and the biggest issue is that from so far we've had better outcomes than our global data, even though we're looking at 80 patients, but I think it's still worth noting. And one of the issues that we have in particular is just the hematoma rate that was a little higher than normal, and I think we'll address this a little bit later. So the other complication that we can consider is the systemic issue. So our pulmonary embolism rates, they were a little bit high, came to about 7.5%. And this is particularly because, I mean, we are dealing with patients who've come in post mastectomies for breast tumors that we've had, and of course we're already dealing with already a hypercoagulable state, and then given the other complications that you'd find even post-operatively in the care, this is some of the issues that came about and we were able to see. Sorry, just if I may distract this a bit. Could you switch on the screen maybe? It's okay, I can proceed. So another issue was some of the other complications, or something that would flag as as things to monitor our ICU stays, our ICU admissions, HD admissions, blood transfusions, all those were within the global standard that you may say, or at least less. However, there's a reoperation rate highlighted at the absolute bottom. So I'd like to draw your attention to that. It comes to about 15%. Yeah, it does look like there's that we're going back to theater, and I would like us to consider this number as we look at the numbers of success. Then it needs to be interpreted in context, and I'll address this a little later. So far we've had two key issues. So we've had our hematoma rate and our PE rates that are a little higher. Yeah. The other outcomes highlighted at the bottom are what we've addressed as a much better than the global rate. And I've put a bit of a benchmark, a global benchmark there that we can compare and see. Yeah. Now, for our hematoma, we considered some of the causes as the high BMI that I had mentioned earlier. Dealing with the higher patients with higher BMIs, you tend to have that predisposition to develop the hematomas, especially post-operatively. Yeah, for various reasons as well. So the hypertensive comorbidities, we still found that some of them were about 17 out of 80 had hypertension. That's almost 20-something%. And then a multiple bilateral dissection. So when we're considering the patients who had both sides addressed surgically. One of the other things I'd like to consider now is the pulmonary embolism rates here. And like I said, we need to consider this in the context that we're dealing with oncology patients who are already in a hypercoagulable state, as well as if you consider this with if you pull them adjacent to the hematomas, we're considering a sort of paradoxical situation where we're trying to avoid thromboembolisms as we can see, and we tend to start the anticoagulation, but then we have a likelihood of actually getting our hematomas from there on, yeah, from bleeding within. Now, like I mentioned a little earlier, the reoperation rate is about 15%. Yeah, this is considering the cases where we had to go back and address the hematomas, and maybe some partial necrosis that we had to excise. But I'd like this to be interpreted in context where we had an actually really low implant loss rate, and I think maybe this 15% can be considered as a sort of salvage and a correction, and considered in the context that we were getting a better success rate from this. Yeah. A few other details now about the oncology of it is we had about 22% of the adjuvant chemotherapy patients had delays because of one reason or another. I'll highlight in the next slide. And adjuvant chemo or radiotherapy. And that calls to mind that we need to address patients' concerns a little earlier, have them spoken to way before, from the point of first contact all the way through, just so that they can better understand whatever is to come. But we'll address some of this in the recommendations. And so they are. So the first of which, the venous thromboembolisms that we've had. So we always address this. So your preoperative Caprini score assessment, our intraoperative sequential compression, as well as our low molecular weight heparin post-op, and continued until ambulation. Some of this. Additionally, there's postoperatively, I think we'd also like that proper tight BP blood pressure management, just so that we can avoid some of those rebleeds, and with our analgesia, proper antiemetics, and sometimes bowel management if necessary, maybe a lactulose or so. And lastly, just our multidisciplinary approach to the patients. So trying to track somebody like a nurse would try and track the patients all the way from presentation in the clinic and all the way through the different services up until the end. And I think those are some of the things that would help manage the patient outcomes a little better and uptakes. Yeah, so this is a quick summary of the conclusion of what we've discussed. Yeah, thank you.
Thank you very much for the very interesting presentations. We'll go to the Q&A. I can start it off, but you can raise your hands. So for the first presentation, for the small patients with less volume in the tummy, are there instances where you would retain the implant just to give the volume with the DIAP, or for all patients you'd remove the implant? For Dr. Saidi, very interesting presentation. I know Motiva has been getting a lot of airtime in the West, especially with the pre-survey, and this is quite good. I'm curious, like, what are the implant sizes, or what's the largest size you can input, and then do you have to, for patients with ptosis, would this be there because there's the severe grades of ptosis you'd need to do like a lift, and then the other point you're saying, I understood it different, but the injecting, are you just injecting the implant, or you're also adding the volume? And then, as you know, the transaxillary approach is usually so difficult, but this is good. What are some of the complications you might be anticipating? For Dr. Ruth, just curious, I know you did it, but maybe for the audience, how you are checking the margins intra-op, and then very great retrospective analysis from Aga Khan. One thing I know that most of us would not check for our breast patients would be BMI, but that's interesting. And if there is anything that would point to increased complications, and then do you give thromboprophylaxis to all, both autologous and implant-based reconstruction? And then for the hematomas, are they more in the autologous or the implant-based reconstruction? Oh, okay.
I think those were good presentations. My questions are, Dr. Saidi, maybe you could comment on the cost of this implant vis-a-vis what we have in the market. And secondly, where do you place the implant? In which pocket are you using? Is it submuscular or subglandular or whichever? And what complications have you encountered this far? Then for Dr. Ruth, you said you use a mesh for the pleural lining. I'm just curious to know what kind of mesh you used, and if you're worried about fistulation, because in literature, one of the disliking of mesh is that you are prone to pleural fistula formation as the lung wraps on the mesh. And then for Dr. Lee, your retrospective analysis is good, but I don't know if I missed out whether you looked at whether the reconstruction was immediate or delayed, and if you have data, it would be very interesting for us to know whether the complication rates were similar or were different in both categories of reconstruction. Thank you.
Thank you, all the presenters. My question goes to the first presenter. Are there any other options of autologous reconstruction that will offer patients who don't have an option of DIP? Maybe there's a previous surgery that you have been done before, or rather they are too lean, or in one way or another you don't have DIP as an option.
Thank you to all presenters. Those were very interesting topics. My question goes to Dr. Saidi. Actually, I think I might have a few. So what are the inclusion and exclusion criteria that you use for these patients, and how much existing breast tissue is required before you put in these implants? Then to piggyback on what Dr. Laura and Professor Nangole were asking, since the pocket creation is performed without direct visualization, how do you detect and manage bleeding, asymmetry, or early malposition? And can migration happen along the existing created channel because it's through the transaxillary? And can you do a revision through the same incision site? Thank you.
Okay, so I'll start. Thank you both very much for your question. So regarding the first question, of course we are not like against the combined use of implants and flaps. So usually like in this cluster of patients I show in the presentation, they all had problems with the implants. So they already know they don't want implants anymore. And in Italy now is being like, also thanks to the work of Dr. Cristina, there's quite an awareness of the autologous reconstruction. So there are, even 10 years ago was not like that, but now many patients already came at you asking specifically for autologous reconstruction. If it's not the case, of course it's possible to combine the two options. Usually maybe we do if there are like some problem in the skin that you have to cover the skin with a skin paddle, maybe with pedicle, LD, and then an implant, in something that we do. But of course, even us, if we have to cover with a flap, even if the volume is not enough, we also try to propose some alternative to put an implant, like to have seriate fat graft injection, because of course one of the main advantages of the autologous reconstruction is that it's almost definitive. You don't have to take care of the implants that, you know, every, if it's good, 10, 15 years, you have to change. So if you're going for autologous reconstruction, we try to do it entirely autologous, but in some cases, yeah, of course, we're not against putting the implants to have some volume, and sometimes the patient have no problem with that, and we do it, of course. Regarding the second question, of course, so DIP for breast reconstruction is now, for the free flap reconstruction, is our workhorse, so is our main choice. Of course, it's not always possible, depending also on the size of the breast. We can have like the PAP, which is a very, very good one because they leave a almost invisible scar. Little less volume, but is a very cool option. Then of course there are all the options not with the free flap, so with the tram, VRAM, there are many. I would say that the vast majority in my practice, I don't know with Dr. Cristina, but I think too, even with her, is DIP. It's like usually our first choice, but of course there are many other. I think the one is the PAP, and otherwise maybe some pedicle option with VRAM or LD. Thank you very much.
Yeah, thank you very much for your questions. First of all, I just started doing this 3 months ago. So in my series, I actually have only 4 patients for this. though my trainers have had a lot. But it's a very simple thing. Once the tumescence is injected through after the marking, the tumescence is injected through transaxillary route. We use a small cannula, just like a lipo cannula, small cannula, to infiltrate within the area. Then we make the 2 centimeter incision. Then we use a channel separator to go subglandular. We are coming above the muscle, behind the gland. So you're going subglandular. You can feel there's an area you feel actually a pop when you're going in subglandular, avoiding the muscle. Once you put the channel separator, then you remove it and put the balloon as was being shown in the video. You infiltrate the balloon. Once you infiltrate the balloon, then you take the gun, the Mia gun, and actually fire the implant into the system. Actually, it's very painless. From my 4 patients, only 1 required sedation because of anxiety, but there was actually no pain as such. These implants are not very big. For Mia, the severe ptosis, Mia and Preserve, actually these are exclusion criteria for severe ptosis. For mild ptosis, yes. The biggest Mia is 325 cc's, 265 cc. With that, and that is a base diameter of around 10.5 centimeters. If you want to go a little bit higher than that, so we use Preserve. Preserve, now we make the incision on the submammary, whatever space, whatever. When you make same 2 centimeter, but this one you can go up to 325 centimeters. If you need the volumes above that nerve, then you have to go to the other Motiva implants. Sorry, I can't remember the other thing. The 4 patients I have so far, none has come back with a hematoma or anything else, because it's really straightforward. They get back to their activity as soon as possible. Cost, I don't think I'm going to discuss it there. Yeah, maybe I'll talk to you after that. Yeah, because in Africa we are the only ones doing it. We are the only one actually licensed to do in Africa. So at the moment the costs are a bit high. So Dr.
Migration of the implants.
Yeah, as I said, my series I've got only 4 patients, 3 months only. So not yet had any complication to talk about so far.
Okay.
But from my literature, from my teachers who have trained me, they don't have these issues.
And the monitoring, are you able to detect BILCL early?
Yeah, you see, with the good, if you see the new technology in Motiva, with the super silicons, all this is to try and reduce all these complications related to that. Then with this monitoring, yes, you'll be able to monitor these changes that occur during with breast implants. I'm not trying to promote Motiva, but that is what now I'm using at the moment.
But you can also detect capsular contractile.
Yes. Okay. Because of now the microchip, now all those you'll be able to monitor instead of doing an MRI.
Okay.
Yeah.
Okay, so thank you for the questions. The first question about how we confirm the negative margins, first clinically and just by inspection. But secondly as well, we used frozen section. So there was a pathologist who was also at the same time reviewing the specimens, and they did inform us that the posterior margin was a bit close, and so additional margins were taken out, and finally it was at least 1 centimeter all around. Regarding the type of mesh that was used, we used a Gore-Tex mesh, which is a PTFE, and it's been shown to be airtight and watertight and to have a smooth surface to reduce the chemical reaction that would cause fistulae. But I can also ask Dr. Gadhura to comment.
Answer as we get to have the mic.
Okay, so 3 questions. I was asked about the thromboprophylaxis to all. Yes, unless there is a gross contraindication, ordinarily, but in likely those cases, you wouldn't have them going through to have a reconstruction at that moment, maybe your thrombocytopenias and the like. But other than that, we do actually give them thromboprophylaxis. So hematomas for the implants versus the autologous, I think from what we looked at, we had more of them actually with the autologous flaps. Yeah, I'd need to look at the specific numbers and then let you know, but it was more, I know for sure it was more than more in the autologous flaps. And then to Prof's question about the immediate versus delayed complication rates, most of this data was about the immediate ones. I think for the delayed we had maybe less than 10, significantly less than 10, but other than that, I think the cases were for the immediate reconstructions. I don't think it would be a fair comparison to say that these ones had, like the delayed had more complications than the immediate ones, given the absolute discrepancy in the numbers. But if you were to look at the hard data, then of course our complication rates would look a little more with the immediate ones, particularly because we had more numbers. Thanks.
Just a comment to support Ruth. We used Gore-Tex, but I must also add the thoracic surgeon was, we did it in a truly multidisciplinary fashion. So we discussed the reconstruction and what we would use. And he reliably informed us that the Gore-Tex mesh is quite reliable. We're obviously following up the patient. They've just completed their radiotherapy. No complications yet, but truly we do anticipate we might need to go in and especially do something about her contour, because you can literally see her heart through the LD flap. So we might need to do something, but for now, the main goal was her oncological treatment. Thanks.
Any other question? Maybe I'm curious, how long do you give the thromboprophylaxis for? And as other questions come up, some comments.
All right, so ordinarily we start, once the patient comes in, we score them with score, see if they would need particularly mechanical or the chemical thromboprophylaxis. And then from there on, up until they're able to fully ambulate and actually leave the hospital, that's when we discontinue our thromboprophylaxis. Yeah.
Any more questions? Okay. Thank you very much for the interesting presentations. I hope you enjoyed. And so we will take a photo and give certificates as Sagifam prepares. We're still waiting for the certificates, but you can enjoy our view on stage. Just curious, by a show of hands, how many people give thromboprophylaxis after breast surgery? How many people give no thromboprophylaxis after implant surgery? How many people don't do anything? Okay. later. So I want to welcome Sagifam for our sponsor, who are our sponsors, to give a short presentation before we start the main session.
Thank you. Yes, hello everyone. My name is Nicholas Mwema from Sagifam Limited, BSN principal. Today I want to share with you something called Sobact, QT-Med Sobact. It's a novel product that uses physical mode of action in binding bacteria. And with binding bacteria does not kill the bacteria, releasing endotoxins, which in turn lessens the time for healing. It's made up of DAC technology, DAC being dialkyl carbamide chloride, which is a fatty acid derivative. Through hydrophobic interactions, it binds bacteria, removes bacteria, and there's no endotoxin, none whatsoever. Some of the products we have, the range we have, we have our mesh for any, it is very versatile. It can be used for any wound type, for burns, for any donor sites. It's very versatile, even for venous leg ulcers, diabetic feet, all that. The benefit about using Sobact is that it does not bring about any it does not bring about any resistance, because it just breaks. It does not break the cell wall. It just attracts the bacteria, removes it, like a plug and play mechanism. It also has minimum. It can be used for a long time because it does not produce any cytotoxic effect through the skin, where it can discolor the skin, and also. It can be used from children, breastfeeding mothers, yes, exactly. Now also we have something called Sobact pad, which has a very high, it can absorb up to 375 ml of exudate for all highly exuding wounds, and it can stay up to 7 days, attracting bacteria and removing. So we have a bigger version of it, which is 10 by 20, this size. And also we have products that also help in giving any dry wound some moisture. If it's dry, necrotic, you can place a product with hydrogel. It will give the wound some moisture where you can debride, clearing the slough with no pain whatsoever. I don't know, by show of hand, anybody who is here been using Sobact? Oh, wonderful, wonderful, wonderful. Now I'll introduce Dan Okoth from Kenyatta National Hospital. He has very good experience in using Sobact, and some of the pictures you'll be seeing, it's all by his own studies. We have not sponsored anything to him. It's just his passion of taking care of patients and documenting what he sees. Thank you, Dan Karibu. Any questions on Sobact so far? No, okay, thank you.
Good morning, everyone. I would wish to kind of share my experience with all of us. With regards to the use of Sobact, it's a personal experience, and I've used it on different wounds, and I think probably maybe one or two things can be picked from that. Now, my first picture, this is a degloving injury. A lady about 48 years old was run over by a truck. The truck driver was told to foot the bill for care of the foot. So being that he didn't have insurance, it was a bit hard for them to go to a hospital. So that was the journey. That was within about 2.5 months. I was done with the foot. The next one, this is a chronic venous ulcer, a lady about 70 years old, had even gone up to the US for treatment. This is also a wound that she's had for, this is the 17th year. So far, that is how far I've come using one of these products without any other. That is a radiation therapy wound. A patient had cancer of the cervix. While undergoing radiotherapy, she developed a wound on the sacral area. While doing a follow-up, we discovered that it was a case of radiotherapy burn. That one, I think, took me about 4.5 months to get there. This is a diabetic foot following an amputation, disarticulation. Also started developing necrosis. That was the journey. 1.5 months I was done. This is a breast cancer patient. That is a pre and post application. I saw her after about 4 days of applying a Sobac gel. The wound was quite clean. Unfortunately, I lost this patient. And again, this is a diabetic hand wound. They are quite rare. So in this case, I had this patient who had a diabetic hand wound. They refused to go to hospital because when they went to some facility, they were told that she'd had to go to undergo an amputation at the wrist joint. So I tried my best to salvage whatever I could, and over time, this has taken me about 4 months. That's where we are. The last one is a traumatic hand wound. This patient was a driver. He took his employer for a trip somewhere. He was abducted, restrained. So basically, this was his right hand. The first picture shows the trauma that he had after he was restrained, because when he was restrained, he was kind of tortured for about 4 days, and then he was thrown into a bush somewhere. Some herdsman found him and then helped him get back to Nairobi. He was in northeastern province. So that is the journey. At the beginning, it was necrotic, and then slowly the debridement took place up to a point when it was completely healed. This is it's a 2 months episode. Then that is his left hand, also was quite traumatic, very necrotic. I used Sobac gel and Sobac Sobion. This is the journey we took. So far, I think the last picture speaks for itself. That's the right hand and the left hand. By now, I think I'm done with him. That was the last picture I saw. That was the last picture for, I think, about 7 days ago. Thank you. And I declare no conflict of interest. These are just personal things I decided to share with all of us. It's just a journey. Thank you.
Yes, thank you very much. Any questions for them? All right. Oh, okay, yes. You're actually my namesake, so.
Thank you, Dr. With regard to Sobac, I don't have that much experience except for the sheets, which are used for only superficial wounds with superficial burns, and maybe where I've taken skin grafts. I was out in the nice room. I don't know what were you using to treat those ones, because those are full thickness, and the last one I saw tendons exposed. And what was your reason delaying treating that cancer patient, treating her conservatively? Was it because no resources, or it was not operable, or what? Why? Because I don't think with such, if you just have to remove the cancer, you don't gain anything by trying to dress the wound on the breast.
Thank you for that question. For example, about the breast, the wound had started showing slough. So I wanted to remove the sloughy tissue. It was not that much that I could resort to other options, for example, maggot therapy or something. So I tried Sobact gel, which fortunately worked very well. It was a surprise to me also, so I kind of had to document it. And then for the deep wounds, I've been using the Sobact Sobion, the one that is padded. For me, with a little gel, it has worked wonders.
Any other question? Thank you. Thank you very much. Please clap for the previous presenters. Thank you, and we are going on to now our celebration for 20 years, and I would like Dr. Mukami to come over and take over. You can stretch as... Oh, sorry, the previous presenters, if you can come on stage. We finally found your certificate. Yeah. Thank you. That was Dr. Legado. She's the president. One of our presidents here, you will know in a few minutes. Dr. Mukami, you guys can stretch. Then we go on to the next session.
Good afternoon. So we are here to officially commemorate KSPRAS at 20. So I'll start it off by giving some introductory remarks by calling the big fish. So my name is Dr. Mukami Gadareki, and I am the chair of the organizing committee. I also feel like I am one of the younger plastic surgeons in the room. And also being the chair of the organizing committee, I feel like I've spent the last few months feeling like a junior in the presence of some of the people, great people here this afternoon. So if I sound a little bit too excited, please forgive me. Because this is a big deal. KSPRAS is 20 years. For anyone who has known our history or the history of plastic surgery in Kenya, they'll understand why it's a big deal. So on 10th October 2006, a small group of Kenyan plastic surgeons decided that Kenya needs our own professional home, a society that would push for proper standards, proper training, and proper care for our patients. So they registered KSPRAS. And here we are 2 decades later, still standing, still growing, and slightly obsessed with making people whole again. I was not there at the beginning. I was somewhere doing something. Some of you in this room were. And we are here to honor you today. You are the ones operating when the specialty was still small, when training programs did not even exist, and when plastic surgery in Kenya was something many people only associated with heavier pockets or with medical tourism abroad. You built the foundation we now stand on. And what a foundation it is. Look at what has happened. We now have a proper Master of Medicine program training, plastic surgeons right here in Kenya, and not just for Kenya. We have colleagues from East, West, Central, and Southern Africa who have come through that program. We have grown from a handful of specialists to more than 30 registered plastic surgeons, with even more coming through. That is not accidental. That is the result of deliberate hard work by people who refused to accept that our patients should have to wait or travel for care that we could learn to provide ourselves. And then there are the camps, the cleft camps that have taken our members to Kakamega, Kapenguria, Garissa, Meru, Homa Bay, and so many other places. Hundreds of children and adults whose faces and futures were changed. Over 1,000 operations through that partnership alone with Smile Train, one smile at a time, that phrase which still hits differently when you have actually been in those theaters. As one of the younger surgeons, I look at all of that and I feel 2 things at once: deep respect and a healthy amount of pressure. Because the next 20 years are on us. We are celebrating today because 20 years is long enough to prove that the original idea was solid. But it is also short enough that many of the people who started this are still here, still teaching, still operating, still calling us out when we need to do better. Now that is a gift. We are also celebrating because plastic surgery in Kenya has come of age. Reconstructive work that restores function and dignity, aesthetic work that is done properly and safely, microsurgery that is no longer a distant dream, but something we are actively building. And a society that is willing to speak up when patient safety is at risk, because we all have seen what happens when standards are ignored. So why does this moment feel special to me as chair of the organizing committee this year when we're celebrating 20 years? because this conference is not just another meeting, it is our 20th birthday party with a scientific program attached. So we chose honoring past directions in African microsurgery because we wanted to look back with gratitude, immense gratitude to those who stood before us and look forward with ambition, especially in the areas that will define the next generation of us. Here is my honest ask to everyone in this room, especially to those who we are in the same cohort. Let's take our work seriously. Let's keep the standards high. Let's keep learning. Let's keep for the outreach camps coming in us, and keep remembering that the real measure of this society is not how many conferences we hold or how many members we have. It is how many patients that leave our care better than they found us. To the founders and the senior, thank you. You made space for us, you trained us, put us, and slight enthusiastic ideas. We see you, thank you. To the partners, hospital that host our camps and our trainees, we thank you for working with us. And to every member of KSPRAS, full members, associate, everybody, the past, the present, and those still in training. Happy 20th anniversary. Here's to the next 20 years. May they be even more skilled, more accessible, more equal, and just as full of purpose. Asanteni. As KSPRAS, we just don't operate by ourselves. We have the Wound Care Society of Kenya, and we have the Burn Society. So I'll take this opportunity to invite Dr. Luegado to say something. Karibu Daktari.
Thank you, Daktari, for welcoming me. I'm Dr. Luegado, the current president of the Wound Care Society of Kenya. Just like he has said, we are a branch of KSPRAS. Today, I will not talk much, but I will introduce Dr. Lee, who has a short presentation to talk about Wound Care Societies of Kenya, who we are, and what we do. Thank you very much.
Good afternoon. It's an honor to be before you, and also just to highlight about Wound Care Society of Kenya. I think from a lot of what has come out from the start yesterday, what has really plagued us a lot is the burden of wound care in the country, and even the resultant gap, because wounds cut across the various demographics, the various people who are involved in the care of the wounds, from the doctors to the nurses, and even to even other specialities at large. So, can you do the next slide, kindly? So, it's always important to honor our past and honor the people who
who have been key in initiating and being presetters. So even in this regard, I'd like just to, first of all, maybe many of you don't know, the late Dr. Odi Tanga was the first president of the Wound Care Society of Kenya. And I think something that Prof. Nangole always highlights is something that the late Dr. Tanga would always talk about, and he would say, I've been sent by God to elevate the pains and suffering of patients with wounds, and their cries have been heard. And so it should be with us. Those who don't learn from history are doomed to repeat it. But history isn't, it shouldn't be considered and its mistakes damning. There are histories that need repeating for inspiration. So, so the Wound Care Society was conceptualized in 2012 in a meeting in Nairobi, Upper Hill, by Prof. Kainga, Prof. Nangole, the late Dr. Odi Tanga, Eric Ragano, and at the time, but now consultant plastic surgeons, Dr. Biribo and Dr. Anjiru. So it was registered and began its operations in 2014 and began outreach camps. And these outreach camps have been all over the country. We've been to Kitui, Malindi, Homa Bay, Nyeri, Nakuru, Kisumu, and Nairobi, just to name a few. So major milestones, because generally you gauge your growth by milestones. Even for any venture, there are milestones that you want to highlight, so that you know your trajectory as you grow is in the right direction. So we've had the launch of the Wound Care textbook under the leadership of Prof. Nangole, and our wound care books are really on sale, and I would actually encourage if you can grab a copy, and even grab a copy for a friend. So we've also done annual symposiums in various regions in the country. The latest we've had is in March, this year in Nairobi, and the one prior was in Eldoret, so we generally try and have them all over the country. A very key milestone was the nationwide cross-sectional study we did on epidemiological patterns of wounds in Kenya. We also carry out 1 month online continuous education CMEs, which target the various professions involved in wound care. So these are wound care, just a photograph of our wound care textbook, and this was the launch of our wound care textbook. So our goals, and again, that's very important, because as much as you are growing, you also want to have endpoints and objectives to what you're doing. So one of our goals has been to create partnerships with institutions and organizations to improve wound care in the country, and institutions have been universities. There are some universities that have approached us either to partner in the education process, one being Mount Kenya University, the institutions such as Roy Family Hospital, who've also approached us for training for the nurses they have in their program, and even diverse organizations. But all these we do under the patronage of Kenya Society of Plastic Surgeons, because we wouldn't be who we are and where we are without them.
Then we also train and empower healthcare workers through the various areas that I highlighted earlier. Then also investing in research and possible local solutions. So this was one of our very landmark studies, and I would encourage it's available online. So this was our last wound care training we had in Eldoret. It was very successful. I think we had around 106 participants, and they came from all over the country. So thank you. Mine is a short presentation, but in keeping in line with honoring the past, charting the future directions in African microsurgery. Thank you.
Thank you so much, Lee, and also for keeping time. On behalf of BSK, Burn Society of Kenya, I'll invite Dr. Wabwire. Dr. Wabwire also carries another title. I hope he'll tell us about it. I know you might not, but please.
Thank you, Dr. Mukami, our conference chair. So, as you've heard, my name is Benjamin Wabwire, and currently the president of the Burn Society of Kenya. Initially, we had planned to have this, what I was being asked to do on yesterday, when we had two presentations from Jose, who is a burn survivor, and Matthew did a presentation on acute burn management. So I was not supposed to come and give you a slide talk like Lee has done. Mine was just to make remarks for today. So I'll probably do that and in a couple of minutes. So other than being the president of the Burn Society of Kenya, I also happen to be the president of the Pan-African Burn Society and the African region representative to the International Society for Burn Injuries. And on that note, I wish to invite you, if you can make it slightly over a month now, to go. We have a conference in Chile, in Santiago, from 11th of October. It is far, but I think you can make it. And for Catherine and people from US, it is only one flight away, so I hope to see you there. Now, back to Burn Society of Kenya. So, just like Wound Care Society, it was branched off from the Kenya Society of Plastic, Reconstructive and Aesthetic Surgeons, and has had past leadership, including Dr. Kahuro, who didn't manage to come. Dr. Saidi is the immediate former chair and our president, and before that we had Dr. Adan and a few others. Our activities have centered around burn education, so we've had regional CPD education events in the counties. This year we've not had one. Last year we were in Mombasa. And then in addition to that, we've had the emergency management for severe burn injuries course, which we usually run concurrent with those regional CPD events. We've also been involved in fire prevention activities and burn prevention, which the burn survivors shared about yesterday, and we do that on an annual basis. This activity has been picked up on the global stage, and this year we shall be having a World Burns Week the first week of November. There will be activities that will be coming up, and we shall be posting them online for you to keep track so that you get involved. Our bigger headache is on public policy and lobbying. Most of us, particularly Kenyans, you're aware, for example, the school tragedy we had in Gilgil the other day, and last year it was in Andrasha. So we still have those gaps where we need to find space with the policymakers at the Ministry of Health, Ministry of Education, the public housing, and all that, so that we can have a national policy that addresses fire safety and burn prevention in public institutions, and in particularly the lower income settlement areas where people are crowded and burns are frequent or common. So it's an area that we are working on. We have someone at the ministry at least who is willing to collaborate with us on that, and it's an area we shall be pursuing. And the last bit I want to say is that we also privileged as BSK to be the host of the Pan-African Burn Society Secretariat from last year. So we have set up office, we are working on the websites and all that, and we're going to have, for example, the websites available in English, Swahili, and French. One of our young doctors is helping us on that front, who is very good in IT, and we shall be looking forward to having all that set up for the continent and for the international stage. So I welcome all of us to join hands from KSPRAS and from OneCare. We support each other from all ends in making our country safe from burns. So thank you very much for your attention, and back to Dr. Mkami.
You can have a seat. Thank you so much, Dr. Wabwire, on behalf of the Burn Society of Kenya. Next, I want to introduce someone to come and give us a talk. We have had very good support from international faculty who have really helped enrich the society. And Professor Kenneth Segwapa is one of them, who has helped us, especially with the residents. He will be giving us something, the journey he has seen us through, some insights, and maybe what we can do better. I know we can always be better. Karibu Daktari.
Good afternoon, colleagues. Once again, I'm really humbled to be here, and you've given me the privilege. So when Madam started talking, I said, there goes my talk. But now she didn't have slides, so I said, no, it's an advantage. Just to make sure, timekeeper, the red light, I have 20 minutes. Prof. Kanja is not here, I have 40. I'm joking. Right, can we have my slides, please? So I decided to talk about the caption of today, of this weekend, which is honoring the past and chartering future directions for plastic surgery. I will look at different things like origins, where we are now and where we are going, because we cannot talk about where we are going if we don't know where we come from. Is it possible that I could see my notes? Not that I need them, but if they are there. But let's proceed. I'll proceed here. Okay. Right, so my outline basically will look at the world as a whole and look at Africa in respect of microsurgery, and then look at the KSPRAS for 20 years of excellence that they've done. I mean, we've had good presentations these past 2 days. I'm really, really impressed by the quality of presentations we've had. We'll then look at the MMed course that is given by the University of Nairobi. We'll look at current status and challenges, and we'll see what we can do for the future. Right, the history of microsurgery doesn't start now. It started in the ancient before Christ era. It was some of these were discussed yesterday. Even residents got a question on one of these. So I'll quickly just run through it, because it started with reconstruction. Now magnification is taking place. That's when we do our microsurgery and super microsurgery. From the South African perspective, Jack Penn and Norman Peterson were actually trained during the wartime. Those are the first people to introduce plastic surgery to South Africa. But officially, in 1940, James Cuthbert established a training unit in the University of Witwatersrand, and the rest followed. The guys who you see there in the picture basically are the first guys of our association. The founding fathers of this, you cannot talk about plastic surgery without talking about Gillis. I'm not going to waste time on him because yesterday we talked about him. I'm going to just talk about what Africa has achieved on groundbreaking first. In 1940, there's actually in Kenya, there's a surgeon who came back in 1975. He was the first local plastic surgeon who actually was recognized in Kenya. I just forgot his name, but it will come up. In 1940 in Johannesburg, that's when we had our plastic training unit. And then UCT followed in 1950, Pretoria, Stellenbosch. Because us people of colors were excluded, Medunza, which is the Medical University of South Africa, was developed for that. It was just for us people of color. So Medunza actually has three names. When I trained, it was called Medunza in the 80s. Then I went there, became a GP for a very long time. I went back. When I went back, it was University of Limpopo, Medunza campus. That's when I was training. Now I'm heading the department is called Sefak Mahatu Health Sciences University. So those three names represent one. It's not different things. Right. KSPRAS was founded in 2006 on the 10th of, I think it's November. This is the first nationally organized plastic surgery society. And then Kenyatta National Hospital in Nairobi had its first hand and foot implantation in the sub-Saharan Africa. I must mention a disclaimer, all this information I got from the web. If I don't call out your name or have gotten something wrong, please don't kill me, don't kill the messenger. Right. And then where in Nairobi, things are happening. It's at, I don't know how to call this name, Kapsoa. What is it called? Kapsoa. There is happening, things are really going. Rural free flap programs, they have 94.7% flap survival rate. And then of course, you guys had the first African-led microsurgery training courses. Right. Can we move? Okay. Now, there are predecessors that we need to mention. There's a picture of some of them there. Our dearly departed Oditanga, may his soul rest in peace, is one of them. Please, if your name is not here, it's not that you didn't contribute, you were there, it's just that it's a lot of, you did a lot of good. So I'm just going to run through a few, and then we proceed. Dr. Lambia is one of the first plastic in Kenya. I'm not sure if I should be including him here because apparently he was for the only rich. Those who couldn't afford to go to him. So I'm not sure if he belongs. But we have this guy, Dr. Professor Stanley Omide Kainga. I knew him when he came to do his fellowship. I was still training at that time at our university then called Medinsa. This is regarded in Kenya as the father of plastic surgery, because he really, after leaving us there with his fellowship and his certificate in microsurgery, he had only one thing in his head: I am going to develop my country, I am going to make sure there is a plastic surgery, and indeed, he did have the plastic surgery department. We cannot talk about plastic surgery. He's there on the poster. Dr. Wanjeri, a very nice guy, also has been with us since the beginning. He's one of the first presidents of the association. Next, the warrior, our Adam, Dr. Adam. He also came to Medinsa, where he did his fellowship, and also the microsurgery. And I think there's some of the works that he did on genital mutilation here back home in Kenya. Now leadership, the current leadership, the president, Dr. Professor Abari, Professor Mangolo. This is the current president. He is said to have written 60 or more peer-reviewed papers. He has observed and supervised more than 30 med students, and he said to have established the microvascular surgery at University of Nairobi and leading major Kenyan procedures, including national conjoint twin separation. And of course, we're not forgetting all the work that you guys are doing for the cleft lip and cleft palate children all over the country. Right? So there's many other, right? They are there in the middle. If you look there in purple, most of you have tried to write, but now my notes are not there. I can't read it out. But you are there, we know about you, right? This is the only photo I could find. So in the middle, the light colored is a good friend of mine and colleague. I think you all know him, Professor Zalache. Right. South Africa also played a role, especially in the form of me and Soli. I'm not going to go into that, but I'll just talk about the Professor. We actually came here, we were doing the Professor Pratt program. Where is the program now? That program, we used to do a lot of work that time. Reconstruction, clefts, free flaps, all that. One misses those time. But Professor Mangole, he did his training again here, and then we went to UCT, where he did his fellowship, and then he did, I think he was the first one to write IBOPRAS in Africa, then they now recognizing it, and he did a lot of training, and now he's the current president of the organization. Now let's look at KSPRAS, which was registered on the 10th of November 2006 with certain ideas in hand. They've operated so far over 30 small children with problems with cleft lip and cleft palate. This association or this society was built around standards and service on the 10th of November, like I've said. Their mission really, they have standards, which is leadership in standards of clinical care in plastic surgery. Their vision, training, ethics, practice, research, and I think Professor is really, I was impressed with his love for research yesterday. I think I will phone you from South Africa to help my department because nobody wants to do anything. There's a lot of things we could do. But point registrars are nothing more. I don't know, Professor, if you have the same problem here. We have material, but people don't want to write. But I'll contact you, Professor, and then maybe do something. But I was really impressed. Keep the good work up, Professor. Right. Service and safety is one of the standards, okay? Because they want their doctors to work in accredited facilities. Right? They cannot be working in facilities. Then, like I said, there's over 300 patients operated through KSPRAS with Smile, Train and other collaborations. Right, this is the mission and structure again. 20 years, 60 publications, 3,000. The ratio of plastic surgeons to the population that I currently got, it was previously 1 to 6, but I think the latest is 1 plastic surgeon to 3 million Kenyans, which is way above what the World Health Organization suggests that should be at least 1 plastic surgeon to 100,000 residents or people. Right. This is just how the KSPRAS moved from 2006 to now. They were registered in 2006. They had their first conference in 2008. Then 2011, Smile. Then KSPRAS, Professor, 2013, 2015. They did the first hand implant in sub-Saharan Africa, and then microsurgery 2017, lymphedema program 2019, 2022. They had their symposium in Nakuru with orthopedics, and then today we are celebrating that milestone, and I'm really blessed to be part of that. This is actually the heart of my, this is what I like. I like education and teaching. Right, so we're going to talk about MMed. This MMed, like I said, was started by Professor Kainga. It's a 5-year program. Somewhere in the, because I was involved with the exams, I know it was a 5-year program last week. So if you go online, they'll tell you 4 years. So I hope to change it. Yeah, it's 4 years. So I hope to change it. So year 1 is a third surgical foundation. Year 2, trauma and clinical, including ICU, I believe. And then 3, 4, 5, you are doing core plastic surgery. This is a little bit different with us. You only come into year 1 if you have those 2 years. If you don't have them, we don't accept you. Right, but this is a robust, well-built curriculum. Right, so let's have a look a little bit at this program, Nairobi. Overview, 1967, University of Nairobi Department of Surgery was established at Kenyatta National Hospital. And then 75, first formal postgraduate MMed was done in general surgery. Anti-plastic surgery was nowhere to be found. And then early 2000s, dedicated MMed in PRS was then, that's when Prof. Kawinga established formal training. And we think the first graduate, one of them is my friend, Dr. Peter Birubwa, who also came to our unit to do his microsurgery. Right. South Africa, like I said, we've got at least us, and we are sort of married to KSPRAS because we exchange ideas. Us, we are PRASA, we are the longest established in the continent, right? And then, also, we run in tandem with our college, which is CSMA. I know now, I think you're also working with COSEXA, which is great. Right. So let's look at Kenya. Dr. Peter Birubwa, can see me. He came to us, he did his microsurgery certification. Even Senton Masitra MMed certification in aviation medicine in Pretoria. Then COSEXA and our college, there's also collaboration there. Then when I read the microsurgery workshop, it was started by KSPRAS and in collaboration with SA3 microsurgeons as co-international faculty. And then we've got a dual pathway, especially where we have a fellowship and an MMed in a form of qualification. What is our current status? Our achievements, our outcomes? We can look at good things. Let's look at also at what we could do to improve and be better in the future. Right. At the moment, when it comes to microsurgery, what I found in public is there's about 89% survival of flaps, and then, but like I said, KSPRAS is, their flaps are surviving much better than the national count, right? Reconstructive surgeon population, we are one, it's not 10 million, it should be 1 to 3 million now. And then our salvage rate of flaps also has a bit of a problem, and that has to be looked at, and we need to look at what could be the causes. And when it comes to cleft lip and cleft palate, please continue doing the good job. More than 300, I think more of those are done. If I'm not wrong, we've got 41 plastic surgeons now in Kenya with a population of about 53 million. So what it says, it means one plastic surgeon into 1.3 million people. This is an approximate, all right? So we need to look why do we have that, because sometimes we have plastic surgeons who qualify here, they go to the neighboring countries, which we welcome, but we need to look at the redistribution, retention, public posts if they are available, and then capacitating ourselves, and not just counting heads. Right? So this is just some of the work I got. I think you will see some of your names because these citations are yours. The pre-reconstructive outcomes for microsurgery, flap salvage was at 45%, complications 51, survival 89. But like I said, KSPRAS is way much better than, right, sorry, let me see where I am. Right. So we should not count, but I think I jumped another slide. Okay, it's fine. So we should just not count how many plastic surgeons we have. We need to have access. I think somebody was talking that the ministry has to come in, they have to talk to them, how they will. I think this one doctor who was saying they don't have resources and all that, and then this is where now we need to engage the government, we need to engage politicians, and they need to come in and help us make sure that the future for plastic and microsurgery is bright for Kenya. Right. So there's threefold evidence, I've already talked about it. There's a 94% in capsule, 89 in the academic series that I have at Kenyatta National Hospital, but the continental benchmark is about 89%. Like I said, SOA shows you what can a rural, this can be done. It's in a rural area, and look at the capacity and what they do. 19 free flaps, 17 patients, 94.7 rate of flaps working properly with no problem. Well, the problem is costs. I mustn't say there's no problem. You can see the cost there, estimated costs. We need to bring private sector and government so that they can help us. Right, what are some of the challenges that I came across is the workforce shortage. Like I said, we have one plastic surgeon per 1.3 million, whilst we recommend one in 100,000. And then sub-Saharan Africa, if you look at it, there's actually one plastic surgeon to 10 million people. 41% of COSEXA surgeons have no training in microsurgery at all, right? Another thing is equipment and infrastructure. If we can improve on these are some of the limiting factors that why we don't proceed as we want to. Training gaps, right? 49% of training only manages 1 to 10 microsurgery cases per year. We shouldn't be there, we shouldn't be doing more. Salvage rate is low. It's actually very high. 45% versus 64%. But it's because of the resource issues, I think. And then another thing problem is, I don't know, in my area, we don't have sufficient cadaveric labs and simulations for us to proceed and do the good work that you guys are doing. Another thing is bring people you train and then they leave, right? Of course, systematic and finance. We all have talked about it in the course of this presentation. I'm going to run through. I've got 3 minutes. I have a video that I wanted to play yesterday, but for some reason the goals were not on my side. What surgeons want, especially microsurgery, is there was a survey that was done, right? 32 responded, and this is how they responded. Was support staff inadequate? They said yes. There's no support, so you guys need support staff, right? 1 to 10 cases per year, 44% said yes, they do that. I think we need to do more. No cases in 5 years, 45% they haven't done. And then essentials, 95.7%. So 91% actually identified that there was inadequate support from both management and I think government and private sector. What are our future directions in microsurgery? I think there was a study on smartphones in, I think it's Ethiopia. So that is a part that we can do. Artificial intelligence, AI, I think I've seen most of the presentation, we all do them with AI. And then 3D printing is something that is coming. We know we are in a low resourced areas, but these are something that we need to aim at, and if money is there, we need to do that. Indocene green, I think if you do microsurgery, you need to have this in your unit. And then, of course, robotics is a luxury for us here in Africa. And then, of course, super microsurgery, I think some of us are already doing this with the lymphatics. Right. So we must match the technology to the evidence that we have just shown. The smartphone, I talked about it. Something as simple as cheap can be done. Please have a look at this study that was done. And then future direction. What we need to do, we need to train. We need regional microsurgery training centers. We need MPRAS, the MMed must expand. Subspecialty fellowship must be, I think you need to start thinking of that professor having subspecialty after they finish. And of course, research capacity, professor, please help everyone. People don't want to research. So we must improve on research capacity. Right, so this is just a model. If there is direct 100, it's just a model that if 10,000 trained people, this will expand the case capacity. And those trainers will train other trainees, and then in a certain period, you'll have about 4K cases. In conclusion, ladies and gentlemen, we were honoring the past and chattering before. So I've already talked about where we come from, where we are. The future, East Africa must have its first dedicated microsurgery training center, which I think we have one as a hub in our hospital. We must formalize our relationship with you guys as APRASA and COSEXA as a trilateral partnership. That we must do. Then ICG, 3D printing supermicro, we need to adapt them to our context, to our situation. Right, Pan-African Free Flap Outcomes Registry, do we have one? I haven't come across it. Actually, with many other things, breast and all, we need to have a registry. Right, and then of course, the government must recognize that this is a need, it's needed, right? Okay, so a call of action is the same thing. Train, collaborate, research, advocate, innovate, and honor. Acknowledge SA surgeons, Kenyan pioneers, global colleagues whose shoulders we stand on today. Carry the legacy forward. We know that the past is our foundation for future development. We must build upon it so that we too can act a stable foundation for future generations. Right? Our inheritance is skill. Our obligation is access. That is, by 2036, everybody should be having access. So we will train, measure honestly, extend access beyond Nairobi, choose innovative innovation for patient value, build partnership, and then live durable local capacity. These are just my references. I think most of you will notice they are very local. Some in international journals. We are having our local Congress on the 15th of October. If you want to come out there, please just call me. We can arrange. And I am on the board of ICOPLAST and the delegate for Africa. We are having our World Congress in Berlin, Germany in next year. Please, guys, come through. Do you have a volume, please, for me? And thank you very much.
Last World Congress 2027 and the annual meeting of the German Society for Plastic. Welcome to the ICOPLAST World Congress 2027 and the annual meeting of the German Society for Plastic, Reconstructive and Aesthetic Surgery, DG Black. Join us in Berlin from the 24th to the 26th of June 2027. ICOPLAST is the largest confederation of national plastic surgery societies with 59 member countries, representing over 20,000 plastic surgeons worldwide. 1,500 participants are expected, with live cadaver dissections of the famous Charité. Meet our internationally renowned faculty. Experience a world-class exhibition at the J.W. Marriott Berlin. Discover our unforgettable social events for networking. Globally united for the future. Please take note of the important dates. See you in Berlin.
Thank you so much, Professor Sagwapa, for that beautiful talk. We honor you for standing with us and for continuing to stand with us. Next, I have the honor of inviting Professor Nangole to give us his talk. Karibu sana, Chairman.
Thank you, Dr. Mukami. Dr. Mukami, I'm proud here I've finished my presentation because what Kenny did not have, well, you had the slides, but then she had the presentation. So I think I'll just try to be brief and see what else to add. But ladies and gentlemen, as the president of the Kenya Society of Plastic and Reconstructive, it's really my honor to be here when we celebrate 20 years of since our inception. Ken knows a lot about Kenya Society of Plastic and Reconstructive because he was there when it was started, and himself with solely worked with us step by step, and they guided us through in so many things that we were able to achieve. And therefore, our achievement has largely been not because of us only as KSPRAS, but really because of the so many other people who have really supported us. You can move on with the slides. Okay. So, as we've already said, it's been 20 years since KSPRAS was formed. The journey has been long, but largely very fruitful. This is therefore the right time to look back and reflect on our achievements and our failures. As a society, our main mission has been to become a global authority and leader in setting standards of clinical care in plastic surgery.
And vision has been to advance quality care of plastic surgery by encouraging high standards of training, ethics, physician practice and research in plastic, to support its members in providing education, advocacy, and enhance public awareness, to foster the highest professional, ethical, and quality standards, and very, very important, to advocate for patient safety, which Dr. Mukami here also mentioned. Plastic surgery in Kenya, as Professor Ken has talked about, has had two phases. There is a private phase, which Dr. Landra largely practiced. He practiced mainly in Nairobi Hospital, but again, he passed on, I think, in 2018 or 2019. So for many people who are here, they do not know how he looked like other than the picture that he showed. But the really person who really will say, really encouraged and really pioneered plastic surgery in Kenya was Professor Mbalu, whom you mentioned. And Professor Mbalu did his training in plastic surgery in University of California, Los Angeles, and he came back in Kenya in 1978 or thereabout, and was he worked at Kenyatta National Hospital, but was a University of Nairobi employer. He laid ground for the foundation of plastic surgery in the public sector, and majority of his work was actually in the public sector. I don't think he even had a private clinic. Actually, he dedicated all his work in the public sector. Of course, the founders of KSPRAS, the really true founders of KSPRAS, are probably the 6 ladies and gentlemen that I've put there. Dr. Kivai, who is here, who was the first president of the Kenya Society of Plastic and Reconstructive. Then we had Dr. Arif, who he wasn't a president, but he was, I think, the secretary in the first meeting. Then we had Professor Hainga, then the late Dr. Tanga, and then Dr. Louis Kahoro, and then Dr. Wanjeri. So those really were the first founders of KSPRAS. But along the way, other rest of us joined. So that is Dr. Tanga. Sorry, that is Dr. Arif on the picture on your left. With Dr. Githai, I think they were in a function. Dr. Githai, I'm sure you can't remember what function it was. And then in the other picture, you can see again Dr. Arif with Prof. Hainga. And you can see how times can change us. Prof. Hainga, I think he just finished his MAd program. And he was encouraged by Dr. Arif to join the Kenya Society to join the plastic fraternity. And I think those were some of those initial meetings. Of course, you all know Dr. Louis Kahoro. Again, Dr. Louis was really encouraged by Dr. Arif to join plastic surgery. And in those days, being a lady and a surgeon was not even something you could imagine about. In fact, there was purposeful intent to prevent ladies to be surgeons. But Dr. Kahoro, very, very spirited, believed that she has to do what she needs to do. So she did surgery, and then she quickly came and joined plastic surgery in Kenyatta National Hospital. And Dr. Arif really played a big role. And then, of course, you can all see Prof. Hainga very majestically standing there as the
as one of the founders of plastic surgery. And then of course, Dr. Njeri, again with this characteristic smile, there again played a very, very key role, as already mentioned by Ken. And then of course, Dr. Soli, most of you know Dr. Soli. Dr. Soli has been our external examiner for many years, I think 5 years or so. And for those of you who graduated in that time, he must have examined you and said that yes, you are good to proceed on as plastic surgeons. Again, as that was happening, myself, Dr. Wabire, Dr. Saidi, Dr. Adan, and Legado, and of course Dr. Dor, sorry I missed Dr. Dor. Most of us were still training in plastic surgery. We didn't have MA training here, and therefore most of us had to go to other countries to train plastic surgery. Myself and Dr. Adan went to South Africa. Dr. Saidi and Legado went to India with Dr. Dor, and Dr. Wabira went to Korea to train his plastic surgery. So of course in that picture, those are my mentors. My teacher, Professor Don Hudson, is a very, very known plastic surgeon in Cape Town. He used to work in the Department of Plastic Surgery in the University of Cape Town, but he's since retired. And then of course we have Kevin Adams, who also visited us here, I think in 2013, 2014, during a PRAS workshop. And all of them, they played a role during the formation of plastic surgery. So the landmarks or the milestones that we feel as a society we've achieved, most of them have been mentioned by Professor Ken. After registration in 2010, we had those two subsidiary societies, the Wound Care Society of Kenya and the Burn Society of Kenya. And this came out of the realization that as the Kenya Society of Plastic Surgery, we could not do everything alone. And we also wanted to bring in other stakeholders. So for the Wound Care Society of Kenya, we were able to bring in all those who directly or indirectly are concerned with the wound management. For the Burn Society, the same thing, we're able to bring in other stakeholders and also be able to reach out to the industries that may be able to support those activities. And then another key was the decision to start the MA training in plastic surgery, and that was in around 2011 to 2014. Now the history of MA training plastic surgery is so much intertwined with the KSPRAS that sometimes it's so difficult to say what is University of Nairobi and what is KSPRAS, because even when this program was coming out, actually, it was more of a KSPRAS rather than the University of Nairobi. Most of us were not in the university. I think it was only Dr. Wanjeri and Professor Hainga were there, but we had all to sit together and come up with this program. Then we've had so many workshops and conferences from around 2012 to date, some local, a good number international, and again, we realized that we were living in a small cocoon, that we did not know what was happening in the outside world, and therefore we realized that we had to move out and just see what's happening. I remember when we went to Canada in 2012 for the International Conference of Plastic Surgeons, myself and Prof. Hainga, we were so surprised at where the rest of the world was and where we were. Until when we came back, we said, no, we must change this narrative and make things better and be able to provide those services to our patients. We had our first graduate of MA Plastic Surgery in 2017, Dr. Biriba, as is rightfully said.
In around 2017, not 2015, we had our first reimplantation. The first was the hand. There, shortly after, we had the foot reimplantation in Coptic Hospital, courtesy of Ruben. He's around, or he's gone. Yes. He carried the foot all the way from Embu to bring to Coptic. And the reward he got out of that was to train the plastic surgery training program. Let us appreciate him. Then in 2018, we had twin separation, which again was successful, and it also gave us a lot of positive coverage. Both reimplantation and 2018, I think those were the years that really gave us a lot of positive coverage in the media. And that's the time people realized that yes, there's a discipline called plastic surgery and should be treated with the respect it deserves. 2021, another key landmark was the MOU signing with the Smile Train. Now that MOU was very, very, very important, and it's still running, and it's something that we should really, really be proud of it. The MOU has got a tripartite agreement. There's an agreement with Kenya Society of Plastic and Reconstructive. There's an agreement with the University of Nairobi and with the Smile Train. Now, from 2024 to date, we've got so many other MOUs that we've signed with other societies and other organizations, including ICOPLAST. We are a member of ICOPLAST, an active member of ICOPLAST, and we want to remain so. In 2024, another key landmark for us was the launch of the Pan-African Journal of Plastic Surgery, which we were able to talk about yesterday. So we have about 35 registered members. Our numbers are growing. When the society started, remember the pioneers were only about 5. So in a space of about 20 years, we've reached about 35. But we've got so many others who will be joining the program soon as they finish their graduation. Dr. Biriba, as soon as he got his master's, he decided to move on. He invited us for that beautiful wedding in Kampala and Entebbe. And I remember it was a nice event. We had just a very contentious general election in Kenya. It was in August 2017. So most of us could not go, but I was able to go and represent you. Alongside that, the other countries where we've got trainees that are finished is in Tanzania, Zimbabwe, Cameroon, Zambia, and Uganda. From the other countries, most of them are almost finishing. Of course, for the residents, this is a very, very chilly moments for them. When you look at Mukami there, she still looks like she's scared. So these are the exit pictures that we normally carry in the department. As soon as they finish the exam, we normally have those pictures. And they're so scared. It's like they're looking for hints. Are they smiling? Are they hungry? Have they passed? Have they failed? But luckily most of them pass. And then of course, another very, very critical event that we've been having is this graduation parties. I never knew, I knew my residents. The only time you can know the true colors of your residents is when they come with these graduation parties. You can see Busuri there. I didn't know that he had skills, such good skills in taking pictures. And of course, you can also see Alwara with all the smiles from one end to the other end. So a very, very beautiful occasion for all of us. Training opportunities for our members has been our priority, and we are very, very happy that it's something that we are very, very proud of. And for this, it has not happened alone. It has happened purely because of the so many collaborations that we've got with other stakeholders. Like for example, shared training. Shared training is very, very keen in developing microsurgery. Professor Ken, so it is some people that we can work with, we can partner with them They're already providing training programs in many African countries, Kenya being one of them, Rwanda another one, in Tanzania, and I think they're also in West Africa. And with the use of this, most of the young surgeons are able to learn skills on being able to tie loops and just being able to dissect and do surgery. So of course they'll be coming again next month, and we hope to continue from where we are. Again, still on that, on the issues of good collaboration with other societies and stakeholders, is we did not have our own operating microscope. And for the first time, they were able to donate this second-hand operating microscope, which is in good condition and which is assisting us to be able to do whatever we can do with our own loops. Another stakeholders that have really helped us a lot is the Italian Society of Microsurgery, and this has really come out because of two key people. One of them is Dr. Cristina, and the other one is Professor Bassetto, and of course Cristina and Sinica are like twins, so they're always together and they always work together. And through them, they've also been very critical in training our residents in Kenangop, and they've also provided fellowship to our young consultants for microsurgery. And so far, 4 consultants have benefited from this. You can see this was the first picture that we had with Christina. I think that was in 2021, and we had taken her out for lunch in one of the places in Nairobi, and we had brought her along the residents, and they expressed to her their desire to have skills in microsurgery. And Christina said, let me not promise anything, but I'll go and see what to do. We were not very sure whether she'll keep her word. But out of that meeting, and out of the so many other interactions that we had with her, 3 of them in this picture have already benefited from that training. You have Kiriga there, you have Christine, and you have Sarah, and many more. Actually, she was telling us that she's gotten a few more training opportunities for the young surgeons. Professor Bassetto also has been very keen. He came to our unit, he gave us a lecture, and as we speak right now, I think there is something that he's also working with us on issues of fellowship for young plastic surgeons. Of course, we've got other people. We've got Luigi there. We also have Andrea Pusik there in that picture, that have also shown a lot of interest and a lot of willingness to work with us as plastic surgeon. And then we met Dr. Andreas, who has gone out. Dr. Andreas, we met him first in the hand workshop in Washington, the picture on your left. And for whatever reason, he just showed interest to work with us, and we bonded. And he already been into Nairobi. He came, he gave us a lecture last year, and he's been there again for the peripheral nerve workshop. And again, he's keen to develop fellowship training, especially for the young consultant in various fields that we can be able to tap in Germany and also in Switzerland. Mission Plasticos has also been very supportive to us. They've been carrying out their work, especially in Nakuru. They've been learning almost a yearly training in Nakuru, especially with special focus on breast and also on contractures. And through this collaboration, they've also been able to train a good number of our residents. When we signed this MOU with SmileTrain, as I've already said, this was a very important moment for us as KSPRAS and also as the University of Nairobi. Through this MOU, we were able to carry out so many community outreaches. In fact, this year, if I'm not wrong, I think we've carried out around 10 outreaches in various communities. And out of those 10, we've done more than 100 surgeries, predominantly cleft lip and palate, but We've also carried out a lot of reconstructive surgeries, surgeries in many parts of the country because of the outreach. Again, because of this MOU, we've got this sponsorship program. All these faces are familiar to all of you. Through this MOU, they're able to train at least 4 plastic surgeons every year, 2 local and 2 international. And therefore, Smile Train has really supported the training of our residents. It is something that I know if this was not to happen, majority of the residents, especially those who come from foreign countries, I don't think they'll manage to go through the training. Again, another thing that we've really benefited from Smile Train is the research work funding. But through the MOU with them, they're able to research, to fund research projects. And as you can see, more than 10 research activities have been carried out. Most of them are the MA dissertations because of the funding from Smile Train. Another key milestone that really changed plastic surgery and KSPRAS in a whole was the reimplantation surgeries that we did, and this really propelled us. Plastic surgery before this was known purely for burns and for cleft lip and palate. But when this chapter opened, the rest of the country realized, and the rest of the disciplines actually took us seriously. They realized that yes, there's a big role of plastic surgery in the management of the patient. Our first case of reimplantation is a young boy who was 17 years old, who was brought in our facility with the hand, and this hand we are able to reimplant fully. The leg that, the foot that Ruben carried all the way from Embu, again, this was done in one of the private hospitals, and the patient did very well. The patient was a tourist who visited this country. He went back to Egypt, and he had a limb lengthening procedure done. We've also had bad times. It has not been very good. The 20 years have also experienced very bad time for us as a society. We lost Dr. Arif. I think 2 or 3 years ago, he passed on when he had just retired in Egypt. We also lost a very young, promising resident, Dr. Kirubi, through a very bad road accident. And then sorry. Oh. Mekata. Just a few more slides, you're almost done. Finya vibaya. Supposed to be reverse, eh? Let him. Okay, just okay. Maybe just come and looks like the Wanjeru's picture of the dog is what it wants to show. But anyway, we also lost Dr. Yeah, there we go. So we also lost Dr. Tanga, again, that was in 2017, and sudden death, and that is his family, his son, his wife, and his daughter. And then just during the COVID pandemic, we lost a very jovial, very hardworking, very friendly surgeon from Eldoret, Dr. Ashraf, through COVID-19 pandemic. May their souls rest in eternal peace. So one of our latest milestone has been our journal, which is the Pan-African Journal of Plastic and Reconstructive Surgery. is the prime journal of plastic and reconstructive surgery in Africa, especially in sub-Saharan Africa. We talked about it yesterday. And the nice thing is that publication in this journal is still for free. We don't judge anything. So any of you who are interested, just bring your manuscripts. We'll go through them. We'll advise you, and then eventually we'll be able to publish. So in conclusion, at 20 years, our track record as a society is an exemplary performance, in my view. If it was it's called CBE, CBC or CBE curriculum, we'll say it is exceeding expectation 1, not even 2. As a society, we've had a solid foundation from our founders and pioneers. We now must propel into the future with confidence while bringing everyone on board. And remember, united we stand, divided we fall. Thank you very much for your time.
Thank you so much, Professor Nangole, for that beautiful insight. Let's continue taking photos. We'll need them 20 years later. Yeah. I'm going to invite Professor Makata. Professor Makata has also been a very good supporter of KSPRAS, has seen us grow. He'll say something, and he'll also help us gift this beautiful shoulders we've been standing on. It is only fit for a giant to gift giants. Karibu, Professor Makata. Wow, you have something very nice on you'd better tell us what that is.
Thank you. First of all, personally, thank you everyone, the society, Mr. President, for inviting me to talk and to say a few words. From one society to another, that's why I'm wearing the KSPRAS. It is encouraging, it is remarkable that plastic surgery is doing so well in Kenya, in Africa, but also to see the training program that is producing surgeons that are going out into other countries in Africa. So you should be commended for your work on that, and I applaud you, and KSPRAS applauds you. Thank you. Dr. Allura asked me to wear this medal. I don't usually wear it because I think sometimes when you arrive at another conference and you wear a medal, people think, why is he wearing a medal? But I think from an official capacity, it was only true and honest to do that, to recognize the contributions that Kenya is making to plastic surgery across the board, but also across Africa. What I would say is that there has been remarkable stories of surgeons who are contributing to plastic surgery. I think we as surgeons should also recognize, and I'm pleased to see that there are a number of nurses here. We rely on our nursing staff to look after our patients, to make them feel whole, to make them feel appreciated. And I would like to applaud the work of the nurses and the therapists and the whole teams that make our lives that bit easier and more possible. I'm not going to say too much more because the history has been, we've heard the history today, and I say it's remarkable. I am encouraged to see that microsurgery is evolving. But I also say to my students and my trainees that they are very keen to learn the skills of microsurgery, and they are important. But what we mustn't forget is where we've come from to arrive in the world of microsurgery. because not everywhere has access to it, and it's very easy to forget the techniques of local flaps, precision hemostasis for skin grafting, and there is so much more to plastic surgery than a microsurgery, and ultimately, as I said yesterday, robots that will do that part for us. The role of a plastic surgeon is to engage with a patient, to find out what it is that concerns them. In other words, being a good doctor. You can't be a good surgeon if you're not a good doctor. And then to apply the skills that we all have in the room, various levels, various stages of experience, but we all have those skills to make people's lives so much better afterwards. So once again, congratulations, KSPRAS, on your achievements. Continue the excellent work that I've been able to observe today, but on previous occasions, on visits. And I look forward to the future. On a final note, I think it's only fitting that we should start a conversation about an MOU between our two societies and associations. So if we can perhaps begin that discussion, I think that would be wonderful. Thank you.
Thank you so much, Professor MacArthur. So I know there are a couple of giants missing, but I think they have sent some representatives. So Professor MacArthur, I'd like you to start with Dr. Githai. Dr. Githai, kindly come. So we have a gift. Dr. Githai, you know, we have come from far, so I'll give you the microphone. Kuja. I'm going to give you the microphone. I hope you don't mind. Before we gift you, just 2 words, and I hope you don't mind.
I've been told to just give 1 word. Which one? Now, I'm so happy for this. I'm so happy to see a full room because the first meeting we had, I think we are, I don't know, are we 5 or 6? Yeah, 5 or 6. And the giants who have gone, because as we talk about us, there's somebody called Dr. Arif who really pushed us. Really pushed us. He has never been an official as such. He really pushed us, Dr. Arif, and said, please, we must get a Kenyan society. We did it. Our first patron, Mr. Radra, he was the patron. He said, I don't want to be an official. I just want to push you to form your own society. He was our first patron. He was in Nairobi Hospital, but earlier on, he used to do charity work in Kenyatta. And you mentioned Professor Baru. Professor Baru was just Professor Baru. Very humorous, very humorous, but pushing people to do their best. He got Professor Kainga the South African training, and after that, of course, Nangore went. So what I will say is I've really enjoyed my life in plastic surgery. I really like seeing all these young guys. Microvascular surgery has come from far, very far. I think we did one of the first free fraps in 2000 with Dr. Tanga. It was a tongue frap. And the logistics of just doing it was so much. Now, when I see people just doing it, you know, the nurses are there, everybody is ready, the radiologists know what they are doing. So I'm so happy we come from that far, and so happy to see a full room with very enthusiastic young doctors. Then, as he said, Dr. Kahoro was a surgeon, a female surgeon, and that time it was so rare. Nowadays, when I see the number of female trainees, I mean, I'm impressed, But of course, for the men, you know, in a few years' time, you'll be the minority. Please, and that's the truth. It has happened elsewhere. So, thanks a lot for this. But let's try and guard our profession, please, please. There are so many other people who are going on a weekend trip to Dubai and learning about liposuction and coming back as cosmetic surgeons. Please, let's guard. Let's not fight each other. And maybe this one I should say. You've taken 6 years to, is it 6 years to train? Some of you have got thrones. Yes. Surgery, unfortunately, somebody has to pay for your own. And sometimes, it has to be the insurance of the patient. Please, stop undercutting each other. Let's charge the fees as the prescribed by the board. We rarely talk about this thing, but let's charge our fees as prescribed by the board. Now, tell me, why did you call me here?
I think you were going to tell a joke.
You can probably move there so that you can get a very good photo. Please move, yes. So we have something for you from KSPRAS.
So where do you want us?
Yes, where we can get a very good photo. Dr. Legado, I want to put you on the spot. President, kuja tu, tupige picha. We need you for memory's sake in the photos. Karibu. Thank you, Dr. Legado. Thank you. Dr. Gedai, don't leave. We have the HESH group who have a gift for all the giants. We want to take care of your bodies too. HESH group, please present your gift. Yes, we want everybody to feel younger. Thank you so much, Dr. Gedai. We honor you, and thank you so much for coming. We don't take you for granted. Thank you. So next, we are going to honor Professor Nangole. Let's honor those who are present, and then we honor those who have their representatives here. This is our current president. We have seen his achievements. Do we put him on the spot to talk? Ama ameongea? Okay. HESH group, please come and present your gift to Professor Nangole. We also want him to feel good on the inside. Thank you. So remember, we're honoring the presidents. Professor Hainga had sent someone. Adegu, do you want me to put you on the spot? Adegu, uko wapi? Dr. Adegu? Ayuko? Okay. So, Professor Hainga, we honor you wherever you are. Dr. Wanjeri, we honor you wherever you are. And of course, the late Dr. Tanga. Those are the presidents. Next, we want to honor Dr. Loegado, Wound Care Society of Kenya. We understand being a president is not easy. Yes. Apart from that, we've stood on your shoulders. We are still standing on your shoulders, some of us, wherever we are. So we thank you. HESH, please come and honor Dr. Loegado with something. Dr. Wabwire. Please switch sides. We honor you. Hesh, please come and give Dr. Wabwire something. Dr. Shaban Saidi. Dr. we honor you. Thank you so much. Hesh, please come and Dr. Amanda Malungo, Njonjo, on behalf of Professor Hainga. Yes, she's coming. We honor Dr. Kahoro and we honor Dr. Adan in absentia. Anybody else we haven't mentioned? We honor you. Okay, I think we are winding up. The award ceremony is not over. We'll still have more awards later on in the evening, but we thought this would be part of the KSPRAS at 20. So now we'll have the cake cutting dessert before lunch, then we release you. Olive, go ahead. Yes. Are we okay with the photograph? One complete, yes. I think we can move towards the right. Yes, I can release you. But KSPRAS executive, mnakata keki. Dr. Gedai, utatusaidia? Please don't leave. We'll have a group photo before lunch. Dr. Gedai, you can have a seat. Have a seat there with Professor Nangole. We cut the cake. Doctor, yes, please don't go. Oh, sorry, Professor Makata, you have to come back. I'm sorry. Mwaka kujia microphone, utuambie keki kona nini? Kuja, we ndio cake matron.
Good afternoon, everyone. I'd like to take this opportunity to welcome you, not just to the conference, but to my hometown. Mombasa, we consider as the capital city of the coastal region, and we like to do things a certain way. We like to dance, we like to sing, especially on such momentous occasions. So I'd like to invite my tribes people. This is how we respond. When we say Ache, Ache means women. So you respond E, and then I say Ache Hoya. You say Hoya. Can we try that? Ache, Ache women. Ache He, Ache Hoya, Hoya. Guys, if you're Kenyan, you know this. Ache, Ache Hoya. Then Alume means men. So we say Alume Huo. Now you say Huo. All right? Yes, yes. Alume Huo. All right, let's take it away. All right, so I'll invite our great giants, as we said, to cut this cake in honor of the hard work that has been placed by our forefathers, the work that is currently going on, and the work that we expect to continue. So let me have Prof. Nangole, Professor MacArthur, Dr. Githai, please come and join us. We can all, it's a big knife, we can all fit. Kata. A symbol of togetherness or oneness and love. I don't know how we're going to do this. I'll ask Dr. Mukami to kindly do the feeding. Yes, we do that here. Yes.
Thank you so much. We can allow you to sit as we share the cake. Then please group photo, don't leave. Yes. Tatu pangaje? Okay, let's start with the group photo, because I think if I give you cake ni hivo. So let's start with the group photo so that we're a bit organized before the giants leave. Then now we can eat the cake as we actually cut the cake. Please, someone help us with the table. Okay. Yes. Okay. I think we can start coming forward to the stage. Professor Segwapa, please come. Dr. Odwor, Njo. Professor Ntumba, Njo. Professor Catherine, please come. Guys, come.
I don't have such a calm voice, so please get out of your seats and come to the front. Please come in front so that we go for lunch, please, please. Come. I see all of you who are seated looking at me. Please come to the front. If you paid to be in KSPRAS conference, please come, we need your photo. guys to pass through hapo wakikula keki. Nani? Sahi. Tutashaenda guys.
Tunarudi ndio.
Tuwa? Itakuwa tricky. Unless it's dinner.
Sangapi sayari?
Wanaenda same day. Shikawaambia wapitie hapo kwa nini wakikula keki na tunarudi saa ngapi?
Please,
Milka zikwe pale, mtu akipewa lunch, apewe milka, apewa keki, apewe milka, atakienda. Yeah. So for 40 minutes. Eka milka pale kwa keki. Watu wakichukua keki.
we can now go for lunch. Please pass by where Mwaka is, get a piece of cake as you collect your meal card. Sorry, we are giving you 40 minutes. We have a very robust program in the afternoon.
Charting the future, directions in African microsurgery. So we are the core of it, and we are going to have some presentations on reconstructive microsurgery. So welcome to this session. So we have very exciting lineup of around 9 to 10 presentations covering different aspects of reconstructive microsurgery. So each speaker has 10 minutes. So we'll keep the session and hopefully we'll leave some time for discussion at the end of it. So I have the pleasure of sharing this session with two of my senior colleagues. That's Professor Segwapa from South Africa and Dr. Esther Gadhura, works in Aga Khan. So to our speakers, we'll give you a gentle reminder at 8 minutes and a firm signal at 10 minutes. Yeah, so with that, we get started. So our first presenter is Dr. Dev Smith. Dr. Dev Smith, you're welcome. The IT people, you can be projecting his slides as he comes. Thank you. I hope we enjoy this session.
Good afternoon. Thank you for coming. Okay, there you go. So my name is Dr. Smith. I'm a plastic surgery resident, third year, and I will be presenting the case report. And this is where microsurgery meets transplant. So the theme is successful microsurgical revascularization of an accessory lower pole renal artery in a living donor transplantation. So this case was done with, it was an MDT done with the transplant team at Kenyatta, as well as the plastics team, Dr. Kimutai and Professor Nangoli and myself. So of course, informed consent was obtained from the donor and the recipient, and they actually agreed to allow us to present user images for this conference. So our case is a case of a 59-year-old male, a non-hypertensive, diagnosed in 2011, and then subsequently developed end-stage renal disease as a result of hypertensive nephropathy. He enrolled in the transplant clinic and was receiving dialysis twice weekly. So following that period, he was able to get a donor, which was his 35-year-old daughter, and with the age early matching of 4/6. But interestingly, during the pre-operative evaluations, there was something that was noted from the CT angiogram of the kidneys, that show an aberrant lower polar artery for both kidneys. So following discussions, it was agreed that this patient is suitable for transplantation, and so the case can continue. So intraoperatively, as per institutional protocol, usually using two-team approach, there was a left donor nephrectomy that was done, and then the back table preparation, the graft was harvested and then taken to be flushed out, and so they used both the main renal vessel as well as the accessory artery. So the second team tried to prepare the recipient site. So a right iliac fossa incision was made, and then they tried to mobilize and expose the external iliac vessels for anastomosis, and then we encourage them to also prepare for us the deep inferior epigastric artery. So the deep inferior epigastric artery was used because of the vessel mass. It was around 3 millimeters, similar to that of the lower polar artery, and so they did an end-to-side anastomosis using 5-0 Prolene suture, and we were also called in now to do the anastomosis to that of the lower polar artery to that of the deep inferior epigastric vessel. So we used actually 10-0 suture, even though we opted to use 9-0, but it was not available at the time. So immediately there was a uniform reperfusion, and then the urine was produced within the first 5 minutes. So these are just photographs of some of the intraoperative findings, where there was alignment of the lower polar vessel to that of the deep inferior epigastric vessels. And then post repair, we can see a well-vascularized, well-perfused graft with the repair shown down in the second image. So the warm ischemic time was around 1 minute and 30 seconds, and then the cold ischemic time was around 2 minutes and 6 seconds. The entire operation lasted for about 6.5 hours with an estimated blood loss of 300 mils. So like I said, the renal vessels were anastomosed to end-to-side to the graft, and then we did the accessory polar artery anastomosis to that of the deep inferior epigastric vessels, and then the new ureter was inserted into the dome of the bladder. So POD1, he had a creatinine level of 411, and by the time he was discharged, creatinine was in normal ranges. And immediately day 1, as per institutional protocol, there was a Doppler ultrasound that was done, and it shows satisfactory graft reperfusion and also patency of our reconstructed lower polar artery. So what is it there in the literature about multiple renal arteries, especially in donor transplants? It accounts for about 20 to 30% of living kidney donors. And we know that there is shortage of graft, especially in the part of the world we find ourselves. So with the advent, like our team says, of microsurgery being very popular, especially in Kenya nowadays, I think it's important that we encourage we don't discourage such patients from donating to their loved ones. So a bit of the embryology of the multiple renal arteries. We all know from our basic embryology that during the ascent of the embryonic kidney from the pelvis to that of the lower back, there are some transient vessels that actually feed that lower embryonic kidney, and so it should regress at a certain time in their development. So failure of regression of that those transient vessels can lead to either duplication or unipolar or multiple renal arteries. And it unilaterally accounts for about around 20 to 25%, and bilaterally around 6 to 10%. So why is it that the lower polar artery is important even more than that of the upper polar artery, some may ask? It's because even though it accounts for 5 to 10% of the renal parenchyma supply, but it supplies the proximal ureter. If you look at the anatomy of the ureter, it has 3 different parts of blood supply. So the upper pole of the ureter is supplied by the lower pole of the kidney. So if you have an aberrant lower pole artery and fail to reconstruct or revascularize that lower pole, it's possible that it can lead to infarction, ischemia, as well as urinary leak, and our graft can fail. So this case matters because it's very important for us to revascularize the lower pole artery, like I said, and we opted to use the deep inferior epigastric artery because of the vessel caliber match, as well as tension-free repair, and so it allowed our patient to actually minimize those complications that were anticipated. And then we didn't want to manipulate or to try to manipulate the already existing iliac artery that was anastomosed using the end-to-side procedure, so we opted to use the deep inferior epigastric vessels. There are some other reconstructive techniques that are mentioned in the literature. For example, there is an end-to-side to the main renal artery. There's also the anastomosis to that of the inferior epigastric artery. And another one could be the side-to-side, the one we call the patalon, and some people anastomose it to the external iliac artery. So our take-home message is that the lower pole arteries in transplant patients should not be, those patients should not be excluded from donating to their relative ones. We should, with proper prevascular markings and then meticulous bench preparation is important, and then we can achieve good results. The deep inferior epigastric vessel is important because in this case it has the a nice caliber match, and then to allow us to provide tension-free anastomosis. So this is just a case report, of course, and it was in a single center, so that's a limitation, and then multi-center studies can be carried on, and then long term. Thank you for listening, and those are some of my references.
Thank you, Dr. Dave, for that exciting presentation. So I know we may be having some questions, but let's hold on them. I think we'll pick them up during the discussion. So our next presenter is Dr. Andrew Hodges. Is presenting to us how to improve outcomes in microsurgery in Uganda and Zimbabwe. So the IT team, you can be putting up the presentation as Dr. Andrew comes onto the podium. Welcome, Dr. Andrew.
Thank you very much. It's an honor to be here and to be able to present to you. Great. Presently I'm a plastic surgeon working in Zimbabwe with Cure International, but in 2005 I moved from the UK to Uganda and developed a plastics unit in Uganda. In June of 2005 we performed our first free flap, and this was for a child who had needed scalp reconstruction. We used a latissimus dorsi, and we and the patient were delighted that with the outcome. The flap survived and all was good. And not surprisingly, I've shown this in a few presentations. This is flap number 2. Actually, this is the only picture I've got. This is 1 month later. We did our second free flap. And this, again, was a latissimus dorsi, this time for lower limb reconstruction. But this flap failed. And again, not surprisingly, this has not shown up in my talks before. But right from the beginning, I think it's really important to be honest about our failings as well as our successes. We love showing our great results. We do not want to show our bad results. But maybe in terms of talking about improving outcomes, one of the first things is we've got to be honest about what we're doing and how we're doing. before we can think about improving. So in those early days, 2005 onwards, our microsurgery was a bit of a roller coaster. We had fantastic, exhilarating successes, but we also had patients like this one where we did not get a good result. We maybe didn't even understand why we didn't get a good result. And so we had those frustrations of those failings. And you know, I may not be alone in having a failed free flap. And for anybody who's had that experience, it's a pretty demoralizing and crushing experience after all of the hours, all of the effort that the whole team makes. To have a failure is really tough. So I hope that this will be of some encouragement as we try to work through how to improve things. So we published a paper in 2015 looking at our free flaps. We looked at 114 free flaps in our centre over a 6-year period, and our success rates overall were 76%. Now that's not a figure that I'm particularly proud of, but I wanted to share a little bit of the backstory of how we came across this paper. So we had this keen young surgeon who wanted to come and do a bit of look at some of our data, and she asked us if she could look at our free flap outcomes. And we were not keen. We knew we had struggled. We knew we had had some failures and a particularly bad run just before she came. But in the interest of intellectual honesty, we said she could go ahead. And we feared the results, and we waited for what it would be. And this was the results that she came up with, that we had in that period of time a 66% survival rate. Now we knew that we were not good enough. We knew that we needed to be better. But we kind of consoled ourselves, well, 1 in 3 didn't survive, but that means 2 in 3 of our patients had a good outcome. But it did provoke a bit of a crisis for us. What do we do with this result? Are we not good enough? Should we stop doing micro? Or should we work out how to improve? And we didn't feel like we could not stop. For the sake of those who had succeeded and for those that needed micro, we felt that we had to go on and do better. So we decided that we would look at every aspect of micro and try and analyze how we could improve. So we did a bit of a mind map and try to look at all of the different aspects and see if we could tackle each one at a time. So the first thing we did was to go back to the lab to see whether we could improve our techniques. We got some lab rats, we got some models, and we practiced and practiced. And while we were doing this, we recognized, number 2, that we had been using a lot of donated microsutures, some of which were very traumatic. So having tried to improve our techniques, we also realized we needed to improve on our microsutures. We threw away all the old ones, got some new ones. We were using S&T at the time. And then also recognized that our instruments were old and worn out, so we got a new set of Mercian high-quality micro instruments. We looked at who was doing the micro, and we felt that until we got better results, the micro should only be done by the 2 senior surgeons, that's Dr. Galawango and myself. And then once we got better results, we would then be in a position to pass on skills. We looked at our nursing team. We had some nurses who enjoyed doing micro and some who really didn't like it at all. We chose 2 who enjoyed it. We sent them off to Ganga to get involved in the micro course there and get involved in what was happening, and then they came back and were able to really improve the service from the nursing side. We invested in our trainees. All of our trainees were also sent to Ganga to do the micro course, and they were all taught to raise flaps. They were all taught how to monitor flaps. And we recognized that anesthesia is crucial for good micro outcomes, and as much as possible we had 1 senior anaesthetist to look after our patients. Ergonomics, I think, is pretty important in microsurgery. It's a tiring procedure and long, and we recognize that if things aren't set up right, then we spend all day tripping over wires and getting in the way of things, and it gets quite exhausting. So we spent more time in the morning setting up for a smooth flow. And we also recognize some people seem to be able to power through with their microsurgery, never taking a break. But we recognize that we did a better job if we had a bit of a break. And so before the micro, we would always stop just for a few minutes and take some food and drink, get ready for the micro. Surgical technique, well, this is kind of a whole talk in itself, so I can't really go into much detail on this, but just a few things that we changed in this period. We started doing more end-to-side anastomosis when appropriate. We got more comfortable with that. And we also started doing more backward anastomosis, not using the double clamp, and this was really useful when we were in a situation which was difficult access. And if needed, we became more comfortable with using vein grafts. And this is more of an attitude change, one of perseverance and being willing to take back. You know, when you've spent so many hours and you're exhausted, everybody just wants to go home. But we recognize that if there was any problem, we had to deal with those problems on table, or we had to take them back early if we were going to get a salvage. And so this became kind of an attitude change. And we recognized that we were picking up problem flaps too late. And so we spent a lot of time improving our flap monitoring and also training our nurses and our residents. We developed our own flap score, which would alert the nurse or the resident when they needed to call. As well as Doppler, of course, we also looked at skin temperature and other factors. Perhaps one of the most significant improvements in monitoring was in always trying to put a skin flap on, even if it wasn't required. And on that skin flap, we would cut a small dermal window, and that would give us a fantastic look at how the flap was performing. So having made a lot of changes, we then decided to look at our results, and our keen young surgeon came back and looked at the subsequent 50 free flaps following all of these changes. So just to remind you, we had initially had a 66% survival rate. We looked at all of these factors, and then having looked at all those factors, the subsequent 50 had a 94% survival rate. So 3 out of 50 went in the bin. Thanks. So we were encouraged by this. And sometime after the publication of our paper, I was reading about the British cycling team. I just want to say that for a couple of very short thing about them. So they developed something called the aggregation of marginal gains. The British cycling team historically was a terrible cycling team. In 100 years, they got 1 gold medal in the whole lot. And they took on a coach who decided that they didn't need one big change. They needed to look at multiple changes. So they changed so many factors, and rather than one big change. And in the 2008 Olympics, they won 8 gold medals and 60% of all available medals. And the reason was multiple small changes, not one big change. Thank you very much.
Thank you, Dr. Andrew. That was an excellent talk. We taking a lot of lessons from it. So on to our third presentation. So we still have a presentation from Uganda, Dr. Naomi Kekisa. You're welcome to the podium. So she'll be talking about complex defect microsurgical reconstruction at her hospital in Uganda. 20-year experience of using free fibula flap. Welcome, Dr. Naomi.
Good afternoon, ladies and gentlemen. My name is Naomi Kechisa from Uganda. Before I start my talk and while they come, as you're celebrating 20 years as KSPRAS, we are celebrating 20 years of using the free fibula flap. And the data I'm presenting is mostly the sweat of the people on whose shoulders I stand, i.e. Dr. Andre Hodges and Dr. Galiwango, who sends most of you greetings. I joined this team in 2018, before as a resident in 2015. That's just the face of our hospital. We are an orthoplastic hospital, just for context, and I have no conflict of interest. So we have used the free fibula flap over these 20 years, and we raise it mostly as a either osseous or osteocutaneous. That's just to show you what it looks like. I'm sure most of you have used it. In this retrospective data, we looked at 218 patients, and that was their gender distribution. The range of defects we deal with span from long bones in the limbs and the face as well. So we've done maxilla, we've done mandible, but this is just to show you that some of these defects span from one side of the mandible to the other, so you have to plan for all that while doing your flap. We've also done a lot of tibia, femur, humerus, radius ulnar, and we even attempted metacarpals. This is, for most of our long bones, it's osteomyelitis, and this is just a picture to show you that the defect and what it looks like initially when the patient presents to us. This and many more others. That's to show you the process. So the patient comes in with their osteomyelitis, it gets taken out, we put the fibula into the tibia or whichever bone is affected, and it reintegrates or it tibializes and takes on the size of the tibia. That's just science that most of you know. This is just an image of the humera, of the femur, going through the same process. Most of our patients, the biggest number was osteomyelitis and then ameloblastoma for the mandible. But we also had some pseudarthrosis and a couple of other tumors that required us to use the free fibula flap. When we used it, on average, our ischemic time was 1 to 2. Most of the patients, we had 1 to 2 hours. For some of them, we went beyond 4 hours, and if you've been in micro before, you know that it can really stretch. For those that were short, it was because it was a simple, it was a simple procedure. You didn't have to, shape the bone into anything else. We're just moving it from one long bone to another long bone. But in the longer hours, it was more of osteotomies, plating to create, the shape of the mandible, and then maybe long micro hours. Over the years, this is what our curve looks like from 2006 to 2026. There's a bit of a romance between the yellow and the blue lines. The yellow line is trying to chase the blue line, but it can't catch up with it. At some points, we see that it catches up, and we are glad that in 2026, the yellow line stands and there's no blue line. The blue line is for our failures, and the yellow line is for our, the blue line is for all our surgeries, and the yellow line is for our successes. Over the years, to explain why the curve went down, free flaps, as you know, are expensive, and around COVID, we lost most of our donors. Our hospital is mostly funded by donors, and most of our patients could not afford, the surgeries. So our numbers dipped quite a bit. Yeah, our total operating time is also shown here, and for most of our patients, it lasted about 6 to 8 hours to do a whole surgery from the start to the end. And we found that we had the biggest successes among children who are below 10 years. Incidentally, even our seniors, those above 50 years, did well. But we had most of our difficulties were around the young adults, 21 to 30, and the biggest reason there was because most of them had very difficult situations to deal with, i.e. bone loss from trauma, and sometimes the trauma had affected the limbs and the vessels a bit too much. Our successes by surgical site, our tibias and mandibles did so well, so did our femurs. We lost only 2. We attempted a hand to put the fibula in 2 metacarpals, worked for a few weeks and died after 3 weeks. We were so sad, but it had happened. What were our biggest complications? Most of our patients did okay, but we also had a couple of them complicating with, a bit of infection, hematomas, a couple of foot drops, and one patient had a post-op osteomyelitis, very rare. We actually don't give routine post-op antibiotics for our free flaps or any of our surgeries in our hospital. Over the years, we learned a few tips and tricks that have helped us. Dr. Hodges before me spoke about some of the things that we learned, so I'll just reiterate what he didn't talk about. One, learn that take care of your equipment. In our center, we have our nurses who are special micro nurses who take care of our instruments very well because they understand how to clean them and take care of them. Also have a budget for replacement because instruments get, they really run out. They get spoiled over the years. You'll need a budget to ensure that you can replace them. There's a time that we actually had an issue with our microscope and we lost a whole year trying to get it sorted. And yet, if you had a budget for that, you'd also solve that. Train your staff, and on a free flap day, just avoid distractions, honestly. Don't put too many surgeries on the same day. Don't show up very moody. Don't kill the team's vibes. Just be happy. And a flap can die before it starts just because of your mood. So try to have a good mood on that day. Don't rattle the room, otherwise it will die. It will die. We've seen that, and we're just here to let you know. Anesthesia was talked about already. Please find somebody who can go through the rigors and endure the monitoring of your patient. A small thing, we've gone through a lot of this, but a small thing can tip your BPs and that flap will die. Good posture, look after yourself. Don't come out of micro having neck pain, back pain, arm pain, shoulder pain. You'll not live long. Then the very controversial bullet point there, learn how to save time. You're going to have people who can do the micro way easier than others. So you have the microsurgeon who needs 10,000 hours to perfect his skill, but you also have that microsurgeon, the annoying type, who will walk into the room and do micro like it's nothing. Learn to utilize those gifted people because they will help you save time. Some people can do micro alone. Use those ones because you will need them. On a day when somebody faints, somebody needs to leave, somebody needs to lift table, the micro can continue by one person. Also, thank you. Also learn to communicate between yourselves as the surgeons, as the team. It will help you. Choose the right patient. Decide whether you're going to give thromboprophylaxis after. We don't give it in our center routinely, but we learned a trick after doing anastomosis. We just bathe the whole anastomosis in lignocaine, 2%, and we walk away, let the flap breathe, let it drink, and we come back to close our incision. So those are tips and tricks. We've also learned over the years, sorry for overshooting, that you need the numbers to hone your skill, and volume will help you to perfect your skill. The better experience that the surgeon has, the better the outcome. Children have higher success rates. Skin paddle, your flap better. Although, implanted Doppler would do the best. Train your teams, and you'll enjoy being a microsurgeon. Thank you.
Thank you so much, Dr. Naomi. I've just learned that you can kill your flap with a bad mood. Thank you so much. Very, very interesting. So our next speaker is Dr. Bethwell Kimutai, one of our residents here in Nairobi. And he's going to talk about reconstruction of a complex axillary defect using free anterolateral thigh flap with thoracoacromial recipient vessels. Welcome.
Thank you. Good afternoon. Let me wait for the slides to come up. Okay, thank you. So my name is Dr. Kimutai. I am a third-year resident in the University of Nairobi, where we do a couple of microsurgery at the Kenyatta National Hospital. So I'm going to present today about a case that we did under Professor Nangole, and then listed there some of the other residents who we also participated in the case. So it's on reconstruction of complex axillary defect with free tissue transfer. And then you can learn a few things about the context that is the African microsurgery. So to introduce, axillary reconstruction is an important aspect of plastic surgery, especially, as you know, in plastic surgery you need to either preserve function or restore it if it's lost, and then provide a durable skin paddle cover for the area that we are covering. So the axilla is an important aspect because underneath it contains the neurovascular plexus, and you need these plexus to be well covered with good tissues, and also preserve the mobility of the shoulder joint. The most common indication for axillary reconstruction usually is trauma, although there are other indications including setup, post-band contractures, and even some chronic infections like adenoitis suppurativa. In literature, there are many ways you could do this coverage, and I'm going to discuss them. But in this particular case, we use a free option. So the patient that I'm going to present, which is a case report, and I list here some of the important aspects that you need to be keen when you're evaluating the patient. This is an 19-year-old male patient who is a barista by profession, and he serves coffee. He's right-handed dominance, although the wound was on the left shoulder. And the injury, which is very important, you need to talk about the mechanism because it predicts the effect of the defect. So it was a road traffic accident, which is the most common cause of these cases. And even more important, remember that you need to preserve life over the limb. And this patient presented in hypovolemic shock. So the management will entail you first stabilizing the patient before you reconstruct. And the stabilization usually, as you all know, follows the ATLS principles. So when evaluating the patient, he had a shoulder wound on the left axilla and extending to the arm, and also an associated lower limb degloving injury. But the one of concern to us is this shoulder wound. Here are the photos. On the top left, you can see quite an extensive wound, and it might be difficult for you to predict how extensive this wound is, and that's why the first aspect of management usually is an exploration and debridement. So it's difficult for you to know, especially for this patient who is in a hypovolemic shock. You're not able to examine adequately to know which structures are actually intact and which one are deranged. So we took the patient for a debridement. You can see the photo on the bottom left. And most of the critical structures, especially the neurovascular structures, were intact, although there were a loss of the biceps tendon, but the other muscles seems more or less involved, more or less preserved. After the first debridement, you see the photo in the middle there. Most of the necrotic tissue on the shoulder has been debrided, although there is some wound sepsis. So before you reconstruct, you need to do another debridement, do wound care, control sepsis, and then you see the photo on the top right where the wound is ready for formal reconstruction. So here I highlight what I've talked about. Stabilize your patient, resuscitate, follow the ATLS principle, serial debridement until the wound is ready for coverage. And then for this particular patient, because of the challenges which events it's important for us to highlight, especially even from the other presenters, the African microsurgery setup. For this particular patient, it took 1 month for us to get into theater for a formal reconstruction. So the choice of reconstruction that we went with was an anterolateral thigh flap, the ALT. It's a common flap. It's been mentioned even yesterday. And the reason it's quite common is because it's reliable, and also it's quite large. And for these patients who are, especially male patients who are quite thin, you're able to get a thin, pliable tissue, which is good for the axilla compared to the other like muscle flaps. So it contours well with the axillary fold. Then it has a long pedicle. This is important because in this injury, your most expected recipient vessels sometimes are involved in the injury, and you need a flap that gives you a long pedicle to get to alternative recipient vessels with limited donor set mobility. You can raise it as a senset that preserves sensation using the lateral femorocutaneous nerve, and you can even do functional incorporation, including the muscles surrounding the thigh. But for this particular patient, we did not need functional reconstruction because there was preserved motor function. We included a senset nerve, although we could not find a recipient sensory nerve at the axilla. So the usual target recipient vessel, usually the thoracodorsal, because most surgeons are comfortable with this anatomy. Although for this particular patient, there was injury extending to the posterior axillary fold. So those vessels were no longer reliable. And therefore, we choose an alternative recipient vessel, which is the pectoral branch of the thoracoacromial arch. Then for the vein, we did the vein that accompanies the artery, and then added an extra vein, the cephalic vein. So this is the interpolative photos. This is the wound just before coverage. Then you see the marking of the flap on the right side, so that you're able to do simultaneous donor and recipient execution. So the flap is raised. I'm not very sure it's very clear, but you can see septocutaneous perforator of the ALT, which was quite dominant, and then we also included an extra perforator, which was musculocutaneous. Next to the septocutaneous perforator, which is on top there, you can see the sensory nerve, the lateral femoral cutaneous nerve of the lateral femoral cutaneous nerve, but we could not use it because of lack of the recipient sensory nerve. Then now on the photo on the top, on the right, you can see its inset beginning. So on this photo, the insert is complete. And what you can pick from this is that for extensive defect reconstruction, you need to realize which areas are important to cover with a flap and which areas can go with a skin graft. For this one, you remember the axilla is where we target to cover so that you can preserve abduction and extension function, and the rest of the wound can benefit from a simple skin graft. So we did a mesh skin graft. Postoperatively, we monitored the flap using a protocol that is standard at our hospital, starting with a two-hourly flap monitoring, which is mostly carried out by residents with the consultation of, the consultants for 24 hours. Then we proceed to do 4-hourly for the next 24 hours, and finally 6-hourly for the third day. And the markers that we use include clinical examination and Doppler. We do not have the other recommendations that have been talked about afterwards. Then usually this is done in the ICU setup to provide warmth, easy access to the patient, etc. You need to protect anastomosis using a splint. For this patient, it's splinted for 2 weeks with a POP. And then thereafter, you can start with an aggressive physiotherapy to preserve and restore function. So yeah, this is a photo around 3 weeks to a month after the reconstruction. You can see the flap well settled. There is a bit of patchy loss of the skin graft. We took our patient in for grafting of the rest of the wound, and now you can see approximately 6 months after the injury, the patient, all the wounds are healed, and there's preservation of the most important function of the shoulder, the abduction and extension. So from the literature, the framework that has been proposed to reconstruct axillary defects include working with the size of the defect, and for extensive defects, which is defined as on average more than 200 centimeters square, usually free tissue transfer is recommended, but smaller defects like contractures, you can use local flaps, including a TDAP, etc., a regional flap that is, and then for even smaller defects, you can do local flaps like we do for contracture releases. Beyond coverage, I've talked about function is most important, and this function includes sensation for the axilla if you're able to get a target nerve, and even motor function, which for the LT is good because you can include the muscles. So with the hospital in which we practice in, it's a level 6 referral hospital, the Kenyatta National Hospital. Most of you, I'm sure, have been there. We use the 4th floor for our ward, although most of our patients go for the ICU after the surgery, which is in 1st floor, and sometimes we utilize the burns unit for the other critical aspects of care. There are many systemic challenges that the other presenters have talked about. That's also true for us. And over the years, I think it's become better, and we're hopefully going to even improve further. So take-home message, the thoracoacromial system is a good, reliable recipient vessels. The LT is a reliable option and versatile, which we use. Rehabilitation is just as important, if not more important, than the actual surgery. And then we need to continue talking about these surgeries that we do for improvement of the other systemic challenges that are there preventing the good outcomes. These are my references. Thank you.
Thank you very much for presenting that interesting case. Our next speaker is Dr. Montanari from Italy. He's going to present about the microsurgical experience in North Kinangop Hospital. Welcome.
Thank you very much. Yeah, I'm here to talk about experience we have in this hospital in Nyandarua County, 2 hours from Nairobi. It's a rural hospital that I've been there since the 60s. I'm just talking, waiting for that. Okay, yeah. I already presented it actually yesterday, so just do a brief presentation maybe for the one who are not here yesterday. Is this hospital in a rural area in Nyandarua County, 2 hours from Nairobi, more or less. And it's been there till the 60s, when it was founded by a collaboration between the local diocese and the diocese of Padua, my hometown in North Italy. It's quite a big hospital, considering the area, 5th level referral hospital with many residents all the year specialty and many services, and actually now 7 operating rooms. We organize the mission in this way with our Society of Plastic Surgery in Italy. 5-6 missions per year, where there are usually two residents stay for 1 month, and then 2 consultants in the center 2 weeks, mainly from Italy, but actually from all over the world. Those are the numbers. Actually, now I didn't count the last 2 missions, so they've increased a bit in the last 10 years. Of course, the first year there were just maybe 1 or 2 missions per year, but after COVID, after 2022, we started to have a stable 5 to 6 missions per year, so the number are increasing. When we started there, more than 10 years ago, of course we were providing general plastic surgery services. And there was like this big dilemma if microsurgery was, if like the environment was good for microsurgery, because we consider some pro, of course, that there were expert visiting teams. There were the proper facility there, because we have the possibility to have a little old but functional microscope and all the microsurgical tool. Was an opportunity to training, local personnel. I think 10, 15 years ago, probably there were fewer centers than now doing the microsurgery. And we had a great range of indication, many patients that would benefit a lot from microsurgery. And often is the last possibility for them. And sometimes we will see, it was a part of my talk, that is the safer option, microsurgery. Could be the most technically difficult, but actually not every time the simplest thing is the best one for the patient. And also there are general surgeon, gynecologists, the orthopedic surgeons, so we have the possibility to work in a multidisciplinary environment and with a bigger team. And of course there were some concern, because of course the expert surgeon coming from Europe, they were used to different equipment. And sometimes a surgeon could be very methodic and needs his own instruments. It was difficult to have a proper patient preparation, because sometimes there was not enough time to have all the diagnoses, in case of lower limb, to prepare properly, the wounds with many weeks of negative pressure, for example. Or there could be a gap between the next visiting team. So in case a patient has some complication, who's going to take care of it? Of course, there are the other doctors, there are other surgeons, but still it's quite a specific niche of plastic surgery. So of course we have to take that into consideration. For the hospital, from an economical point of view, it needs higher costs, because we occupy the operating room for longer time, longer hospitalization of the patient. And of course, even at first, the surgeon were a bit scared, because they saw there were much higher complication respect their home places. So our cases, our indication are acute trauma with bone soft tissue loss, burns outcome, emergency revascularization, and the last year also autologous breast reconstruction. We are missing here head and neck reconstruction, because the hospital doesn't have really an ICU, so it's not really possible, to assess those patients. I'm going to show some cases. Those are, for example, chronic osteomyelitis. There was a patient, 15 years old, that had a fracture already fixed and already did a debridement for osteomyelitis 2 years before. Then came with a classical fistula, okay, that broke the skin. You can see also on the X-ray. And at first, we assessed it with a reverse hemispheric flap, because we thought it was enough, to use the muscle to fill in the gap in the bone. But unfortunately, not always the simpler solution is the safer one, because we have a kind of experience with a reverse flow flap in the lower limb that they are not the most safer option. So once it was failed, we resort to a more reliable latissimus dorsi free flap that just after 10 days, almost 10 days, was almost healed, and after there was a follow-up clinic after a month, it was completely healed. In rural areas, it's very important to have the possibility to give a revascularization service, because it's still a lot of people are working with agricultural machine, and we saw quite often like big hand trauma, and sometimes they are devascularized, like this case. You had to do anastomosis of the ulnar artery, and then was kind of spaghetti wrist. And this is very important. From there, they don't really have the time, to go to other center. Let's see if there's the video where I check here after the vascularization. The blood flow. Burns and hand trauma outcomes. This is a patient that after burns have a complete obliteration of the first web space, and we use a skip flap, okay, very thin, to reconstruct the first space. This is the result, quite bulky at first. They told me this patient was actually treated for the bulking in this mission by Dr. Garuzzi. More hand trauma. Sometimes there's not much we can do. Those are very, very nasty trauma, also from agricultural machine. And in this case, we try to save what we can. You see just a couple of fingers. And these are some patients that we are trying to get to have some toe transfer, which actually we found a bit of resistance by the patient to undergo this type of procedure. But still, we try to save what we can, because it's a possibility that maybe once we are starting to do them, also that the population and people try to get more used to it, and doesn't look like a strange or sophisticated option. Burn outcomes, of course, this is a very big retracting scar. We see a lot of this patient. Sometimes we do skin expanders or Z-plasty. This guy was too big to do that, so we resort to an ELT flap to restore the proper extension of the neck. And then, of course, this patient underwent also the bulking as well. And of course, as I saw in this morning, the presentation this morning, in the last 2-3 years, we saw a bigger increase in the request for autologous breast reconstruction. This is particularly important here because it's not that easy to get the implants. And you can see usually the DAP is our first option, and we can get quite good result. So as we saw before, also when not every of course not everything goes as planned, because we saw we are facing quite a bit of complications and even failure. This is a patient that came from another hospital with an open fracture, already treated, and they put a negative pressure for almost a month, for 3 weeks, so he came in this condition. We did a debridement. We put some bone cement, waiting, for another time to do the graft or to put a fibula flap, and we cover it for the moment with an ALT. And firstly, it seems pretty good. After some days, it developed a blistering all over the skin, but still at the Doppler checking, the anastomosis was pulsing. So we wait and see, but unfortunately the next day it just became completely necrotic. And this is after 20 days I have to do the full debridement. So this is a bit a sum up of our results in the last 12 years. Actually, this has to be a journey. We are now more than 40 procedures done. And we see we got like a 12%, more than 10% of failures. Those are all our indication and the most common free flaps we are performing. I did a similar job to go through all our cases, and to see that our main indication is in the lower limb. So the main indication is low orthoplasty. And we see we are experiencing almost a 40% of overall complication. In the complication, I mean like late wound healing or partial necrosis, need to go for little adjustment in the theater, and more than 10% of flap failure, which is high, but we still think that in this area, it's still very worth it, to perform this kind of surgery, because many times it's the best or even the only option for the patient. Then you have to consider this, that not always the simplest option is the safest, like in the reverse flow flap. And of course, it's very important both for the new indication like the autologous breast reconstruction and also to increase and expose all the local personnel to this kind of surgery. Thank you.
Thank you, Doctor, for sharing your experience. Our next talk will be by Dr. Esther Gathura on a multidisciplinary collaboration to enhance microsurgery and institutional experience.
Thank you. All right. So I'm finding that a lot of what I'm going to say has probably been said. Same themes, because we're doing microsurgery in the same environment. So waiting for the slides. Thank you. So I'm based at the Aga Khan University Hospital here, not here, in Nairobi. And it's just for context, for those who are not from Kenya, it's a private but not for profit making institution. And it's quite, even though it's not for profit making, the prices can be quite hard for the patients. So I'm gonna ask an existential question for all of us before I start my presentation. What is plastic surgery? The reason I'm asking this is even as we talk about doing microsurgery and advancing, we have to think about our speciality in terms of we don't own a particular part of the body. So an orthopedic surgeon can say, I'm a bone surgeon. It's one sentence. A vascular surgeon, the same thing. But for us, we have to, even when people ask you what is a plastic surgeon, we have to explain. And the main thing is that we work with many other specialities, and we have to work with many other specialities. And in fact, I really loved the first presentation that we had about the case with the renal team. And I thought, this is right home. This is exactly what I want to say. So multidisciplinary is, we know what it means. It's multiple professionals from more than one clinical discipline working together. So that's Joseph Murray. I came to find out actually a few years ago that he was the first person who did a renal transplant was a plastic surgeon. And we do kidney transplants in many hospitals. In my hospital, they're doing once a week. And I'm sure if I told the theater team that plastics used to do renal transplants, they'd think I'm telling stories. The reason I bring this up is most of the procedures that we do can be and will be done by other specialities. And that's not a problem at all, because our patients eventually need the help they get. For instance, the renal transplants, there isn't enough plastic surgeons to do this. But my point is, as young plastic surgeons, as young trainees, we have to sort of think about what are we bringing to the table, are we pushing ourselves, because plastics is about innovation. And that's why the first presentation about the renal team have gone and said, oops, there's an aberrant renal artery, what can I do here? Let's call plastics. And that's the heart of our speciality. That is what we are about. So I'm going to talk about a few case summaries, going through different types of free flaps that we've done. And just my scope is how we've worked with other specialities and how the other specialities need to know about what we are doing so that they can involve us. So it's a two-way traffic. So this is an upper limb case. So a 41-year-old had an RTA. I think this was my first week starting as a consultant. And I think I was alone. So there was a vascular injury, there was soft tissue injury, bone injury. And the vascular had revascularized, and then the orthopedic surgeon said, you guys fix the soft tissue injury and we'll come in. And I looked at this and I said, well, if I fix that, I could do multiple things. He had trauma to the volar aspect of the arm, so I couldn't really do any local flaps, but we could do regional. You could do a thoracoabdominal flap, you could get a flap from the abdomen. However, that joint will not move. It was completely flail, no tissues on the lateral aspect. And I felt to myself, what's the point of doing this soft tissue recon if this patient is not going to move the elbow? So I called the orthopedic surgeon and I said, sorry, this is not moving, it's stuck. So yeah, so my point was, I called them and I said, what can you do for this elbow joint? And bearing in mind I'm all alone and I'm going to do an ALT flap, I can't be thinking about reconstructing the elbow. Maybe it's something I can do, but I said to him, you think about what we can do for that stability, and then I'll put in a flap with fascia so that we can prevent a lot of adhesion and get that elbow joint moving. And so basically that's what he came back reluctantly, and he was really happy with what he did. He used the gracilis tendon, and then I put the ALT on top and skin grafted the rest. So this is the gentleman, probably 9 months or so post-op, and he's able to supinate, pronate, he drives, he's doing everything. So that was my first. Maybe I did the multidisciplinary collaboration because I needed help. But ultimately for the patient, one operation, they didn't have any further subsequent procedures, and it was good overall. This is another case, a 32-year-old gentleman, post-RTA. You can see the tibia is, there's a tibial fracture with displacement, and the bone injury actually wasn't that bad. So the orthopedic surgeon who was referred the patient to me said, actually, I've got a very simple fracture in a very complex soft tissue injury, and he was right. So if you saw this image, and I would expect most of our residents to just tell us we can do a gastroc, which is what I would do anyways for such an injury, but however, he had this degloving element, and it ended up all getting necrotic on the posterior aspect. That's after X-fix, and the bone was actually not the problem here. And so we did a procedure at the same time with the orthopedic surgeon. So he put in an IM nail and we did an LD. That's the posterior aspect. Sorry, that's the posterior aspect of the leg there. And that's the flap on the left side. And you can see that we did that simultaneously, again, one surgery. And that's after settling very well, and that's 9 months post-procedure. He's walking, no issues with especially the posterior aspect of the leg, no contracture or anything like that. The next case, this is the opposite. This was a crash injury to the ankle after an RTA. The soft tissues don't look that bad, but that foot was completely flailed, multi-level fractures, both tibia, fibula, and also the ankle joint. It was completely disarticulated. Again, the orthopod who called me said, let's do this together, but this is a super complex bony injury. And again, same sitting, one operation. So I raised the gracilis and they did the bony fixation. They took longer than we did. And then my take home from this is clearly define where the problem is and communicate with the patient. And also, I've given some nice lower limb cases. We've also had some really bad cases where there's a really bad foot injury, and the orthopod tells me, you just do the soft tissues, I'll come in and do the bone. And we've done a beautiful LD on the foot, and then the patient cannot walk, the bones don't heal, and it's actually a huge waste of resources. They need to have an amputation. So I'll just whiz through. So this is a free fibula flap for maxillary defect, a chronic defect. And we've done a free fibula. The take home from this case for me particularly was planning. The operation, the free flap raising and anastomosis wasn't long, but the inset, because we hadn't planned properly. And the take home for that was, for max-fax cases, we really need to sit down and think. Breast, we have done quite a few breast cases. We follow the American guidelines because we don't have local guidelines, and we do things in a very uniform way for the patients. This patient was referred by our oncoplastic breast surgeon. So she can do LD implants, but occasionally she'll send the patients who don't want to have an implant and cannot have a tram or anything else. So we decided to do a tag flap, and that was the outcome. Then I'm just briefly gonna show the slides about anesthesia. I think this has been said, and I won't belabor the point. We really have to work closely with anesthesia. I've had trouble where patients have not been monitored very well intraoperatively, and you actually can end up losing a flap. Then multidisciplinary collaboration. There's so many factors, but I'm just going to summarize. It increases patient safety. In terms of staff, when you work together, you establish actual relationships, you get your referral patterns, especially when you're starting off. And at times it can feel lonely, but it's actually quite good when you work with other people. So in summaries, develop great working relationships. I can't say that. Attend MDTs, tumor boards, or what you call them in your local hospital. Be present. Let people be able to approach you. And then we obviously have to develop our skills, not just microsurgery, but even in other things. Let you bring the solutions. Let people know us for being able to bring the solutions, because that is the heart of our speciality. Thank you.
Thank you, Esther, for sharing your experience and beautiful results, and doing unconventional flaps choices, which I like. If you were a registrar, I would say it's maximum register benefit. But congratulations, beautiful results, although you don't get help from the orthopods. Our next talk will be by Dr. Odinki on the evaluation of the outcome of free flap at KNH.
Good afternoon. My name is Dr. Ndieki. I'm a registrar at the University of Nairobi. So I'll take us through my research. I've done a preliminary analysis, both on the prospective arm of it. So it's on evaluation of outcomes and factors influencing free tissue transfer at Kenyatta National Hospital here in Kenya. So my supervisors, Professor Nangole, Dr. Wabwire, and Dr. Anjeri. I have a disclosure. I'm a Smile Train scholar, and Share International Foundation funded this research. So the success of free flap basically relies on optimization of an array of factors, from meticulous patient selection to surgical expertise to monitoring. So all those factors come into play in order for you to succeed in free flaps. So our success rates, the success rates in high income volume centers is as high as 95%, and they tend to have up to 10% revision of flaps. Complete flap failure is less than 3%, again in high income countries, and less than 10% in low mid-income countries. So most of these flap failure tend to occur within the first 48 hours. Back home, our success rate is at 87%. This is a study that was done about a decade ago. So in low resource settings, flap salvage rate remain inconsistent. Some of the challenges we face are related to suboptimal infrastructure. We have limited access to advanced monitoring tool and the constrained availability of ICU support. Data on free flap outcomes in our region is notably sparse, especially on surgical variables. So the last audit that was done on free flap was about 10 years ago. And since then, KNH as an institution has made significant advancements. We've refined our surgical technique. We've improved on our peri-operative care, resource availability. There's more monitoring being done. The number of plastic surgeons also are higher compared to before. So my question is, have these improvements translated into better patient outcomes? So the aim of the study is to determine the current prevalence of flap failure. We want to look at the linked complications, also assess the parameters which are influencing this success. We'd like to also provide an updated to evaluate progress and use the data that we have gotten into furthering research in microsurgery. So the research question, what are the early outcomes of free tissue transfer at KNH Kenya? So early outcome, we are cutting it to 1 month after free flap. The second question, what are the factors that influence this outcome at KNH? And the broad question is to determine early outcome and factors associated with free tissue transfers at KNH. Specific objective, we want to determine the early outcomes of free flaps, to determine complications, and also to determine factors influencing outcomes. So it's both prospective for 1 year and 5-year retrospective. It will be done, the study is in KNH, and all consecutive eligible patients will be considered. So under the prospective arm, we look at 23 patients, the retrospective 74, totaling to 97 participants. So far, the results that we've gotten, so VLNT, we've so far done 7, 6 were successful, and we lost 1. ALT, we did 4, 3 successful, and lost 1. Gracilis, we've done 1, it was successful. Free fibula, we did 3, all successful. Radioform 4, all successful. We did free tibialis anterior, and free DIEP, 3 of them, all successful. So far, out of the 23, 21 were success, and we lost 2, with an overall percentage success of 91%. So that's one of the cases that we did. A case of ameloblastoma, we did mandibulectomy. Again, it was an MDT with MaxFax. So you can look at the picture on the right. There's nice capillary bleed after a needle prick. So the skin island was used to form, to refashion the intraoral mucosa. We also encountered partial loss. These are a young boy who had full thickness anterior chest wall defect. So we did a trilaminar repair using momentum, mesh, and ALT. So we lost part of the ALT, and later we ended up covering using a rotational flap and a skin graft. So we've also, this is one of the losses that we encountered. It was an ALT. We did this in collaboration with the international faculty. It was during one of the camps at KNH, and we were lucky. You can see the picture to the right. We completely lost that flap. During this procedure, we were lucky enough to use technology It's the first time we used the surgical microscope. And for the venous anastomosis, we used the venous scapular, so reducing the overall ischemia time. But even then, despite all that, we ended up losing the flap. The second flap that we lost was a VLNT. That's the picture to the right is a recent picture that I got last week from that patient. So what do we deduce from the preliminary results? That the 91% overall success is an improvement from the previous 87% that we had a decade ago, meaning that we are advancing, though we are not yet, we are approaching the rates at high income countries of 95%. So we are closing in the gap. The radiophium fibular flap of 100% is likely reflects accumulated institutional experience. In the previous audits, 30% of the flaps that we did were radiopharm free flap. So you can imagine all that build up experience and institutional memory. A VLNT, as per our data, now accounts for a third, with a success rate of 85%, begs the question that probably we need to look at the lymphedema disease burden in Kenya. Again, it shows that we are expanding our scope in terms of free flap. Of the 23 cases, 22 were done under loop assisted microscopy. So meaning that it is feasible, and these loops, we can actually do these free flaps in low resource setting. Much as it's good to have technology, technology alone is not guarantee that our flap will survive. So we need also to improve on the other critical areas of flap. Our salvage rate is consistently low from the previous analysis 10 years ago. Even presently, of the 2 flaps that we did, we lost them after 48 hours. And of the 2, we didn't attempt to take the flap back for salvage. So our priority going forward, we need to strengthen our monitoring, escalation, and rapid re-exploration pathway to salvage flaps. My limitation, this study is short. It's a 1-year study. Some of the patients may be our patients. So we'll take a large sample as a delimitation and more participants, 10% more participants. Thank you.
Thank you, Dr. Ari, for sharing that with us. Wonderful results, I must say. More than 90%. Don't worry, maybe this will make you, a doctor who doesn't get complications means doesn't operate, okay? So don't worry. But excellent, meaning using loops, you take me back to the days we started with Professor. We didn't have microscopes, we're using loops. Beautiful results. Right. The last talk of the day is by the only one professor, Professor Ferdinand Nangole, on, it's a master class actually, our Kenya experience with free functional muscle transfer.
Thank you. Thank you, Professor. Again, I think we've all been here for some time and I'm sure we are tired, but I'll try to go experience. So, free functional muscle transfer is an advanced microsurgical procedure that replaces damaged or missing muscle with. It's a useful technique in patients in whom the motor unit has become irreversibly damaged and where there is no adequate local or regional donor tissue that can be sacrificed. In 1970, and he did his studies in canines or dogs, and he transplanted the rectus femoris muscle to the considered standard of care for patients who've got functional
muscle loss, especially over prolonged duration. So the main indications for this Volkmann's ischemic contracture, massive trauma, brachial plexus injury, and then post-oncological resections, and then congenital conditions such as neurological supply to the muscle that would have led to loss of the motor end plate. Contraindications for this, of course, for you to do functional muscle transfer, you must have mobile joints. So contraindications include things where there are stiff recipient joints, where you've got lack of donor nerves, and of course where the soft, there's poor soft tissue bed. And in the event where this is, then you have to reconsider it as well. Therefore, you may have to bring in tissue that can also give you sort of the issue of the soft tissue as well as the muscle, things like chimeric flaps. And then, of course, unstable proximal joints. You need stability for the muscles to move. You need proper stability. And therefore, you need to sort out those issues first before you can do your transfers. And then, of course, we have patient-related factors. This may range from comorbidities and patients who are not fit for prolonged anesthesia, or patients who may have psychosocial issues that will prevent them from going for rehabilitation programs. Those may not be good candidates. So some of the muscles that have been highly reliable for free muscle transfer, pectoralis major used to be, but it has run out of favor. So the most muscles are the latissimus dorsi, the gracilis, the rectus femoris, and then you've got the extensor digitorum brevis and the serratus. What you really want to achieve. Is it a small muscle transfer, or is it a major muscle that you want to have a good functional outcome that will determine for you what to use. Of course, other critical issues that you need to consider is the skin coverage that we've already talked about, and then anatomical locations of the recipient vessels. Preparative evaluations, this may vary from patient to patient, but what you're interested in is you want to be sure that you've got a good motor nerve that you have to use at the recipient site. And then, of course, remember you're bringing in a free flap, and therefore you need good recipient vessels, and therefore in cases where there is trauma where we are not sure of the quality of the recipient vessels, as we've already said, you need to assess the quality of the soft tissue. So we'll go into some of the cases that we've done in our unit. This was the forearm, leading to the loss of all the flexor tendons. In this child, there was both neurovascular as well as and basically was not able to move. So in this particular case, we were able to do a skin island that in this case was also used to provide soft tissue coverage, much as it was also created as an attempt to try grab things, like in this case you can see that it's trying to grab a cup. And see those, we'll share with the band brachial plexus injury. Now this was a patient who had an old band brachial plexus injury, presented to us 3 years after the injury, and he had his hand trapped in a roller and was not able to use. So after evaluation and after discussion with him, we realized that the only way out here again was to do every gracilis muscle transfer. So the muscle is being harvested. In the proximal is the identification of the obturate, the anterior branch of the obturator nerve, and then we have the perforator that is identified, and then again, the gentleman. I don't know whether it will move this one. Sorry, Mekata. Okay, then, but he had a very, very good functional outcome in this particular case. He was able to move. Now, another case was, this was actually our colleague. She had agreed for us to share this picture. So we had a facial nerve palsy. And as a result of that, her biggest concern was symmetry. And again, the reason why she had this was that she had a mastoid tumor much earlier in life, and she had excision of the tumor involving the mastoid. So in this case, we had to do a two-stage procedure with the cross facial nerve graft that you can see. That was the first procedure, and then later on, we came and reconstructed. You can see that she had symmetry at rest. We had her pictures on motion, but we do not have it here. Our final case was of abdominal tumor with the desmoid tumor that we resected, and after that, again, we reconstructed with the vastus lateralis muscle. They came in as a referral. With a huge tumor of the posterior thigh that initial excision had been done in one of the facility. The margins were positive and we had to go in again. The sciatic nerve was involved. We had to reconstruct the nerve, and then finally again bring in the latissimus dorsi muscle. I don't know whether it will move. So in conclusion, free muscle transfer is a very, very good technique. Most of these patients will require multidisciplinary approach, like those cases that are oncological based. You need to discuss with the oncologist what is possible. The ENT related cases, you need to work with the ENT. Like the case we did at Gracilis, we had to get the ENT surgeons to assist us, just expose the facial nerves and work with them. And then, of course, the brachial plexus, you really need good physiotherapists and occupational therapists to work with you. Our biggest problem is late referral of these cases. Now, it's very, very important that you have good patient selection, the characteristics of your patients. Some patients are keen on rehabilitations, others are not. You need very, very good post-operative rehabilitation program, and even so, you really need to have realistic expectations from the patients, especially when you get patients with brachial plexus injury. You really need to tell them that, yes, this is what you are likely to achieve after the reconstruction. Thank you.
Thank you, Prof. So we've come to the end of the microsurgery session. So if there's one message you can take from this session is that microsurgery is not simply about the technical skill. There are so many things really that come into play, including patient selection, planning, teamwork, before you can have good outcomes. So we'll go ahead in a few minutes to take any questions from the audience and have a panel discussion. So Mark, you can ask one question. So on deck, you, in your presentation, you were looking at the factors that influence the outcome. So which study, because that was one of your objectives, strongly dictated or influenced your outcomes for free flap surgery? Then, as Ondeki prepares to answer, as we get other questions, I know to centers that a low resource setting, we understand, for example, in the Kenyan setup currently, the mode of financing of most public patients is SHA and its limitations of 2 surgeries. And most of these patients that you'll do free flaps on are patients who have already been seen by other surgeons and, for example, orthopedics, for example, on how the surgery is financed for those who work in institutions that are SHA dependent. So any other?
Yeah, I think just a question or comments from our colleagues from Uganda. If you could comment, veins do you do in your anastomosis after you've done your free flaps? And secondly, how do you monitor you spread it out? And thirdly, do you always use microscopes, or do you have situations where you use your loops as well?
Thank you, Professor. We use 1 vein, 1 reliable vein. We never use 2. We stopped using 2. It's cumbersome for nothing. If 1 can flow, just how we monitor, it's for the first 48 hours. We do hourly monitoring, and then after that we do 2 hourly. Refuse to use loops. We refuse to suffer. We'll use the microscope. If it's not there, we will not work.
Surgeon dependent, because when you're used to loops, now you feel you're suffering when you're going to the microscope. Especially when you do not have a very good quite well with the loop. So really, at the end of the day, I think it's just surgeon dependent. What do you think you are comfortable with? Again, on the issues of the veins, that you want to go home when you're very comfortable, and it may take an extra 30 minutes or 40 minutes, but wherever possible, I still feel that that is an extra security for you, especially in an environment like here, where for you to take that patient back to us.
Maybe to answer the question regarding what are some of the factors that are influencing the analysis, but that we are getting in what we're able to gather, that areas to do with pre-op preparations of the patient and time. Basically almost going under what we did within 30 minutes.
Maybe one question for Esther and one question for Prof. Esther, from your talk, I would like to know, is there anything that has changed in the pathway from detecting a threatened flap to getting the patient back to theater, and how did you measure that change? And then, Prof, how do you define a successful functional muscle transfer in your practice, and what useful activity can the patient perform as a result?
So in terms of detecting a threatened flap, I think I'll give an example. The transverse upper gracilis flap that I presented, was it on post-op day 1? Unfortunately, the patient had a hematoma from actually the axillary site, but because the pocket is so small for transverse upper gracilis, it actually affected the whole breast, and the flap went blue. So the nurses, we do the hourly check for the first 48 hours as well. We have the same protocol as our colleagues from Uganda. So we do hourly for 48 hours. Then after that, we do 2 hourly. Then we do 4 times a day. So it was detected quite easily because the nurse is doing hourly. They'll see that it has changed. Then there's a protocol. They call the resident, and then the resident informs me. But we normally, I give the nurses, I write my number at the bottom of the post-operative note, and they're free to call me.
So basically you haven't changed your routine and your protocol. It continues as that.
It continues as that
As
for
the
now.
protocol you have.
For now.
Yeah.
Yes.
Okay.
Yes.
Yeah, so when do you say that you've attained success? It's very important, and this is what I was trying to stress, that you need to discuss with your patient and have discuss the expectations. For most of the other reconstruction, especially like the limb or the abdomen, it's not difficult because at the end of the day, you want the patient to flex and be able to say, yes, we've done this, but the ultimate success will require on how aggressive you are with the physio, and at the end of the day, we expect you to have a reasonable, good function of the flexion of the joint. For brachial plexus, you need to define to the patient what exactly you are going to achieve. The patient will expect that if you do a gracilis transfer, he or she will expect that he'll be able to flex the fingers, he'll be able to get hold of all objects. That is not going to happen. So you need to explain that your aim is to have flexion of the elbow, and that is what you are going to achieve. And even with that minimum flexion of the elbow, he or she is likely to support the arm, and there's not going to be a fluid extremity. Therefore, the measure of the success depends on what exactly did you want to achieve. What was your aim for the surgery?
Thank you, Prof.
So maybe one last question. So maybe to Prof. Nangole, to Dr. Andrew and Naomi, and to Dr. Gadura, in your own microsurgical practice, what is this single or one complication that really taught you a big lesson, and did it really revolutionize or change on how you approached free flaps thereafter?
I'm not sure whether I've got an answer to your question, but I think what I'll say is the most important is your preparation. And secondly, for me, I feel that most of the flaps you lose them on the operating table. I was told that you can lose even before you start the operation. Yeah, so I have to push it maybe further. But for me, I feel that the most critical moment for you is during the surgery. And if you're during your surgery and you're not happy with your anastomosis, no matter how tired you are, it's not going to get better. It will worsen. If the flow is not good, don't say it's spasm, it's going to improve. No, just open. And we've done that with the residents here many times. Sometimes the residents will always feel like, oh, why you should be closing this thing and go. I tell them, no, it's not flowing, let's open. And when we open, actually you find there is a clot. And once you remove the clot, you regain perfusion again. So for me, that is one big lesson that I feel is very important. Take an extra 1 hour, go back again, open the anastomosis, look at it, be convinced it is okay, then you close and then you move on.
Yeah, I would say the same, that in my experience early on, you know, when you spent 10 hours doing a free flap, everybody wants to go home. and there's a conspiracy for everybody to say it's fine. No, and even if you start prodding things and go and say, well, I'm not so sure, everybody else is going, no, it's fine, because they're desperate. And I think I've had to learn that it doesn't matter. I know everybody's tired and everybody wants to go home, but if I'm not 100% happy, we have to carry on and we have to relook. And if we then are 100% happy when the patient goes off the table, it almost always works.
Thank you, Dr. Kiriga. For me, I'm definitely on my learning curve. So I'm still learning quite a lot. So it's very difficult for me to say the one thing, because every free flap I'm learning. However, how to manage failure from free flaps, especially when you start. So your first failure feels like a heavy load, an extremely heavy load. I think in my institution, because patients pay for their surgeries or insurances pay, and then you've done one surgery, it costs so much, a patient only has that one chance. So you almost take it personally. And I remember one lady who we started off with, because it was a lower limb. I think we tried gracilis first just to avoid the bulk. It contours really nicely and it didn't work. And I remember going off and trying a local flap, which obviously failed after, because the reason why I'd chosen a free flap is because I didn't have faith in the local flap. And eventually we did an ALT and it worked. But just getting yourself to do the second one after a failure, you really have to draw into yourself and not give up and not take the failures personally as you're starting. I think for me that's the one lesson that I think is very important.
Okay, thank you for those good responses. I hope we've learned a lot. So we can give our presenters some round of applause. So I'll ask Professor Segwapa to present certificates of presentation to our presenters.
Okay, and also for Baseta.
That's very important.
Yeah.
Most important.
Dr. Hodges. Professor in Angola. I'm sure I don't know how many you have now. Okay, Dr. Ndeki. Thank you.
Okay, thank you. As they go down the podium, before our sponsors come, I think we have one of
our sponsors is supposed to speak to us before we break for tea. There is a presentation we missed yesterday that we need to have. So Dr. Gasheri, you can be coming to the podium. So Dr. Gasheri had a presentation yesterday that we missed in the afternoon. So she requested that we give her 5 to 10 minutes to just tell us about her work. So she's presenting on amniotic membrane processing and use in rural Kenya. So in less than 10 minutes, you can put the presentation up. Welcome, Dr. Gasheri.
Thank you for the second chance. So this is a project that we are undertaking at Meru Teaching and Referral Hospital. And being a resource poor area, I know yesterday you heard something about amniotic membrane, and I know you know about a dried amniotic membrane. So this is this fresh, cryopreserved amniotic membrane, something you can use in low resource settings. This is the history we all know. There was the history in 1910s and 40s, and then because of some challenges went down, researched again, and then in 2003-04 there was FDA approval of cryopreserved amniotic membrane, and it's in use up to now. These are a list of just the properties that an amniotic membrane has, and these are the properties that are actually the reasons that we are using amniotic membrane now. We know there's the mechanical function as a scaffold, and the fact that when it's cryopreserved, it loses most of the antigens, and so rejection is low. And this is something that is very available and affordable. And I just wanted to give you an idea of what we do at Meru Teaching and Referral Hospital. First, these are the cleared indications at our hospital for wounds, pain control in burns, surgical wounds, bleeding wounds, and preparation of graft beds. So this is what we do. We just go talk to our pregnant ladies that are due for elective CS section, and they give us a written consent that they are free and they are comfortable for us to use their placenta to harvest the amnion. And then when we get this, immediately after the CS, it's put in the fridge, and then we practically peel off the amnion from the chorion, and this is how we treat with a mixture of antibiotics and antifungals. We process in a laminar flow, and we use sterile container. We use glycerol, and we still go ahead and freeze. So when we put in the glycerol, the same bottles, we take a piece of the amnion and we take it for culture. Oh, and before collecting, of course, we screen the mothers before. So this is exactly what we do. So that is us at work, and then we process in these fluids mixed normosaline with a mixture of antibiotics and antifungals, and of course you can see where the separation happens between the chorion and the amnion. This is us processing in a laminar flow. This is the storage, and that's the degrees and the glycerol that we use, and it can go up to 8 months. So these are other ways we are trying to preserve the same. So this is like, I can call it a pilot study. It's more like trials, and then hopefully with some support we can come up with the best method, and we are able also to test what our final product has in terms of even biological properties, what we are able to retain. So usually do a very good debridement. This is exactly what we do, and then we make sure we've irrigated enough to remove all possible particles from that wound bed, and then we just place the amnion and we make sure there are no bubbles or there is complete contact placing. And then we go ahead and dress, and of course if there's some edema, you do some compression. And with me, we have a specialist nurse who is actually doing the actual work of dressing the wounds, and I want to give him a chance.
Hi everyone, my name is John. We work hand in hand with Dr. Gasheri. And now, these are the cases we do manage. This was a This is a patient who presented with burns. We managed it well, successfully up to the healing, which took us around 7 weeks to get to the final result, as you can see on your far left. Then we had another case of a burn. This patient presented with much pain and bleeding. We applied the amniotic membrane, and we were able to achieve control of pain and bleeding up to the healing. Again, it's also of importance in the venous ulcers. It controlled the pain associated with the venous ulcers, of course, with compression also, and the healing took lesser time. Then we had another case of a child. This was a case which we were preparing for the graft. So you can see it had some hypergranulation and infection. Initially, after we applied membrane, it granulated well, and the child was due for grafting. Then we had another case of necrotizing fasciitis. The patient had a lot of pain and bleeding, and they were able to be controlled well after we used the amniotic membrane. This was a case whereby the child presented with pruritus, and after 2 dressings, the wound closed well, and there was no pruritus reported anymore. Thank you.
Thank you, John. I think there's a slide that is missing where we are able to control bleeding. There's a slide here, but that was a coincidental finding for us. We're actually managing the pain, and that wound practically, I don't know what is happening, I'm not even touching. Okay, sorry, I have no clue what's happening. Okay, fine. So our hopes when it comes to amniotic membrane is that we are able also to process the chorion, and then we know, of course, also the amniotic fluid has so many properties, and our hope is that we at some point will be able to harvest the fluid as well, and we'll be able to exploit the properties that come with that, not only for wound care, but also in terms of aesthetic medicine. And we know, and actually some of the trials we are doing right now, only that I can't get the slides, is that we want to use these amniotic membranes on keloids, especially post-keloid, because from the literature it can control hypertrophic scars very well. And our hope is that every kid that actually comes also with burns in the hospital, after we make sure they all get amniotic membrane, and then we study the probability of them getting hypertrophic scars. So these are the trials I wanted to mention, especially the keloid surgery, RAPS on severe eczema, and this is because we found out that it's controlling itch, especially even the burn itch and other blistering conditions. And the hope also is that we'll be able to use it in stable vitiligo because of we are able to culture it in melanocyte culture. And the biggest thing that was surprising to us is that actually mothers were so willing to offer this amniotic membrane. It's something that I thought culture would be an issue. And we hope to get more training and support for further exploit, because this is a place that is not really exploited enough. Thank you.
Thank you, Dr. Gashiri. That was eye-opening. Remember, this used to be done by Dr. Kahoro. Maybe that would be a good way to continue Dr. Kahoro's legacy. So we'll call in H. This H is one of our sponsors. So they have a brief presentation before we take a break now.
Good afternoon. I'm very privileged to stand before the great work, the miracle, the doctors. I'm impressed. I'm scared to see all these photos. But it gives me one reason that we are in the right place. You might be asking yourself, what is a natural supplement company doing within the medical forum? Well, I've seen the gap, and I'm going to explain later. My name is Christine Yabayo. I work at HESH as a manager, research and development, and also product development at large. So, I don't know. The presentation, maybe? No. So let me introduce HESH. HESH is a German-based company focusing and pioneering in beauty nutrition supplements. They started with collagen as one of the main ingredients in beauty nutrition. But then after so many okay, now I can go through the presentation. So I'll start by giving you a reason why HESH has a philosophy in what they do. I give you an example. For example, there's a mythic theology where a lady, goddess for the dawn, fell in love with a young mortal and asked the gods, Zeus, to give this man eternal life. But she forgot to say he should also get eternal youthful. So this guy lived long, but his body deteriorated, and he was just a living soul in a cicada type of a body. So this reminds us that healthy lifespan is nothing without health span, and that is where HESH comes in. HESH focuses on nutritional supplements, targeted nutrition supplements, to make sure that the body has all the building blocks that need to cover the morbidity gap, and also to help to make all the life lived worthwhile. There's also another very important and very clinical relatable paradox. I really didn't know this until recently, that when you have white hair coming emerging from your follicles, it means that your stem cells sacrificed their capability to produce melanin, and in that case they changed they stopped producing melanin and mutated into something else that will stop cancer in your body. And if I see I have white hair, I thank the cells for sacrificing themselves to help me. So this is the same way when you do your surgical operation, you create, I don't want to say damage, but there's trauma in these tissues, and the body knows this, and it will sacrifice the aesthetic of the hair formation, skin integrity, and focus the energy towards heart, brain, and lungs to survive. So aesthetic is sacrificed in this case. So HESH will come in and pay this luxury tax upfront, so that the body doesn't need to gather all the nutrients from your body just for it to help repair the wound and stuff and all. So HESH was founded in the 1990s. It started by the family of HESH. The family was focusing mostly on herbal therapies and also pioneering in phytotherapy, and under the guidance of what's the name, Gustave Heydrich. And later in the 1990s, they developed sport nutrition. They worked closely with different experts in gyms, like gym instructors, nutritionists and stuff, and it became very massive, and it was known all over. Then his son, Ralph Heydrich, took over since the 2000s. He had gathered enough experience from working around the world, especially in the Asian country like China, and there he came back to Germany with the knowledge that collagen can be the primary beauty component for any skin care routine. So that's where we started with Beauty Nutrition, Beauty from Within, where we have made products that are catering for longevity and have helped us to pioneer in longevity as a supplement company. Further, now the newest and the most high-graded category has been born, and it's called medical beauty supplements. And this is the reason why we are here today, to make sure that we see that the two of this discipline merge together. So in order to find our place in this forum, in the medical forum, we have to define the problem. The problem I see, the problem we saw, the problem we've learned from visiting multiple forums like this in Dubai. Like, you know, those guys do a lot of plastic surgery, they do injection fillers and all, and they mentioned always one problem, tissue integrity. And I realized, even after sitting there and listening to all the talks, none of you mentioned anything to do with nutrition that might help with wound recovery or tissue integrity, which is really, really important in this case. And I believe when you do your cuttings and sewings and all, you create a demand for metabolic repair, because the tissues are now under stress. And I've not seen yet any company that has nutritional supplements that are indeed made for this type of problems. So there's scarcity everywhere, even in Europe. So here HESH brings in the problem solving capability. By bringing all the building blocks the body needs during the peri-procedural procedures that you do it very well. We are not going to replace anything. You are already doing a great job. You lay down the foundation, the fingerprint for the success and the patient outcome. But the patient follow-up is not well monitored, because you don't know what the patient eats. And this is where we step in. We give you the tools to recommend to these patients to make sure that the outcome is as expected and with integrity, to create more trust. So our long-term strategy is also to extend patient-doctor, to strengthen patient-doctor relationships, to enhance output is perfect, to create compliance, to make sure the patient is always has faith in the procedure and all, and to grow out, to practice trust and growth all over. So with all this, we make sure that the products that we bring to the table are quite of high quality, and this includes several aspects that we take care of. I will not mention them all because of time, but with this quality and the reviews we've got so far from all over the world, we are really everywhere right now, and we are merging into many different markets that are not already shown, but we are globally present. So shortly, I'll introduce to you the three-tier supplement that we have. We start with the Beauty Nutrition. Since 2025, we've put foot in Kenya, working with Linton's as the distributor for our basic supplement portfolio, consisting of collagen as the main factor. Then we developed, we advanced to longevity supplements, because everywhere you hear longevity. Even yesterday I saw longevity toothpaste, and everyone is earning for longevity. So we've worked with different pharmacies in across Europe, Asia, and now in Middle East, because those guys love a lot to look beautiful, and that's what we do. So with the medical supplements, like I said, our target demographic includes microsurgeons and aesthetics, like most of you here, dermatologists and nutritionists, medical and wellness spas. So longevity as a big topic, I don't want to go into details, but that's where our medical beauty supplements cater. They take care of different aspects: mitochondrial diffusion, you have protein degradation, you have cellular synthesis and all. With this, we build a pillar to formulate, whereby we make sure that the products we create have been sourced ethically. The bioavailability is also catered for, because what's the need of having an expensive urine when you can also just eat a mango and expect to have all the ingredients. So you make sure anything you take has your heart has some physiological benefits in your system. So the next. So these are the 3 products. Maybe some of you have come to our booth and seen some. I can go through quickly. The H Tissue G is mainly for the weight management. It's supposed to complement your procedures, making sure that during the patient's recovery journey or routine, there's no sugar spike, the muscle are maintained, there's no sugar face like the sagging of the face, because apparently people tend to use these remedies like Monjarno or what's the other one, and they tend to lose muscle mass very fast, and connective tissue degradation happens. Then you have recovery. This is very good for wound healing, and what I've seen today, the patients that have been going, having flaps failing and dying and stuff like that, if they took recover they have the building blocks which will always prepare the body for any stress or peripheral tissue degradation. Our mission is now to bridge the gap of microsurgery, build connections within in this forum, make sure that one thing I forgot to mention, the medical nutrition supplements are not for the general public. They are very exclusive, and they are only for made for experts. So we give you the mandate, digest the information, translate it to the patient so that the outcomes are as expected. And in HESH, we have a group of team, in-house scientists from biologists, food chemists, pharmacists. I'm a chemist myself. I wanted to be a doctor, but that didn't happen. So I decided to follow with nutrition, and I don't think I'm on the wrong track, because we all have the same goal: tissue, connective tissue integrity, patient outcome, even though we are not recommending for patients. So thank you for listening, and I want to acknowledge 2 of my colleagues, and they've worked hard to make sure that I can stand here today and pitch HESH, and I hope to see you all in our booth again. Thank you.
So thank you, HESH. It's HESH. Okay. Yeah, when I heard about white hair. Okay, interesting talk. Maybe next year you need to come with a proper scientific presentation so that we have more time to listen to your talk. So we didn't have this program, but I think because Dr. Gasheri presented on her talk, I'll just ask Professor Nthumba to come and present her with the certificate of presentation. And then after that, thank you, HESH. I think if we have any questions with regards to your supplements, there's one surgeon who used to work with Mission Plasticos. I just forgot his name. He was really interested in longevity. He would have been very attentive for this talk. I remember he used not to eat the whole day, every Monday of his life for longevity. Okay, do you have any question for Gasheri now that, or yes?
Thank you for the presentation. How often do you change the amniotic membrane dressing?
Dr. Kasheri, I have got another question also for you. You showed very good pictures. Some of them had very good granulation tissue, which I thought maybe you could even have grafted. So I'm just wondering whether you work with the plastic surgeon in some of those cases, or it's just you just work alone or something. Because some of them I thought they were even ready for grafting, and maybe that could even have shortened the healing duration.
Thank you, Prof, for that. Yes, we work with Dr. Ongas, who is, I'm actually disappointed he's not here, because he should have assisted here, because is he? No. So we actually get to that stage, and then we hand over to him. We are a team of 4, actually, as Ongas and cardiovascular surgeon, when it comes to vascular lesions. How many? Mostly 3 days, after 3 days. Unless the wound is very oozing, but sometimes you can actually put the spongy dressings on top of that. Thank you. And actually it's Dr. I keep getting the name wrong, Kaho? No. Yes, Kahoro, who encouraged me to take up this, because I know you guys, I think, tried something like this in KNH. So we're in conjunction with the ophthalmologist in our hospital, and when we wanted to go their own way, I got in touch with her, and she actually also gave me some guidance on the same.
All right. My name is Dr. Lee, right here. Yes. I have a question about the amniotic membrane. Is there any compatibility matching that needs to be done before the membrane is applied to the wound?
Not really. Remember, mother and child are 2 different human beings. So scientifically, not really. And also when we cryopreserve, you actually lose most of the antigenicity. Not as much as the dried one, the one maybe that is somewhere, we usually import, but most of it, not really. And we are using this in the eye. That's also what I wanted to mention. And we've not had, actually he has done so many cases, and we've not had any issues at all. And what I also wanted to say is that we are not able to test the end product to actually say these are the growth factors, these are the cytokines, we are yet to get there, and hopefully some support will get there.
Thank you so much, Dr. Gasheri, for your presentation. Knowing the community that you practice in, I know most men will not agree to this. Have you faced those challenges?
Yes, actually, yes. So I told you I was shocked that most women are willing, and what we do sometimes we go back with these pictures to show them, but we've had cases where women say they have to ask their husbands, and for us, ikifika hapo, we just move on, but we've had such cases. But unlike Western areas, we are actually shocked. Mount Kenya region is so willing to offer, and they influence each other actually. One agrees, and then they talk, and they all sign, like asitatupwa tu, like, you know. So we are actually, I was really shocked, because I thought we were not going to pass that barrier, but surprisingly, I think we've moved on really well.
Thank you for the good presentation. How cost effective is it? How much does it cost per change of dressing?
It's extremely cheap, if I can say that. We should have done that. But if you realize, most of the combinations of the antibiotics that we use are actually quite cheap, and then the rest is just normal saline. So if you're able to get like 2 to 3 placentas, because elective day is usually 1, we process in the same fluid. So if you're processing 1 placenta at a time, it actually becomes a bit cumbersome. So it's more of human presence than actual cost. So the actual doing the job, by the it's a bit limiting, and most nurses, like him, we actually really him, like he volunteers his extra time to help us do that processing. So the actual work, the peeling, the rinsing, you rinse from the bloody thing to that white thing, you rinse like 10 times in that concoction. So it's quite engaging manually, but the moment maybe you get support for someone to be paid to do that, that will be quite good. But price,
just those antibiotics and that's it. Actually, we are not charging anything extra to the patient, just the same dressing costs at the hospital and that's it.
So thank you. I think we can end it there. So Professor Nthumba, I'll request you to hand over this certificate to Dr. Kasheri. And Tim. So thank you so much. So we've come to the end of the evening. For HESH, I think people will come at the tent. I think that's the most appropriate place. Yes. So at this point, we have a special event that is slated for the evening. So I'll ask for our scientific committee chair, Dr. Mukami, who is also responsible for that specific event, to come and give us the details of where, what time, and is there any specific thing you're supposed to carry or put on before you come for that special event? Welcome, Dr. Mukami.
Thank you, Kiriga. Thank you, everyone, for your patience and for being here on for the second day. So we're inviting you for our gala dinner, our annual gala dinner. It's going to be by the beach. You'll see a couple of tents there. So the dress code is African elegance. However, I don't want you not to come because you're not dressed that way. So please feel free to come as you are dressed. It doesn't mean that we'll chase you out. We will not filter you and chase you out. So be comfortable. If you can, it will be great. But if you can't, also, we shall accommodate you. So come, let's have great conversation, let's have good food, and let's dance. That's all. We start at 7:30. Try keep time if we can. So go rest, shower if you want to, then let's meet at 7:30. Thank you. By the beach? Yes. Karibuni. Please also remember to pick your CPD points for yesterday, today, and tomorrow, hopefully, so that we are ahead of that. Thank you, and see you in the evening.
It was good.